Good morning. Ladies and gentlemen, welcome to the 6th meeting of the Interim Committee on Health and Human Services for the 25-26 interim. It's great to see so many happy and excited people here this morning for our meeting focused on child welfare issues in the state of Nevada. Let's start with roll call. Secretary, would you start with roll, please?
Senator Danyate, Senator Lang, Senator Titus,
I'm here.
Assemblymember Edgeworth, Assemblymember Goulding,
I'm here.
Assemblymember Hibbets,
Here.
Assemblymember Nadeem, Chair Brown-May.
Here, thank you. Please mark the members who are not here present when they arrive, or absent if at the end of the meeting they are not here, although I don't believe that to be the case. I would like to remind you all to please silence your electronic devices, especially your cell phones and laptops during the meeting. Agenda items, we have a very full agenda today. They may be taken out of order, and 2 or more agenda items may be combined for consideration. The committee's meeting materials can all be found on the legislative website. You can sign up for electronic notifications related to any activity. When testifying in person, turn on your microphone to speak and off to listen. We have people who are listening in multiple locations and online. And with that, we will officially move into public comment. Public comment will be limited to 2 minutes per speaker. Staff will time each speaker during public comment to ensure everyone has a fair opportunity to speak. In addition to testifying in person, members of the public may also provide public comment in various other ways, all of which are listed on today's agenda. If you would like to call in to provide telephonic testimony, please dial 888-475-4499, and then when prompted, provide the meeting ID. Enter number 857-1071-3988, and then press the pound sign. We will start with public comment in our physical locations right here in Las Vegas. If you would like to provide public comment this morning, please come forward and fill in the chairs. And we will start here in Las Vegas.
Good morning, Chair and members of the committee. My name is Leah Dodds, Leahdods, and I'm the Deputy Director of Foster Kinship, Nevada's statewide kinship navigator organization, supporting the 30,000 children who are being raised by a relative or fictive kin when their parents are unable to. I'm here to ask for your consideration of our recommendation related to Agenda Item 4F. The recommendation we submitted via email would require Nevada to identify, document, and track Child Protective Services facilitated parent-child separations, including situations where CPS involvement results in children living with relatives outside of the formal foster care system. When CPS determines a child cannot safely remain with their parents, there are different paths that can follow. Some children enter the formal foster care system, which services and resources follow. Others children are separated from their parents by CPS but are placed with relatives outside of the foster care system. This is often referred to as hidden foster care. Staying with families outside the system may be the right outcome, but it should not mean that a child becomes invisible in our data. These children have still experienced separation, trauma, and family crisis. Yet when families are diverted out of the system, we don't have a consistent data collection mechanisms to know where children are living or whether families were connected to support. This recommendation does not ask that Nevada bring more children into foster care or track families that have not come to the attention of CPS. These children have already come to the attention, and we're just simply asking that child welfare agencies document what has occurred in a way that is consistently measurable, connect kinship families to support, and report the data so policymakers can make informed decisions. Children should not lose visibility, support, or accountability because a relative has stepped forward. Foster kinship is here as a resource to the committee, and I thank you for your time.
Chair Brown May, members of the committee. For the record, Dwayne Young, Vice President of Government Affairs for Silver Summit Health Plan. However, today I'm testifying in my capacity as President of the Nevada Health Association of Health Plans, representing 12 statewide health plans, including the 5 managed care organizations that contract with the Nevada Health Authority to serve Nevada Medicaid members. Thank you for the opportunity to comment on children's access to behavioral health services in Nevada. We appreciate the Children's Advocacy Alliance for bringing attention to the challenges providers and families experience when navigating our healthcare system. We share the same goal, ensuring Nevada's children receive timely access to high-quality care. Provider experiences are important to deserve careful review, and we support continued collaboration among providers, Medicaid, managed care organizations, and state agencies to improve the provider experience wherever possible. At the same time, we respectfully encourage the committee to consider the full provider participation process before drawing conclusions about provider access or managed care contracting. Provider participating in not a single process, it includes Nevada Medicaid enrollment, centralized credentialing through Verisys, managed care contracting, provider onboarding, and claims administration. While these steps are related, they serve different purposes and are administered by different entities. For example, the Nevada Health Authority took significant steps to reducing administrative burden by implementing a centralized credentialing system through Verisys, a change providers had long requested. Instead of completing credentialing separately with each managed care organization, providers now complete one centralized credentialing process. While contracting with individual health plans remains a separate process, centralized credentialing represents meaningful progress that should be recognized as part of Nevada's ongoing access to improvements. As with new statewide implementation takes time, we remain committed to collaborating with the Nevada Health Authority and providers to ensure its functions as intended. We also believe it is important to distinguish between the types of documents presented to the committee online as exhibits. Some of the providers' letters involve Medicaid enrollment requires, while others still involve managed care contracting decisions. There are letters that even reflect claim denials. These are not the same process and should be evaluated as though they have the same root cause. Similarly, references to business decisions, closed panels, or no current network use are not determinations about provider quality. They reflect routine network management based on contractual network adequacy standards, geographic distribution, specialty-specific capacity, member access, and overall network sustainability. Health plans have 2 core responsibilities: ensuring members have timely access to care while maintaining high-quality credentialed provider networks that are sustainable, appropriately distributable, and responsible steward of state and federal resources. A statewide workforce shortage does not necessarily mean every specialty or geographic area lacks specific provider participation. Network adequacy is used evaluating standards that consider member access, specialty-specific capacity, and geographic distribution, not statewide provider supply alone. To meet these responsibilities, managed care organizations must retain the ability to effectively manage their provider networks. Contracting decisions are based on network adequacy requirements, again, geographic and specialty needs. The member access documentation, duplication of practice locations, or other factors requiring additional review. These routine network management decisions help preserve program integrity, maintain adequate provider networks, and ensure responsibility and stewardship of public funds. We agree with the CAA and other stakeholders presenting, and I'm wrapping up just certainly. We want to respectfully work with the committee, reduce administrative burdens, and collaboratively work together with the Nevada Health Authority on an ongoing future. And we are happy to answer any questions the committee might have today.
Thank you for your comments. Thank you. Go ahead.
Hi, good morning, Chair and members of the committee. Thank you for the opportunity to speak today. My name is Dr. Amanda Habas-Delay, and I'm the Executive Director for the Nevada Institute for Children's Research and Policy, which is also home to Prevent Child Abuse Nevada. Today, when we talk about preventing child abuse and neglect, we often think about child welfare services, but prevention begins long before a family ever comes into contact with that system. It begins by ensuring families have the resources and supports that they need to thrive. Research consistently shows that child abuse prevention is closely tied to the social and economic conditions in which families live. Access to affordable quality childcare allows parents to work, pursue education, and also provide stability for their children. Safe and affordable housing reduces the stress and instability that can place families at greater risk. Economic supports help families meet basic needs and reduce financial hardship. Parent resource centers, home visiting, parent education, and other community-based services strengthen protective factors by helping families build resilience, increase social connections, and access support before challenges become a crisis. These are not separate issues. They are all interconnected investments that strengthen families and reduce the likelihood that children will experience abuse or neglect. When we invest in one area while neglecting another, we miss opportunities to create lasting change. Nevada continues to face significant challenges with housing affordability, access to affordable quality childcare, and financial pressures on working families. And these challenges are interconnected and they increase family stress when they are left unaddressed. This is why Nevada has an opportunity to continue building a coordinated prevention system, one that recognizes that child safety is not the responsibility of a single system or a single agency, but shared across early childhood, education, healthcare, behavioral health, housing, workforce development, and community organizations. Families don't experience their challenges in silos, and our policies should not operate in silos either. So if we truly want to prevent child abuse and neglect, we must invest not only in responding to crises, but making sure we build conditions that support families and help them succeed from the start. Prevention is not a single program, it's a coordinated system of support that gives every child in Nevada the opportunity to grow up safe, healthy, and thriving. Thank you for your time and commitment to Nevada's families.
Thank you. Is there anyone else here in Las Vegas who would like to offer public comment at this time? Seeing no one coming forward, is there anyone in Carson City who would like to offer public comment? I see no one at the table. AVH, let's go to the telephone line. Is there anyone on the telephone who would like to offer public comment?
Thank you, Chair. If you would like to provide public comment today, please press *9 now to take your place in the queue. Again, if you would like to provide public comment, please press *9 now. Caller with the last 3 digits of 637, you are unmuted. Please continue.
Yes, hello. Thank you, Madam Chair and members of the committee. My name is Michelle Ondey, O-N-D-E-Y, and I would like to ask the committee to reconsider, please, the mandatory step therapy protocol in the treatment of retinal disease. As part of the protocol, I am required to take Avastin, Pavblu, and BioViz, but I have already had an adverse reaction to Avastin. My 20/20 vision has been reduced to 20/60. For the past 10 years, I have been taking Lucentis 4 times a year that has shown positive outcomes. Despite this and the injuries caused by Avastin, nevertheless, my health insurance company now refuses to pay for Lucentis and require me to try these other 2 medications. I think it unreasonable for a health insurance company to require me to take such a risk when it comes to my eyesight that has already been injured by virtue of this step therapy protocol. I would like to thank Madam Chair and the members of the committee for giving me the opportunity to express my experience with you. Thank you.
Good morning, Chair and members of this committee. My name is Catherine Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. I wanted to briefly thank the committee for taking up these issues today. From the DD Council's side and our perspective, access to timely and community-based services remains one of the most consistent concerns that we hear from self-advocates, families, and providers across Nevada. And families often tell us that they have insurance, but they still struggle to access medically necessary therapies and support. And that gap between having coverage and having meaningful access is one of the greatest challenges facing individuals with intellectual and developmental disabilities. I'm looking forward to hearing today's presentation and learning more about the barriers providers are experiencing, and I appreciate the committee's willingness to examine these issues. We hope that today's discussion helps identify opportunities to strengthen access to care for Nevadans that we all serve. Thank you for your time and your commitment to Nevadans.
Caller with the last 3 digits of 256, you are unmuted. Please continue.
Hi, my name is Kendra. I'm a community member and parent. I'm calling today just to express my concern regarding the lack of care options available to children with severe mental health concerns. I'm a former foster parent and an adoptive parent, and we have a child with a very severe mental health condition. And the fact of the matter is that Nevada lacks the ability to provide that. Even in what facilities we do have and what providers that are available, there is not a good long-term option for a child with long-term treatment-resistant diagnosis. My child, unfortunately, has been to RTCs. We have accessed every single community resource available. We have gone to therapy. We have tried reading. We have tried every single thing that has been suggested to us, and none of them have helped. And so now we are in a position where if my child gets discharged from the current RTC that they are in, we will be faced with the decision as to whether we ought to bring them back into our home and experience violence again, thus placing my other children in a place where they are exposed to being abused, or we are potentially then faced with the choice of what to do. We have been told by service providers that when she is discharged, we could just leave her, but then we would incur a charge against our family. We cannot do that. Families should not be placed with a choice of whether they have to put their lives and their safety at risk, or whether they should have to potentially face child abuse and neglect charges. That is no choice. But that is the reality of what's happening in Nevada. We are not alone. We know other former foster parents or current foster parents faced with this exact decision. We know people whose children were never in the foster care system who have been faced with this decision. And really, it's not a decision. So I'm asking that you guys begin to put this on your radar and begin to come up with long-term solutions for this that aren't just Band-Aids, but are actual solutions for these children's care. Thank you.
Good evening, Madam Chair, members of the committee, Stephen Cohen for the record. I want to thank the legislature for its consideration of artificial intelligence in behavioral health care last session, and respectfully request that specialty care be considered this upcoming session. For the past 3 months, I've been trying to get care established and continued with a particular neurology firm. And when they have AI answering the phones to misroute messages, multiple messages to my provider, that delays care. Further, I would ask that the committee consider having main insurance companies requiring that their third-party administrator companies, primary care groups that they contract with, have the same networks that the main insurance company has. To this end, I'm faced with a position at the moment of where the main insurance company has a network of neuroradiologists, but the third-party administrator has none, and thus trying to evaluate an aneurysm or not. I am waiting on the third-party administrator to find a solution. Thank you, Madam Chair.
Thank you. If you recently just joined us and would like to provide public comment, please press *9 now to take your place in the queue. Chair, you have no more callers wishing to provide public comment at this time.
Thank you, AVH. That will conclude our public comment agenda item 2 and move us into agenda item 3, which is approval of the minutes. So members, that is our first official meeting, February 17th. You have the meeting minutes in your binders. I will entertain a motion. Are there any questions regarding the minutes first? Okay, seeing no questions, I will entertain a motion to approve the minutes of the committee meeting on February 17th.
So moved.
Thank you. Motion by Assemblymember Hibbets. Do I have a second? Second by Assemblymember Nadim. Are there any comments or discussion on the motion? Seeing none, all those in favor say aye.
Aye.
Any opposed, nay? And the motion carries. Thank you. That moves us to agenda item number 4, updates and recommendations from the task forces that are studying issues related to child welfare. We will start with an overview of the child welfare services in Nevada and the youth population with co-occurring behavioral health and neurodevelopmental diagnosis. Ms. Betsy Crumrine is the Deputy Administrator of the Division of Child and Family Services. She'll be doing our first presentation up in Carson City. And down south, we have Kimberly Abbott, who is our Administrator for the Division of Child and Family Services, who will be doing our second presentation on this agenda item. And so I would like to offer a few comments as we begin this. Over the course of this last interim period, after we adjourned the last regular legislative session, there have been 6 task force groups that have been meeting regularly, consisting of members of our community who are interested in serving children and addressing the needs of children in the child welfare system and families that are potentially affected by the child welfare system. So first, I want to congratulate all of you who have served on a task force, who continue to show up for children in Nevada. And we're excited to be here today to learn what your recommendations are so that we can continue to work on the solving the many issues that were identified in our very first meeting. And so with that, I will defer to Ms. Betsy Crumrine, our Deputy Administrator, to begin your presentation whenever you're ready.
Thank you. Can you hear me? Is this working? Yeah? Okay.
Yes,
I am
thank
Betsy Crumrine. I serve as the Deputy Administrator for DCFS. That is BETSEYCRUMRINE. Good morning, Madam Chair and members of the committee. My presentation is designed to just be an overview of child welfare services in Nevada. Do you guys have the PowerPoint by any chance?
I can put it on here. I don't know if that works.
I don't have it with me. I only have it.
I think we have Kim. Ms. Administrator Abbott is putting it up here in the south.
No, that's fine.
I have it on the screen on the computer, but how do I get it? Oh, okay, perfect.
Kim, are you
We
gonna?
can see it here.
There we go. Okay. So the agenda for this presentation is we will cover an operations summary and the administrative structure of child welfare in Nevada. We'll talk a little bit about the DCFS agency, which serves the 15 rural counties. I'll give you a brief overview of the life of a child welfare case, and then we'll look at some data on removals, placement types, relative licensing update, some data on adoptions and kin gap guardianships. I'll address the extended foster care program briefly, the CFSR, which is the Child and Family Services Review, Child Link, and then we'll have an opportunity for questions if anyone has them. So in Nevada, the Division of Child and Family Services is responsible for the 15 rural counties. We provide child welfare services in counties with populations of less than 100,000 people. DCFS is also responsible for statewide oversight of child welfare services for the 2 urban counties. The services that each agency provides, I mean, this is a sort of a small list, right? I could have probably made a list if I were going to list everything that was 4 times this size. But this is an overview. So it's Child Protective Services, right? That's the assessment when we get a report of abuse or neglect. There's an eligibility determination for federal programs that comes after that. Foster care licensing and foster care placements. Intensive Family Services, which is a clinical program for DCFS that serves the 15 rural counties. Maintaining the Child Abuse and Neglect Registry, the Interstate Compact for the Placement of Children, Permanency Reunification Adoption, kin gap, and services to foster youth transitioning to adulthood. Nevada is one of 2 states with a hybrid child welfare administrative structure. In Nevada, the 2 largest urban counties are state administered and county operated. The 15 rural counties are state administered and state operated. The funding of child welfare is bifurcated throughout the state. The DCFS rural region funding is caseload driven and follows all other state agencies in its budgeting process, which includes a CPS assessment paid for by each rural county. Washoe and Clark are allocated an annual capped block grant amount each year with the opportunity to receive an annual incentive payment in response to improved performance. The incentive amounts are listed below. $1,750,000 for Clark and $750,000 for Washoe. The next slide is different, Kim, than what I have in my PowerPoint. I have the map of the DCFS offices, the state map.
And apologies, Madam Chair. I think we have a more updated version on the screen than the one Ms. Crumrine has in front of her. So it's okay, Betsy, just give an overview and we can move forward.
I will, and I will get to that slide though in just a second. So in the packet, I'm assuming you all have the PowerPoint, perhaps you don't, but it's a map which shows you Washoe and Clark's jurisdiction and then the 15 rural counties. So there are 8 DCFS offices spread out across those 15 rural counties. We have offices in Elko, Ely, Fallon, Fernley, Yerington, Nye County, Carson City, Pahrump, and I think that I covered it. So, overview of a child welfare case. The first thing that happens is screening and assessment. So, a call comes into the child abuse hotline where an alleged child maltreatment allegation is made. The decision is then made based on the information presented, whether there is a viable allegation of abuse or neglect, and whether that allegation should be screened in or screened out. If it's assigned for assessment, a priority response time determines how quickly a worker needs to go out and make contact with the victim and interview all other children in the home. So this can be a priority response 1, 2, or 3, which is like 6 hours, 24 hours, or 72 hours. So it's pretty quick. What follows that is an assessment of present danger. That is immediate danger to a child that a worker is interviewing. After the assessment of immediate danger, the worker has 30 days to complete a more holistic assessment of the entire family, the caregivers, the children, how people are functioning or what they're struggling with. And then a decision is made at the end of that assessment about whether or not there is evidence, a preponderance of evidence to substantiate abuse and neglect, and whether or not there is impending danger. That is not necessarily the immediate danger, but that's the sort of underlying danger that could escalate at any time. A decision may also be made to open a voluntary case. These are typically informal, they don't involve court, and they're short term. Or the case could move for court oversight. After the substantiation, if the allegation is substantiated, typically the case is opened. If it's an informal case, services are provided to the child and the family until safety is achieved. That would be a case that didn't go to court. That would be what we would call an informal case. For a formal case, there would either have to be a warrant for the removal of the child, or exigent circumstances would exist, which would enable the child welfare agency to assume immediate custody of a child, and then have to go to court within 72 hours to justify that removal. After that initial hearing, there are several hearings. There's a plea hearing, an adjudicatory hearing, a dispositional hearing, a semi-annual hearing, and a permanency hearing annually. In addition to each of these hearings, there are assessments that are ongoing throughout the case to assess not only the parents' capacity and willingness and motivation to change, but also to assess the progress of that change during the course of the case. And then we come to case closure. Either the child successfully reunifies with a safe parent who has adequately addressed the risks that brought the child into care, a relative or fictive kin takes guardianship of the child because the parent failed to address the issues which created the safety threat in the first place. Parents' rights are terminated and the child is adopted. An adoption subsidy is typically available to support the family, as is a kin gap subsidy if kin gap is the permanency plan. Or a youth turns 18 and chooses not to remain in extended foster care with the services and supports, and they may age out of the system. Or they opt into extended foster care where they continue to receive support and a subsidy until the age of 21, at which point they would age out. Kim, I'm back to your slide with the CPS data. So this slide simply shows you the number of CPS reports received by calendar year 23 through 25. And it breaks it out by agency, which is the color-coded key along the bottom. The next slide is the total youth served in foster care by calendar year. Again, the colors are consistent, so it breaks it out by Washoe, Clark, DCFS, and then also gives a statewide count. The next slide is a placement breakdown of youth in foster care as of March 10th, 2026. So you will see these are sort of the most common placement types. We have relative foster care, family foster care, shelter care, residential care, unlicensed placements, and independent living or extended foster care. The next slide is the same information, just sort of presented a different way so that you can see percentages of children who are placed in those placements for each agency. The next slide gives you a snapshot of children in out-of-home placements by agency. And the next slide talks about licensed beds and unoccupied beds in rural counties. So now we're talking about just DCFS in the 15 rural counties. Many of you have probably heard there is a nationwide epidemic, a shortage of foster homes for children. And as a result, across the nation, many foster children have ended up living in hotels with workers because we did not have a placement for the child in their community or in any other community. So I wanted to really highlight this so that you all would sort of see in numbers, this is what we're up against. So we listed all of our counties where we have foster homes and the number of beds. So a foster home may have 1 bed or they may have 4 beds, right? But foster parents also have the ability to tell us, we only want infants, or we only want kids under 5, or we only want kids between 7 and 9. Only boys, only girls. So even though it looks like we have a lot of licensed beds, when you look at the number of unoccupied beds, people could have a hold on their beds because they're taking a vacation or they had a family crisis and they need to stop taking foster kids for a period of time. So even though it may look like there are a lot of beds, many of the beds are filled and we don't have any beds in many of our communities. And that's where it gets really devastating because to be removed from your home is a pretty traumatic experience for a child, even if that home has some abuse or neglect occurring in it. but to then be removed from your community, to be sent 300, 200 miles away to a new school with new friends, with the inability to visit with your siblings and or parents frequently, is even more traumatic. So we really are trying to increase the number of beds. We would love to have available foster beds in every community so that if a child is removed, they never have to leave their community of origin. We haven't gotten there yet. But in an effort to do that, DCFS has made relative and kinship foster care a priority over the last year. In November of 2023, the Administration for Children and Families issued the final rule, which allowed states and tribes to create separate, less burdensome licensing standards for relative and kinship foster homes. DCFS implemented these standards in the 15 rural counties on April 1st, 2024. So the reason for the federal change, better outcomes for children, right? When we can keep them with family members who they know and love. And also it addressed the numerous barriers that exist when licensing non-relative foster homes. So after we implemented in the rural region, we then started working on regulations that could align with the expectations of the federal government. These regulations have been finalized and were adopted yesterday by the administrator, and we are now seeking approval through the Legislative Commission and finalization through the Secretary of State for codification. Once that happens, I believe Washoe and Clark County will also implement the relative foster home licensing standards, which will help them license relatives much more quickly than they're able to do right now. The next slide just shows you in 2024, we were able to license 19 relatives, and 25, 43 relatives. And in 26, only 12, but that's because we did such a good job the year before, right, licensing 43. And we obviously, maybe we've had less removals. I don't know why it's only 12 this year, but the licensing time has been reduced from about 9 months it takes to license a family, a foster family, a stranger foster family, right? To this process, which takes us approximately 90 days. So the work that has been done to improve the licensing process has been going on since about 2019. We started by reducing the application paperwork and process to make it an easier process for people to get through. We joined the National Quality Parenting Initiative, which we call QPI, which includes branding, improving initial and ongoing online training for the annual renewal of the license and the initial license. We acquired, DCFS required an online application system called Binti. We had never had online application for foster parents to be able to go in and upload information. It was all paper and had to be mailed or delivered. So that was very helpful. We've hired a marketing firm to help advertise. We've updated our training a couple of times to make it more relevant and easier to access by offering it virtually to the 15 rural counties. We contracted with Foster Kinship to provide a reduced online 15-hour training specifically to relatives and fictive kin, which is part of how we're able to get them licensed more quickly. We held panel discussions with DAs, division staff, CASAs, and numerous communities to educate and inform the public of the need for additional foster homes. And then, of course, the relative licensing standards that were implemented and the regulations that were recently approved. The next slide addresses the count of finalized adoptions from 23 to 25. Again, color-coded, so you will see it by agency. The next slide is an average monthly kin gap caseload. So kin gap is the guardianship for relatives which can occur without a termination of parental rights. So if there's an adoption, parents either have to consent, right, or their rights are terminated for the adoption. With KinGap, you don't have to terminate parental rights. You can finalize a permanency plan that is more culturally sensitive to tribes and relatives. Nearing the end of the presentation is the new foster care program, and that's the Extended Young Adult Support and Services Program. Extended foster care took effect on July 1, 2025, expanding services and formalizing agreements between youth and child welfare agencies to better support their transition into adulthood. The new program allows young adults who were in foster care at the age of 18 to voluntarily remain under court supervision until turning 21, giving them continued access to support like housing, financial assistance, and guidance with education and/or employment. Though they're no longer in state custody, the court ensures that they're working toward goals in their independent living program, and they can opt out at any time. In addition, any youth that was adopted or achieved guardianship at 16 or older can have their monthly subsidies paid to them until they are age 21. The next slide gives you the data on extended foster care caseload by month. Again, by agency and then statewide. The next slide addresses the Child and Family Services Review. The acronym we use is CFSR. That is a federal review. The statewide CFSR quality assurance reviews occur annually. So the statewide reviews do not involve the federal government. We do those ourselves annually to make sure that we are on track, because every 5 years, the Children's Bureau comes to Nevada to participate in a review with us. And so we feel more prepared for the review when we're sort of annually also looking at that data and doing those reviews. Nevada completed our federal review in March of 2026, and a program improvement plan will follow that big quality assurance review. For the PIP, the Program Improvement Plan, Nevada opted into the new federal initiative, which is called A Home for Every Child. It's a pilot PIP that focuses on the ratio of one home for every child in foster care. Success will be determined based on either a decrease in removals from the home or an increase in all level of care placements for youth. The final slide is pretty exciting, and it's about ChildLink. ChildLink is a new modern CWIS system. It's a major project that's underway to build Nevada's comprehensive child welfare information system. The acronym is CWIS, which will replace Unity. Unity is our current CWIS, well, it's not even, I don't think, a compliant CWIS system. It's our current database that has been in existence for about 20 years, that has been band-aided together for many years to keep it operational. So the new CWIS system is, I can't overstate how much it is needed. The name ChildLink was chosen by users, child welfare staff, statewide suggested names, and then voted on the finalists, choosing ChildLink. Connecting children, families, and services, it says exactly what the system is meant to do: to link children to safety, families to support, and our workforce to the tools and information they need to do the work well. ChildLink will reduce administrative burden and improve access to critical information, increasing the time workers spend with families and helping to ensure every child and family gets the support they deserve. It is anticipated for ChildLink to go live in July of 2027. And if Nevada can pull that off, I think it is fair to say that it will probably be a national record in getting a CWIS project up and running in a short amount of time. that concludes my presentation. Do you have any questions?
Thank you. Members, questions?
Madam Chair.
Thank you. Go ahead, Senator.
Thank you. Thank you very much for being here.
Sorry, Senator Titus. Senator Lang was
Oh, sorry. Thank you.
identified first. I'll come to you second.
Hi, I apologize for being late. In your child placement, are you cognizant of ethnicity and your placement so that children are placed in like households from where the ethnicity is that they're from?
Betsy Crumrine for the record. I can't speak to the exact process in Clark or Washoe with respect to that issue. I can tell you that in the larger urban agencies, they do have placement support teams that are assigned when a child needs to be removed, and they are trying to really match the child with a foster family. So I would assume that that is being taken into consideration. In the rural counties, there are so few homes. Yes, that would be considered, but there often is not enough homes to make that the primary consideration. One of the primary considerations in the rurals, I think, is to try and keep the child or the sibling group as close to their community as we can, to avoid having to change schools, and to be able to provide, increased visitation amongst siblings if they're separated, and or with their parents.
Follow up, please. Thank you. Thank you for that. And so in the sibling groups, when siblings are separated, can you please explain to me what is done to ensure that it's never, the process is never great, right? But what your department does to enhance what sibling groups, the challenges and the needs that they have, so they don't feel as much trauma from being separated.
So for DCFS, Betsy Crumrine, for the record, Deputy Administrator for DCFS. In the 15 rural counties, great attention is paid to ensuring that children have enough visitation with their siblings and their parents right out of the gate. That becomes more of a challenge if people are, a great distance from each other. So the court is also interested in looking and ordering visitation when they're aware that a sibling group has been separated or children are separated from their communities. It wouldn't be uncommon for a court to issue an order for visitation to take place, weekly or monthly or whatever the order of the court is. We also try to do virtual visits so that we are, if we have to separate, we would never want to separate siblings, but if you have a shortage of homes and you have one home that's only willing to take 5 and under, and another home that's only willing to take another age, you may not have a choice. You may need to separate the siblings. So we would do virtual visits, we would do phone calls. We have had in the rural region large families with like 6 kids that were, all over the rural region, unfortunately. And in that family, we had a monthly in-person sibling visit. So we had workers from every office picking up kids and driving to sort of a new central location monthly so that the siblings could visit. So we try to get creative, and that is a priority for us.
Yeah, and one more question, please. One final question. I'm really concerned about the behavioral health of the children. And so, as it is traumatic when children are separated from each other and from their parents, could you please tell me a little bit about your behavioral health services that you provide the children and what gets you to that point that you provide those services?
Betsy Crumrine, Deputy Administrator for DCFS, for the record. I directly manage the Rural Region Agency, right, DCFS, so I can speak better to that. I do know that in the urban areas, urban counties, the services are more extensive, right? They have more services in Washoe and in Clark County, behavioral health services. So in the rural region, that has been a barrier for our agency for as long as I've been here, nearly 20 years. We have worked to try to help create an infrastructure in rural communities where they have well-trained clinicians. We have done that by offering free training to clinicians, in those private clinicians in those areas, especially if we have seen a need for a certain type of behavioral therapy that isn't offered. TBRI, or cognitive behavioral therapy, or parent management training. If there's a modality of treatment that we are thinking we need for our families, then we would try to utilize grant money to bring clinicians from rural communities together to be able to get the training that they need. We also have a fairly large intensive family services program when we have it fully staffed. We run with about 5 vacancies out of, I think, 13 clinicians that are spread out across the 15 rural counties. And our clinicians are trained in many evidence-based modalities of treatment so that they can work with families and or children if a service is needed that is not provided by someone in the community. Did that sufficiently answer the question?
Oh, one more. Go ahead, Senator.
Yeah, and just one final question. So, are you able to utilize telemedicine for behavioral health therapy?
Yes, and since COVID, telemedicine has become much more available. More people are using telemedicine. We even are able to offer some of our clinical support virtually. So we may have a clinician in our program that specializes in substance misuse in Winnemucca, and we may have a client in Pahrump that person is working with, because in the past we didn't use virtual services or telemedicine, and so it was much harder to get the accurate, correct service to the person. Now that we have that ability, we can do that much more successfully and easily, reducing drive time considerably.
This time we'll move to the north, and Senator Titus.
Thank you, Madam Chair. Again, thank you for being here, and thank you for your years of dedication on this effort. This may seem, it's not obvious to me, and I need an answer. Why do grandparents and aunts and uncles need a license to watch their family members?
Betsy Crumrine, for the record, Deputy Administrator for DCFS. Well, let me try and answer that for you. They don't need a license to take placement of their relative. They need a license to be paid. Because of the 4E, right, reimbursements, And our statutes and our regulations, that license is needed to be paid. So we can place with them initially, right? Because we want to reduce the trauma to the child. So that means placing with the relative. But in the past, it would take the DCFS agency then 9 months to license that family. Now we get them licensed in 90 days. So we get support much quicker.
Sorry to interrupt, but if there's an emergency middle of the night or suddenly decide that they need to be placed, they can go directly to a family member if the family member is willing to accept them.
Yes, we would do an emergency, we call it an emergency placement checklist. So we would go in that night and we would do all of the, sort of down and dirty. Do they have smoke detectors? You know what I mean? Is it a safe environment? And then we would follow up with the fingerprint background checks the following day. But yes, we could make that placement.
And these children can stay in these homes while the licensing is being, so that 90 days they could stay in with the family member. And then is the reimbursement retroactive?
No, it's not retroactive because of the federal requirements. So we cannot pay a placement until we have received the fingerprint background checks back, because there are federal requirements about exclusion, right? Exclusionary criminal background that we can't place with people who have certain things in their background. Violent, a violent assault, a felony assault, a drug conviction within the last, 5 years, or a drunk driving conviction. So until we get that back, but from the date we get that back and it's approved, we can pay them.
Additional question, Madam Chair? So, if on a different subject, years ago we passed some different regulations on foster homes, and one of them involved the possession of firearms in the home. And I was worried that in the rural areas this might affect how many applicants you have, because I thought it was pretty broad. Most rural homes have a firearm, if nothing else, a 17 to shoot a squirrel, those kind of things. And there was some limitation on those. Have we seen a decrease in rural applications for foster homes? Number one, because the amount of hours of training before they can apply. Number two, the issue of whether or not there's a firearm in the house.
So Betsy Crumrine, Deputy Administrator for DCFS, for the record. I'm not sure about the piece of legislation that you're talking about. There are regulations and/or statutes regarding firearms, but the firearms can be in the home. They just have to be locked up separately. The firearm and the ammunition cannot be locked up together, and they both have to be locked up. So I don't think there's a restriction on the number of guns that can be in one.
Okay,
one
I
house.
think it was perhaps a misunderstanding, because I know a lot of rural folks were saying, number one, all this training I have to do, I can't do it, and number two, hey, I have a shotgun and all of this, and there was very big concerns about being safe. I mean, everybody, of course, gun ownership requires responsibility. And so I get all of that thing. So good to know that. And I think for the rules, I think better education on, hey, you could take this training online. Number two, you could still possess firearms. You just need to have certain rules with them. And so hopefully you can see continued expansion of the available housing and foster homes for children in rural. And again, thank you. Thank you, Madam Chair.
Thank you. Administrator Abbott, do you want to weigh in on that?
So my understanding is that the same as Ms. Crumrine, that it is not that you can't have a firearm in the home. It's just that we have an appropriate plan for the safety of the firearm in that home, and that we are following appropriate procedures to keep it locked and keep it safe. So that's my understanding of the current law.
Thank you for providing that additional information. Next, we will go to Assemblymember Hibbets.
Thank you, Chair. I apologize if I missed this in the presentation, but early on you said that Nevada was one of 2 states with a hybrid child welfare administrative structure. Can you tell us what the other state is?
Yes, Betsy Crumrine, for the record. Wisconsin.
Thank you very much. Thank you, Chair.
Thanks. Next is Assemblymember Goulding.
Thank you, Chair. Early in your presentation, you mentioned incentives, a budget for incentives. I think it was performance incentives for Clark and Washoe. I'm not sure I understood what you were talking about there. Can you unpack that a little bit and talk about, is it performance incentives and what would that performance be? And is it only the two larger counties?
Betsy Crumrine for the record. I will do my best. We may need to get back to you with more detailed information about the incentives, but I can tell you that yes, the incentives are just for the urban counties. DCFS was not included in that. I believe it's a statute. I think it's related to the block grants that they received, right? So the funding is a little bit different. DCFS is funded based on caseload, and the counties have the block grants. And so the incentive program is tied to program improvement. So they get to pick one or two things, three things probably max, that they want to work on and show improvement on. And if they successfully do that, then they can draw down the incentive money.
Follow-up, Chair?
Go ahead.
So have those any incentives been either paid or denied?
There have been incentives paid for the last couple of years. I don't have the history of that beyond that.
And Madam Chair, if I may.
Go ahead.
Administrator Abbott, for the record, ABB OTT, we can certainly provide that information to the committee if you would like, as far as the history of the incentives. I know we just went through the round of incentives for this past year where they were given to both counties because they had met the targets that they had set. I don't have the specifics in front of me of what those were, but we can certainly get those to you. And I will just go back to answer the question about just those two counties. It has to do with the way the child welfare system is set up in general. The child welfare system is set up so that child welfare in Clark and Washoe is run by Clark and Washoe counties. And so that's why it doesn't cover the other counties, because the other counties are under us as DCFS. And so we are the ones managing that. But it is tied to the block grant and increasing the block grant payment based on the incentives.
Thank you, Administrator Abbott, for that clarification. Assemblymember Goulding, do you have a follow-up?
That's fine, thank you.
Thank you. Okay, seeing no other questions. I want to take this one moment, Ms. Crumrine, if you will please stay right there. I will call on my colleagues up north, who I believe are holding a special surprise for you. It's my understanding today is your last official day as the state of Nevada distinguished employee. And so we would like to take this moment of personal privilege and recognize you and your incredible 36 years of service to children and families. So it's my understanding that you originally joined Nevada's Division of Child and Family Services in 2007. And under your guidance, our child welfare programs have benefited from thoughtful stewardship focused on protecting children, supporting families, strengthening our rural services, and fostering collaboration among state agencies, local partners, caregivers, and advocates. Your legacy, Ms. Crumrine, is reflected in the programs that you guided through helping all of these countless children and families, your compassion, your wisdom, and enduring commitment to public service. So after nearly 2 decades of admirably serving the state of Nevada, we encourage you all in our audience to please join us in honoring Ms. Betsy Crumrine for her extraordinary career.
Thank you, Madam Chair and committee members. This is very, very meaningful. I am honored to have served for the time that I have, and I am very excited to be retiring and moving to be closer to my grandchildren and my daughters. So, thank you.
Madam Chair, just to be clear also, we really needed about 3 plaques to put all that you have done. And so fitting all that on just one was quite the challenge. So thank you very much for all your services.
Thank you so much.
Thank you, Ms. Crumrine. We really do extend our extreme congratulations for your distinguished career and offer you the very best wishes for a happy, healthy, and long retirement. So enjoy your very last day. I noticed that you did say that we would follow up. So we know that you won't be there to be a part of the we, but we congratulate you together. Thank you. With that, we will now move to the second part of this presentation. We'll welcome Administrator Abbott to move on to the next piece. Thank you so much for being here.
Thank you, Madam Chair, and then good morning, members of the committee. Thank you for having us today to talk a little bit, as Deputy Crumrine did, about the overview of child welfare services in general. And then it is my pleasure to be with you to talk a little bit about meeting the needs of an incredibly complex population, youth with dual diagnosis, that is youth who have both intellectual and/or developmental disabilities, as well as significant mental health needs. I tend to talk quite fast, so hopefully I'll catch us up on some time and you can stop me with questions when I finish, but we're going to try to cover just quick five quick things today. An overview of some of the issues and needs surrounding this population, a project that we have been working on that we called a community solution session, some next steps coming out of that, and then I want to highlight just quickly some of the work our system of care team is doing, and then I'll take any questions the committee might have. So before I get into the details on this slide and the lack of homes, I just sort of want to set the stage on the broader issue, which is throughout our child serving systems in Nevada, we have seen increasingly complex youth. And the issues become more complex when they have dual diagnoses. And that can be, as we're talking about today, intellectual and developmental disabilities, as well as significant mental health. But we also see this crossover in the substance abuse population, as well as with youth who are juvenile justice involved and have some maladaptive rule-breaking behaviors in addition to their significant mental health needs. So finding ways to treat not just one piece of a child, but to treat the whole child is an issue that we as a community need to continue to do more significant work on. With regard to youth in foster care, this really impacts the availability of homes for youth with intellectual and developmental disabilities, plus significant mental health needs. As you heard Ms. Crumrine talk about, we have a challenge nationally on homes in general for youth, and that's why we now have this national initiative to try to find a home for every child. That becomes even more complex when you're finding a home for a child with significant needs. So as we sit here today, we have very dedicated, specialized foster homes that are very, very good at treating youth and their mental health needs and understanding their trauma triggers and trauma histories. But many of them don't have a lot of training around intellectual disabilities, and they're not as confident or comfortable in taking youth into their home that present with those needs. Similarly, through aging and disability services, we have some talented providers who provide developmental services, but they may not be skilled in understanding trauma triggers and youth's mental health needs. Additionally, many of them are not used to dealing with system-involved youth. Our youth come with attorneys and CASAs and caseworkers and court hearings and visitation and appointments, and it is a lot, and we tend to overwhelm providers who are not used to dealing with all of that. So as we sit here, we have these homes that treat certain aspects of the child, but we have not developed specific placements in most instances that treat the whole child. And we really need to act with intentionality to do that, because these homes are not just going to pop up on their own. They're once in a blue moon, we find a diamond in the rough. We find, an amazing foster parent who maybe has these skills, but until we work with intentionality to build them, this is always going to be a challenge for our system. And so just to put kind of into perspective, I wanted to just give you a couple of quick numbers. And I will say our data is far from perfect, and I think you'll hear more about that as the presentations go on today. We definitely have some work to do. And with that new child link system that we are talking about, we're hoping to improve some of our data collection. But based on the data we do have, when we were preparing for the event in April that I'm going to speak about in a moment, we were able to pull some data, and we looked at the number of youth who exited care in 2025 across our state and whether they had a known intellectual or developmental disability diagnosis at the time they were in our system. And you see the numbers there, 12, 20, and 14% respectively across Clark, Washoe, and the rural region. But I didn't feel like that fully captured the picture because unfortunately, some of these very complex youth are long stayers in the system, and they end up with us in their teenage years and sometimes aging out of care. So then we also took a snapshot on a particular day in late April before our event, and we looked at of all of the open cases in our child welfare system on that day, the known diagnoses. It was a little bit higher in Clark, 15%, Washoe 27%, and the rural's 15%. But then we also pulled out those numbers. What did that mean? Out of the total kids in foster care on that day, nearly 700 kids had an intellectual or developmental disability. And that's huge. And so it is not a tiny problem. It is a problem that's throughout the population that we serve in the child welfare system statewide. Also, that data showed that these youth have more placements compared to their peers, less stability, longer stays in certain homes because of the challenges. So we set out to attempt to address this issue because there are significant consequences to this issue. It means more instability for a population that's already incredibly vulnerable. It means how do they continue to access consistent services if they're being bounced around from placement to placement from one side of town to another, or in the rurals in a complete different community. It also, these are youth who often have loss, trauma, and attachment injuries, and having all of these placement changes contributes to making that worse. And in the most serious of cases, and we all know, anybody who works in the system knows these youth, there's this cycle of shelter, detention, hospital. I didn't include runaway, but that's often part of it for our teenagers. And that is something we want to prevent and we want to avoid for these youth. So we set out to try, and our goal with this event that we did in late April was to try to have solutions in real time. How do we come together, talk about these issues, and try to work through the barriers? So we brought together our state and county agencies, providers on the developmental services side, providers on the child welfare foster home side, some of our elected officials, and we were very grateful to you, Chair, for being part of our presentation. And we brought in an expert facilitator to help lead this. And what we did throughout the day was to try to really figure out what are the barriers, why providers don't develop these types of homes, and how do we then work through those barriers so that we could get to the specific homes that we need for these youth. So we came up with lots of different things, and we agreed to kind of work together on next steps. And so what we did at DCFS is try to pull together all of the ideas that came out of that day, the barriers, and then the ideas for solving them. And we've tried to organize them into a matrix. We started meeting with our state and county partners. We met last month, and we're working to get a date on calendar this month to follow up. To identify some of the viable solutions that came from the ideas from those discussions with providers. And our goal is to develop a list of priority actions that we'll be able to work on together, and then designate lead agencies and collaborators for each one, work plans for each one so we can move forward, and also to come together with the broader community and involve them in the process to support these efforts as we move forward. So the next couple of slides, I know we're short on time today, so I won't go through every single one, but we tried to pull together some of the barriers that were identified and some of the potential things we are looking at working on. A big one that came up, and it really resonated throughout the room on that day, was we have lots of different statutes, regulations, different licensing authorities when you're looking at ADSD providers, child welfare providers, and kind of getting on the same page and making it a more streamlined process for the providers so they don't feel like it's cumbersome and confusing. So that is something that I know we have agreed to partner with Medicaid and our county agencies to kind of come up with a matrix and look at whether there's some places that we might be coming to you all moving into next session to look at cleanup or things we can do to streamline that. There was also a significant concern from providers about the rates, given the significant needs of this population, and even the way we structure our rates. There was a request that we look at a more tiered model, not just be one flat specialized foster care rate, but additional levels that could be added depending on the complexity of the youth's needs. We also had a lot of providers express concern that paying by bed or when a bed's full does not make a house sustainable for a youth like this, because they're putting in extra training, bringing in extra providers, and they need to be able to pay those people whether we have a youth in the bed or not. And so looking at ways to fund the home versus to fund bed by bed. Transportation was a huge issue that came up, and so we're looking at a number of ways we can try to support that. Adequate transitions. This is a population that often needs longer and more attention to their transitions because change is hard. So looking at ways to support that. A really big one as well were concerns about behavioral health incidents. If I'm a typical child welfare provider and I now take a child with autism or FASD in my home and they have a tantrum late at night when there's not a provider here or a caseworker available, what do I do? And what if I have to restrain them? What if they do damage to a window or the walls in my home? Lots of concerns around that issue. So the group is looking at a number of possible solutions to address that, having 24/7 clinical support that's appropriately trained, having behavioral consults available to the homes, maybe a fund for property damage so we can help ensure those sorts of things, and appropriate training and supports around de-escalation and crisis intervention. Lack of childcare options is another big issue, and I know we're going to hear more later on some childcare initiatives today, but something that we certainly need to look into partnering with our friends at DSS about maybe some specialized programming for this population. There was some concerns about the process to access other services. And again, I know in the interest of time, I'm not going to go in detail to everyone, but some of these are also things that are already in process in other ways in work that's being done in our communities. For example, there was a concern expressed that the youth sometimes have fatigue about being interviewed and going to a new home or engaging in a service. And I know that Medicaid is doing a lot of work around the development of the peer support reimbursement. And so that's something that was a potential solution for that we know is already in the works. That is ongoing work that we are committed to doing at DCFS, is being a conduit and bringing our community partners, sister agencies, counties together to try to see if we can solve these problems and find appropriate homes and develop programs that really treat and address the whole child. Additionally, I just wanted to spend a minute to highlight some of the work our system of care is doing, because it lines up with this work and serving this population. So just generally about a system of care. It's not an isolated program. It's really a structure. It is what the name says. It's a system, and it is to serve complex youth throughout our community. These could be youth in child welfare, juvenile justice, or in the community at large. And it's family-driven, youth-guided, culturally responsive, and supported by coordinated planning, provider capacity, and data-driven decision-making. We are currently in a system of care grant with SAMHSA that runs through 2028, and there are 3 goals that grant is working towards: building a statewide infrastructure to support our youth, enhancing our provider network, and statewide training and workforce capacity building. And so our team at System of Care has been putting together a series of trainings, and I think the next slide tells us we have engaged with over 600 providers in the community that are interested in these services. So when we put notice out about the services, it was something to watch the responses coming in and the tally going up and up. So clearly there is a need and there is a desire for more training in our provider community around working with this dual population. And so the intended impacts for System of Care is to give families clearer pathways and more access to support to evidence-based services, better coordination, more family and youth voice as the system is improving. And for the state, it's going to give us more visibility into where our gaps are, shared priorities across systems, again, focus on being data-driven and sustainability. So when this grant ends, we can continue this work and find ways to build it into the work we do on a regular basis. So right now, the System of Care is providing evidence-based trainings. They have 4 different types of trainings, and they're listed there on the slide for you, that they're offering right now. And then they are also working with a national provider with expertise in building a framework to sustain this moving forward. and increasing workforce capacity by, again, helping train providers. They need to build in some additional governance into this system and refine our access pathways, and also, again, focusing on how we sustain these services moving forward. So working closely with partners, with Medicaid, and of course, ongoing continuous quality improvement. And so I just want to be really clear, this is a very big issue for our community. I think as a whole, we have a lot of work to do on our system of care and our continuum of children's mental health services. And then it is also imperative that we focus on these distinct populations within the broader population that need specialized services. So homes for foster youth with IDD is a very small chunk that we bid off to try to tackle one thing at a time. But there's a lot more work to be done. And so we will continue to work on this through our community solution session follow-up and the work of our system of care. But I also think a lot of this that I'm talking about will really resonate as you hear the other presentations today. There was quite a bit of sort of synergy across the different presentations and the recommendations coming out, especially as it relates to kind of building the system, and especially focusing on the intensive services in the community so that we are not putting kids into institutionalized care. And with that, I will stand for any questions.
Thank you for your presentation. I would just like to follow up on that and note that in my experience, when we build systems for groups that are seemingly small in number, that have a high level of need, we often build a better system that responds to the entirety of our community. And so I appreciate that your efforts are there and focused on this very high need population of folks that may have a dual diagnosis. And so with that, we'll move to our first question, Senator Donyate.
Thank you, Madam Chair, and thank you again for the presentation. I think my question is more guided towards, it can be in subject of this presentation and the previous one. It's my understanding that DCFS is in the process of looking at a revised proposed regulation. I'm looking at R029-25. That's the one that's most recent. Are you guys, you're familiar with that, correct?
I'm not familiar with all the numbers off the top of my head. So if I may, is that the relative licensing?
Yeah, that's for a correction. That is the one relating to foster homes, looking at the licensure structure and so forth. So we're on the same page of which one I'm looking at, correct?
General foster care or family foster care?
Family foster care. Okay. So the reason why, and I apologize because I'm trying to catch up on the presentations and the content that you're delivering, and on top of the regulation that's being proposed. It's my understanding that states across the country are kind of looking at revitalizing how they're doing licensure structures, and I think this is my understanding of the proposed regulation. I'm wondering in terms of where the department is in the proposal of this regulation. Are you making changes to it? Are you still in the community feedback period of it? It's my understanding that it hasn't gotten approved yet. And the reason why I mention that is I believe in kind of the comments to my colleague up north, there's this question as to whether or not the requirements that we set forth for for family foster care or children placement, if whether or not they're too onerous for families to be able to achieve. And so my belief has always been place the child first, work our way backwards so that we can unlock the payment mechanism for families and then provide them the wraparound services that we need to. And so I'm wondering if you guys have had discussions internally as to whether or not the regulations that we're looking at right now are still too onerous for families to achieve, and what we would actually need to be able to streamline so that families can get a level of presumptive eligibility or a provisional licensure so that we can place children, whether they're struggling with disabilities or not, into homes. So I don't know if this is a subject that you guys have had discussion about, or if you have any recommendation feedback.
Sure. Kimberly Abbott, DCFS administrator for the record. So I came in at the tail end of this process, but this is a process that's been going on since I think early last year. When we develop regulations at DCFS, we work with our community partners, get input from our counties, especially because we have this bifurcated system of child welfare. With regulations, we go through a series of workshops that has already happened on these as well. And then yesterday was the adoption hearing that we had, and I moved to adopt those during that yesterday's session. There was no public comment during that session yesterday. So the last step is now going to the Legislative Council Bureau Committee for the final approval. So we're close to finalizing these. To answer that piece of the question, I think these all came about because of the concerns that you're raising about it being too onerous for families. And it's not just sort of a movement nationwide, it is a directive of the Children's Bureau. They issued guidance basically telling us to try to remove barriers and to make it easier to license these families. And so this is our attempt to do that. It was a negotiated attempt, is my understanding, because we spent a lot of time talking with our community providers in the counties, foster kinship, the other groups that work with these families, because yes, we want to make it as easy as possible and remove barriers, but we also have to maintain some basic safety and make sure that youth are not being taken from one unsafe environment, being removed from a parent and putting in another dangerous, being put in another dangerous situation. So my understanding is this is about a year to a year and a half of work groups and discussions to get us to the point where yesterday we're now at the final stage of moving these forward, having taken into consideration the comments and input that we received from our partners and others in the community about how to get here.
Thank you. Next question from Assemblymember Nadeem.
Thank you so much, Chair. Thank you for the presentation. Thank you for letting us know that the great work is being done through the system of care and how they are giving more education, more training to the providers. So my question is that 600 providers, is that a good number, or do we need to provide training to the more providers? And how many providers are, like if there are 5 children, are they taken care by one provider or there more than one assistant?
Kimberly Abbott, administrator for the record. I think I'll answer the second part of your question first. I think it depends, on the community and on the needs of the child, right? If it is youth are placed, let's say, in one of our family or one of our higher level of care foster homes in the community, ideally we would have them all seeing the same provider who worked closely with that family and could coordinate services. If different youth in the sibling group have different specialized needs, substance abuse, a sex abuse history, other things, they might need more specialized providers and not be able to use the same provider that their siblings do. Also, the age of the child often determines, right? We at the state have early childhood mental health services that goes 0 to 7. If they have a teenage sibling, they would go to our children's clinical team, which is adjacent. So all of those things have to be taken into consideration as far as how to divide up the providers. We are still processing the 600 number because it was much larger than we realized. And this was also in general, we advertised 4 different types of training. So some of those providers may have wanted all of that training. Some may have wanted a specialized program. I will be honest, it was far larger than we were ever anticipating. And we're trying to figure out how to work with all of the people who are interested into our schedule. So I don't know necessarily that we need to recruit more or how that meets the need, but I think we have to see how many folks attend and their response to these trainings and if they feel like they need more. But that is something we are committed to continuing to work on.
Thank you so much.
Thank you. Members, any other questions? Okay, thank you. Thank you, Administrator Abbott. We appreciate you being here and your presentation.
Thank you, Chair.
That will move us to the next agenda item, which is the Child Welfare Continuum of Care Systemic Issues. And Jill Morano with Las Vegas, the Director of Clinical and Community Services with Clark County, will be joining us to deliver the next presentation. Thank you and welcome.
Good morning, Chair Brown May, members of the committee. As you said, my name is Jill Morano, and I serve as the Director of Clark County Clinical and Community Services. So, oh boy. We pause 1 second while I just went away from the screen that I needed to be on to pull up the presentation. 4B. All right. Okay, thank you, committee. Sorry about that. Okay, so we should be up and running now. So I had the privilege of being the chair for task force number 2, which was the very broad topic of focusing on the systemic issues and how we develop our continuum of care. So when we talk about a continuum of care, we thought the best thing that we should do is to explain a little bit about what that means. And so you see on this slide, there's a review of sort of that continuum from least intrusive, least intensive intervention to most intensive intervention, starting with prevention services that were also briefly mentioned and described during public comment earlier today, to early interventions, which would include things like mental health, like screening and early intervention to assess and make sure that children are developing on track, to more interventions that would be things like outpatient therapy, crisis response, assessment and diagnosis of mental health concerns, to intensive interventions, more of those more in-depth and involved community-based services that are often provided in the home, would also be things like partial hospitalization that would be like day treatment kind of programming, to the most invasive and restrictive intervention of residential or inpatient services. So when we talked about, as a committee, how do we determine what to focus on when we talk about how do we build this out for Nevada? And the adage of you eat an apple one bite at a time, we thought we really needed to focus on that area that would have the biggest impact on how we improve our services, and really start there and build out from there once we really start to focus in those high need areas. And so as a committee, we decided that really focusing on these intensive interventions or intensive in-home interventions was the area where we thought that we could see the biggest improvement in Nevada as we continued to develop out our mental and behavioral health services for children and youth. And so we got to that by looking at a bunch of different pieces of research. One, and a big one, was the 2022 Department of Justice findings, where I believe this committee may have heard about this report before, but essentially the concern noted in that report is an over-reliance on residential services to provide mental health treatment for youth. We also internally surveyed the task force just to get the opinions of the decades of experience that everybody on the task force has working in Nevada. We also looked at the 2023 Clark County Children's Mental Health Consortium report that was written after the DOJ summary. So it really highlighted and shared and expounded on recommendations related to that. And then would also like to give credit to the Nevada Health Authority Behavioral Health Transformation Work Group. They have done a lot of work over the last year or so in looking at what services could benefit Nevada, and we really found that we supported a lot of the ideas and what they've already shared. So the reason that we really wanted to focus in that community care area is really just because of the outcomes that you get. You see a decrease in mental behavioral health symptoms for youth, you see decrease in suicide attempts, school success increases, and there's less law enforcement involvement. And so the big goal is, what can we do to help keep children in the community and in their homes so that we don't see what we see now in our system, which is the repeat hospitalizations, long-term placements, and kids are coming and going out of those systems. So here again, just a little bit more information on the DOJ findings and the key system failures that they identified: the lack of intensive in-home services, limited crisis response, weak care coordination and discharge planning, and an insufficient provider network. So as we, again, just more information that Children's Mental Health Consortium report highlighted those same concerns, that there should be a no wrong door for services. Families should be able to access services. We needed an increase in awareness around the support for mental health. And one of the things we'll talk about a little bit more in our recommendations around locally managed systems of care for providing mental health services. So a shout out in these next couple of slides that you're going to see again to the Behavioral Health Transformation Work Group. These slides may look familiar to you. You've seen them before, but we thought that they were important enough to share again, that the reason that we really wanted to focus on this intensive intervention level, which is sort of to stop youth from entering residential or help them successfully step down, is because we do in Nevada institutionalize children at a higher rate than the rest of the country. You can see we have a 51% higher risk for children experiencing a residential hospital stay than other states. And if the impact of the children isn't something that's convincing, the other concern is 80% of our Medicaid spending is done to support residential treatment. Residential treatment is a very expensive intervention for children. And so if there's ways to divert funding to lower levels of care, not only do you see better outcomes for children, but you see a more fiscally responsible intervention. On this next slide, so when we talk about intensive intervention characteristics, what are we really talking about? We're talking about services that typically use a team model, that care coordination is a key component, 24-hour crisis response so that families have the support they need is a component, and requiring treatment planning that can be provided in the home or in other community settings. The key is this is not done in a residential setting. There are many states that have different kinds of services. I have some examples that we can take a look at. Some of these can be done independently. Some of them are done in the context of a care management entity, or some of them can be funded in other states by waiver programs. But all hope is not lost with where we are in Nevada. Washoe County actually, in their juvenile services program department, actually has multi-systemic therapy, which is an evidence-based in-home intensive service. And so we wanted to make sure that we highlighted where we have opportunities in the state that we can grow from. And this is a great example of something that we've already started in the state. Intercept is another program that we wanted to highlight. Intercept is an evidence-based program. There are a few different available funding streams for it. One of them, the Family First Prevention Services Act, because it is an evidence-based program. And other states often use child welfare or Medicaid funding to fund the service. Intercept is essentially an intensive in-home service where you have case managers or clinicians going into somebody's home multiple times a week to help the parents better address and manage the concerns in the home. The next few slides are really, I'll leave them for your review so that we can get to our recommendations. But these are just some examples of what some other states are doing. And you can see the characteristics and the qualities of most of these programs really include intensive in-home services done by typically bachelor's level or master's level clinicians that are coming into the homes. And again, also having the ability to address not just like the Medicaid reimbursable service of like a counseling session, but also the ability to address any other concerns that might be going on in the home. And the reason that I highlight that is because when we talk about the recommendations that we had and the funding concerns that we have, that's really the struggle is how do you pay for it? And so we came up with some recommendations, and we didn't want our sole recommendation to be, can you just pay for it? But we had a really hard time coming up with other ideas that didn't result in, can you just pay for it? But I'll go through them in a little bit more detail. As I mentioned, the Division of Healthcare Finance and Policy or Nevada Health Authority have done a lot to identify what the needs are and to start to explore other funding mechanisms. One of our recommendations is that their efforts to fund intensive in-home benefits be supported. Another is that we support efforts around health insurance parity and benefit mandates for intensive in-home services for insurance purchased through the exchange. We recognize that Medicaid funding helps a certain population, but it doesn't help everybody. So one of the big discussions that we had in the work group was, how do we make this more widely available? Because what we don't want to do is drive children or families to justice systems or to child welfare systems in order to be able to access services. And when systems like Medicaid are the only system that's funding a service, there ends up being creative ways that people figure out how to get children into the systems so that they can get the funding. We would also support funding requests that improve access to transportation to intensive services. Partial hospitalization is a great example. There are a few different partial hospitalization programs that have recently opened up in Clark County, but getting the children there is particularly difficult. And so Medicaid funding or other funding that can help get children to the service be helpful. You know, the challenge becomes something like partial hospitalization. The program may run from 9 a.m. to 2 p.m. That's very frequently when parents are at work or when parents are trying to get other kids to or from school or to or from other appointments. And so any way that we can help either reimburse parents for the transportation or provide transportation services to get children there is very helpful. We also recommended supporting development of a Medicaid benefit for respite services. Sometimes what parents need is just a break. They need a time to take a breather. They need a time to run their own errands. They need time to watch a movie uninterrupted. And so anything that can be done to help give parents that time to reset and recharge so that they can then again engage appropriately with their children, we think is really important. We would also recommend creation of incentives for mental health providers to be trained in and implement evidence-based programming. You just heard Administrator Abbott talk about some of the work that DCFS is doing with systemic care, so we really do support that. Some of the clinicians that work in our county department have also been able to take advantage of some of those trainings, so it is already proving to be beneficial to us. We would also recommend creating a learning collaborative that would support quality implementation of services. Getting services is one thing, but really developing strong quality services is another. And particularly when we're at such an early phase of starting to build out services, we recognize that providers of services need an opportunity to practice and hone skills and work with one another to ensure that we're developing the most comprehensive system as possible. Finally, we recommended supporting the Division of Child and Family Services in their efforts to update the Families First Prevention Services plan. So that was briefly mentioned earlier. Essentially what that is a plan that allows for an alternative use of federal Title IV dollars to use to prevent children from entering the foster care system. And we recognize that there are many of these intensive in-home services that could be provided to youth that could prevent their entry into the child welfare system. And so therefore using the funds earlier on so that you're not using them to pay for foster care, you're using them to stop the children from entering foster care. So again, just a summary of kind of all of the things that we talked about in the group, about the things that we thought were important. And then as I wrap up, I wanted to make sure that I recognized everybody that participated in the group and helped come up with these ideas. It was a large task force with many people with years, if not decades, of experience. And so I really appreciate everybody's time and energy in working with us. So as I wrap up, I would just like to echo and highlight a comment from earlier about Deputy Administrator Crumrine. I have worked with Betsy for almost the full 20 years that she was here, and we have worked a lot in the rural region. I know all the hard work that she's done. I know her dedication. She will be greatly missed. So with that, I wanted to wrap up and offer any questions.
Thank you. Well, we do have a question from Senator Titus.
Thank you, Madam Chair. So I want to refer back to your page that where you noted, and I don't see a page number, maybe page 15. Or is that an 18? Anyway, 51% higher risk of a Nevada child enrolled in Medicaid with an inpatient stay compared to the national average. And I just need some clarity on that statement. Do you feel, looking at your numbers, is it because there's not enough access to in-home care or outpatient care, and so these families or the agencies are forced to take them to an inpatient location?
Jill Morano, for the record. Yes, that's the DOJ. That is essentially what the DOJ findings said, and what our experience, I think, in the field is that there is a lack of resources to address the concerns at a lower level. And I think when I say lack of resources, I really, quite frankly, mean lack of funding, because and insurance will pay for a residential stay. Medicaid will pay for a residential stay. Medicaid will not pay for intensive in-home services to have a clinician come into the house 3 times a week and provide therapy, in the home.
Well, I'm curious about, thank you for that. I'm curious if I might, Madam Chair, follow up on that, because everything else that we hear, there's not enough inpatient beds. And so would this, if we had, in the long run, as a fiscal conservative, I'm looking at if we had more outpatient care, we could free up these beds that these folks are taking up, that we could keep them in their home, save some money, and then actually have beds for folks that need it. And so we're not sending these kids out of state. Is that a reasonable analysis?
Yeah, Jill Morano, for the record, I think that's exactly what our perspective is as well, is that if we could serve these children at a lower level, the beds would not be necessary for them.
Then thereby opening them up for kids that actually need them, kiddos.
Correct.
All right. Thank you.
Jill
Thank
Morano,
you.
for the record, yes.
Again, thank you for that, and thank you, Madam Chair, for the question.
Thank you. Members, any other questions? Go ahead, Assemblymember Nadeem.
Thank you, Madam Chair. Thank you for the presentation. And as you mentioned about the Intercept, I was reading about that program. Almost 25 states in US, they have adopted that program, and it's very beneficial. So do we have any such program in Nevada that is very much similar to Intercept?
Jill Morano, for the record, no, we do not have anything like Intercept. The closest thing that I believe we would say we have is this Washoe County Juvenile Services multisystemic therapy, which is another intensive in-home family services model, but it is different than Intercept.
Thank you. Members, any other questions? Thank you. Thank you for your presentation. We really appreciate the recommendations. I would like to especially shout out your slide that says thank you to Task Force Number 2 work group and identifying exactly who was a part of your work group throughout the interims. That's really important. Thank you so much for including that. We will now move to our next presentation, the structure of the child welfare funding in Nevada, and we will welcome Cadence Matievich, Government Affairs Liaison with Washoe County. Ooh, and Joanna Jacob. We have lots of folks here today. Okay, thank you so much. Welcome, and you may begin whenever you're ready.
Good morning, Chair Brown-May, Vice Chair Donyate, members of the committee. For the record, I'm Cadence Matijevich, CADENCEMATIJEVICH, and I have the privilege of serving as Government Affairs Liaison for Washoe County. I'm joined this morning by Joanna Jacob, Director of Government Affairs for Clark County, and Amy Hines Sutherland, Interim Chief Executive Officer for the Nevada Association of Counties. Madam Chair, are you able to see our slides? Okay, there we go.
Thank you.
Great,
yes.
thank you. Thank you for the opportunity to present today on the work that Task Group 3 has undertaken during this legislative interim. The focus established for our task group is how child welfare and children's behavioral health are funded in Nevada. Chair, I recognize that this is a policy committee, but given that the focus of our group is on funding, I will ask for your indulgence as we discuss primarily fiscal matters today. When the task group began our work, we had a broad group of stakeholders who set out an ambitious work plan with associated objectives and tasks, which are summarized on this slide. And while much work has been completed over the last 6 months, I must admit that we were not able to complete nearly as many of these items as we had originally set out to, and that there is still a great deal of work to be completed. I would note that much of what we're going to present today comes from a subgroup, and so I intentionally didn't include a slide with all of the task group members because I didn't want to imply endorsement by some of those others. And so that was not intentional to exclude them, but also intentional so as not to have their name associated with something that they had not necessarily been intimately involved with. And again, for reasons I'll discuss a little more in detail shortly, many of these would have provided opportunity for involvement by that full work group, but they've been deferred, and our sub work group has focused exclusively on the structure for the funding for the 3 child welfare agencies in our state. I want to thank the members of the task group who've been patient while our scope has been narrowed, and I look forward to re-engaging with them to determine next steps on our full work plan. As you saw from our work plan, many of our tasks centered around obtaining and analyzing financial data, which proved much more difficult than we had anticipated, and we faced significant challenges in obtaining the fiscal data that we needed to complete our work. I want to be clear, the challenges that we faced were almost exclusively system-driven, not people-driven. I want to thank the Governor's Finance Office, the Legislative Council Bureau Fiscal Analysis Division, the Division of Child and Family Services, and the Nevada Health Authority for the support and time that they've given and responded to our many data requests and follow-up inquiries. Chair, I naively believed that we would be able to easily access much of the revenue and expenditure data that we sought through online resources available to the public. I was wrong. And this slide highlights some of the challenges that we faced relating to accessing the data. All of that said, we come before you today with recommendations based on the work that has been completed to date. In this slide, in the following slides, we'll dive into the detail and background on these items, but we wanted to present these to you at the outset so that you had some context for some of these wonky details we're going to be covering. So our first recommendation, well, we would ask this committee, and indeed the entire body, to urge Congress to update the Title 4E of the Social Security Act to increase the income eligibility limit for children in foster care from the standard that was set in 1996 to a standard that is tied to current federal poverty rates. And our second recommendation would be to amend Nevada statutes governing child welfare block and categorical grants to include a method to adjust base appropriation amounts based on certain growth indexes and to account for new policy mandates. In her presentation earlier, Ms. Crumrine covered much of this, and so I'll skip over this slide, but thought it was important to include it for someone who may be reviewing this presentation by itself. Again, we are one of 2 states in the US that function under the hybrid structure that we have today that was largely put into place beginning in 2001 and then amended again in 2005. And really the structure that we have today from a funding perspective was first put into place in 2012. Outlined here, you can see the primary funding sources for child welfare in our state, which are a combination of federal, state, and local dollars. I want to acknowledge that the local funding category includes monies that come directly to local governments through non-federal grant and other external funds, including funds from nonprofit entities who are very important partners in our system. This chart illustrates the total state and federal revenues across the 3 budget accounts for our 3 child welfare agencies. I want to note that there are funds for child welfare in several other state budget accounts. We counted, we think, as many as 23 other budget accounts, but that these 3 really represent the bulk of the funding. And so we've focused our analysis here first. As you can see, Title IV funding and state general funding make up most of this. And that is why our recommendations today are focused on these 2 primary funding sources. The next several slides focus on Title IV and the factors that determine how much IV funding Nevada is eligible to receive from the federal government for children in foster care. You see here the 3 criteria for the state to be able to receive IV funds for a child in foster care. The first, a court finding that the removal from the child's family was necessary. Number 2, that the child is placed in a licensed or approved setting. That gets back to the question that Senator Titus asked a little earlier around placement with family and what that means. And I think Administrator Abbott did a great job in clarifying that it really, not that they can't be placed, but that they're not eligible to receive IV funding without a licensed placement. And then third, and this is the focus of our recommendation, proof that the income and assets of the child's family fall below a dollar threshold set in 1996. You heard me right. The income portion of the eligibility criteria is based on a standard set 30 years ago. This chart depicts the difference between that threshold that was set in 1996, and I should note that that is not a standard that's nationwide. Each state had its own individual need criteria under the Aid to Families with Dependent Children, and so this is Nevada's specific need rate that was put into place in July of 1996, and this depicts how that looks compared to today's federal poverty rate. As an example, for a household of 3 with 1 working adult who makes $12 an hour, under the 1996 standard, that adult can work no more than 118 hours per month before their income surpasses that 1996 threshold. If the threshold were raised to the current poverty standard, that same adult could work full-time, making $26.33 an hour before their income would surpass the maximum. So how does this eligibility criteria factor into the amount of IV funding Nevada receives for children in foster care? It is a key component of what is known as a state's penetration rate. Sometimes we call it the PEN rate for short. And it's calculated by comparing a state's expenditures for children in foster care who fall below that income threshold to the state's total foster care and adoptions expenditures. The more kids that fall below that IV income threshold, the higher our penetration rate. So we did some analysis to look at if the eligibility threshold were adjusted to current poverty rates, what might that mean for our state? And in Washoe County, we completed an analysis of the children that were in foster care in April of 2026. And this will always vary because, right, kids come in, kids go out, but we took a snapshot in time and looked at that. And if the income eligibility threshold were adjusted to the current poverty rate, our penetration rate would have increased from 55% to 78%. Similarly, for Clark County, based on all of the factors, it would have meant a 22% increase in their penetration rate. It's a big difference. The next two slides cover the federal Medicaid assistance percentage, or FMAP. And I know that many of the committee members are familiar with FMAP and the fact that the FMAP rate in Nevada has been declining in recent years. So I'm not going to dive too deeply into the details on these slides. However, what some committees may not know, what many people in the audience may not know, I didn't know before we started this process, is that our FMAP factor is also considered in determining how much 4E eligibility funding we are eligible to receive. This slide, perhaps the wonkiest of our slides today, shows how the penetration rate and the FMAP together determine our effective federal match rate and how that translates into the percentages paid by 4E for children in our care. From a policy perspective, we believe that advocating for updated 4E income eligibility criteria has the highest likelihood of increasing the number of federal tax dollars paid by Nevadans that could be returned to our state to invest in care for kids in foster care here. Moving on to our second recommendation, we're going to talk a little bit about Nevada's child welfare block grants. And again, Ms. Carmine covered this a little bit in her initial presentation. And as she described, in 2011, the legislature established capped-based child welfare grants amounts for Clark and Washoe. Those went into place for the first time in fiscal year 2012 under Senate Bill 477. And those really, with exception of an increase that happened in the last biennium, those capped block grants amount have remained the same at that same amount as they've been since 2012. And if you look at today's dollar compared to the 2012 dollar, if you index that to inflation, you would need $1.48 in every one of today's dollars to match those dollars. And so, Madam Chair, for more details on the second recommendation, I'm going to turn over the presentation to Ms. Jacob.
Good morning, Madam Chair. Joanna Jacob, Jacob, no S for the record, on behalf of Clark County, but really here as a member of this task force and a number of other task forces, here to kind of pinch hit a little bit and give Cadence a break. And I'm going to ask her to walk us through the slides as I kind of walk through an illustration of what she has described and what this means for both Clark and Washoe County. So moving on to slide 15, this is an illustration of data that we pulled from using data from the state and all of the partners that Cadence outlined in her presentation. And this is what Clark County's block grant has looked like since approximately 2012. So I want to point out to you that the block grant is the second blue line from the top. From 2012 to 2025, this has been capped at $28 million approximately per year. In the 2020, you'll see a bump, and I want to explain the bump because you're going to see that in both Clark's chart, and then we have a similar chart later on for Washoe. We are structurally the same. Our dollar amounts differ, but I will say you'll see the bump there as well. This is because the legislature approved in the 2023 session a foster rate increase, which we are very thankful for. And we want to thank the legislature for investing in the families and the kids that we serve. This was separately accounted for in the fiscal year 23 and 24. And then the bump you'll see is because of the state budgeting process that it got wrapped into our block grant in the last biennium. And I want to say there was also a similar rate increase, which you will see also down here in a different number. That is our adoption payments, and that was a similar rate increase. This is funding very important funding that is a pass-through, was put into our budgets and is a pass-through to the families and the kids that we serve. Very needed funding, as you've heard today from many of the other people who talked there. But I will say, and I have to say, that it did not offset any of the costs to the counties that have gone along with delivering our program, and responding to a lot of the policy shifts that we have seen in the last decade. And I have a note in here at the bottom of the slide that really makes that point. And I, just by way of illustration, because I want to make sure if you're looking at this online, you'll say, wait a second, it looks like the funding's gone up. What are they talking about that it's been capped? And I will say that in 2023 to 2025, for illustration, when it looks like we got a bump of approximately $11 million for the foster care rate increase. At the same time, over the same period, the difference in the expenditures that Clark County incurred in delivering our program was 17 million. Included in the 17 million was that 11 million, because it's an expenditure that we made that went out to the families. But then we also had about approximately $6 million in additional costs. And that is really related to staffing and other things, workload that we've had to implement through the years. And we'll go to that in future slides. So I'm just going to say the top line on this graph is our total amount. The blue line is our block grant. The dark blue line down here is our adoptions. And this is where I mentioned that there was a rate increase in the last session, and you'll see that slight bump there. The orange line at the bottom is the incentive payment that we've had a couple questions about that this morning. And I will just say the incentive has been capped at $5 million. Through the years, there's been a lot of talk about this incentive payment. I know this because I've been with the Clark County for a long time. During COVID, when we had the budget challenges, there was a proposal to cut this incentive payment from Clark and Washoe budgets, and it said it's optional. For the counties, this is not optional. We have earned it, and I will work with the state to do the follow-up information that you've requested today about how this incentive program is used, but we rely on this funding. When it was put into place, when the block grant was first put into place, it looked at our expenditures and it held aside something that we were already spending as an incentive payment, right, that we would apply for in the future. But the truth is that it's funding that we always had and that we always are working on. And we largely use it to try and comply with some of the federal mandates that and the improvement plans that Clark County, Washoe, and the state, we all have to report on the federal improvement plans. So I will say, moving on to the next slide, I want to just point out, Ms. Matievich said that yesterday's dollar is today's $1.48. This is what this looks like for Clark County on the inflation. That inflation rate that she talked about is that adjusting for inflation alone to the block grant would increase our block grant level from $42.75 million to what it would be adjusted for today's rate, $63.1 million. We know we can't walk into the legislature and say we need a 48% increase. I know this, but I'm just illustrating a lot of what I think you are feeling and what our families are feeling and what everybody is feeling is that the inflation is increasing and everybody is struggling with this. And along with that goes some increased pressures on us in delivering programs. So moving on to slide 17, this is Washoe's illustration. So I don't want to belabor the point. You'll see it roughly mirrors Clark because we're under the same structure. And I will say that this is what this looks like. I do want to point out, we worked really hard on this presentation, but there's an error in the note here, which was unintentional. And it kind of goes to the data problems that we had that Ms. Matievich illustrated. It's not urgent or anything, but I note that in the note, it says the increase in funding reflected in category 12 above. For Washoe, it's actually category 13. So I just want to make that correction. And it is correct on the chart, but not in the note, Madam Chair. And I will just say that they have had a similar pattern to Washoe County. We'll sit with that, but we'll also go on to the next slide, the block grant for Washoe for inflation. You will see that for Washoe, this would mean an increase from 14.5 million as it is today, and would really reach about $20 million for Washoe. And you can see, as it illustrates on the chart here, that the gap here has widened as the inflation has increased. We'll sit with that, and then I think the next slide, we really want to just highlight. Inflation is one thing, but the other thing that we and the state have had to respond to is the significant policy changes that have been enacted during the same time that we've illustrated on the chart, in which largely our funding was capped. So we saw the Family First Prevention Services Act. We've talked about that a lot. For Clark only, I don't know, we've talked about this for a couple of years. So if you're new to the legislature, maybe you might not be familiar with it, but Clark County, before the Family First Prevention Services Act passed, we were operating a waiver, what they call a waiver program. That was kind of an early program that predated, it was a prevention program that predated the passage of Families First. And we called it Safe at Home. And it was to help support families if they were involved in child welfare services, to accelerate reunification and to help the families, reunify in their home. With that, there was funding associated with that waiver. When Families First passed, Congress said that anybody operating under that waiver had to transition that waiver out, because Families First was intended to replace that waiver. And so we have seen during that time period, we incurred a $10 million annual loss. And that is for Clark only, because we were the jurisdiction doing that program. Then in Nevada, I've listed some of the things that we have done. I don't want to go into very details. We certainly can on all of this legislation, but this is really the most important thing to say, is that there have been some real policy changes put into place by the Nevada legislature, and it's not a criticism. I think a lot of these bills were positive ones for the families and the kids that we serve, but they did not come with resources to the counties to implement it. And that has been, we've had an increase in staffing needs, we've had an increase in workload that we struggle with, and that has been the biggest challenge, I will say. The TANF, I have a note here on TANF funding. We have partnered a lot with the state on, there is TANF that was put in, that's temporary assistance to needy families, to kind of supplement this and to assist the families and the kids in there. And it's been kind of sporadic through the years. So there's been a lot of work with the former welfare division and on this to try and support us in this, and we want to thank them for that. And now social services, I think the state social services division, but we want to thank them for that. But it is just the reality. And I will hand it off here. I know there may be questions, but we'll hand it off to here, because another piece of the pie really is what it looks like for our rural counties. So I'll hand it over to Amy Hines-Sutherland from here, Madam Chair.
Thank you, and good morning, Chair Brown-May, Vice Chair Duniate, members of the committee. I am Amy Hines-Sutherland, HYNE-SUTHERLAND, Interim Chief Executive Officer, the Nevada Association of Counties. And I'm joining you here today to share information on rural child welfare funding on behalf of Task Group 3. So here on slide 20, you can see rural child welfare revenue by funding source. Title 4E funding is largely flat, while general fund spend has over doubled over the time period from fiscal year 13 to state fiscal year 25. Something I want to note and has been remarked on a number of times today, but the bifurcated system allows the state budgeting process to proceed in a different manner than the counties. However, I do want to indicate here that DCFS, on behalf of those 15 rural counties, faces very similar challenges to Washoe and Clark in regard to when we take a look at the general fund spend. That's the orange on this slide. Even though we do have over double the spend out of general fund on DCFS, rural child welfare, it's also the case that increases to staffing costs have pushed that up, also adoption subsidies, which are pass-throughs, and also increased foster care and relative maintenance payments. Let's see. Yep, and that's all for that slide. Can you, next one? Okay. One of the things that we took a look at through this funding evaluation process is what are driving the costs of the child welfare spend. And when we take a look at a couple of the categories in the DCFS budget category, we could really see some of those increases. So on page 21 or on slide 21, you see the expenditures for personnel. Those have increased from 7 million in fiscal year 13 to 14 million in fiscal year 25. On this slide, you see the breakdown of how we fund that, the braided funding model that we have in Nevada for those personnel costs. This is just budget account 3229. So the purple here is general fund. The orange here is county reimbursements. I do want to highlight counties, the 15 rural counties that are served by DCFS as their child welfare agency. They pay a child protective services assessment. It is just for child protective services. If you're looking just at this slide, it will look like those county assessments have gone down, but beginning in fiscal year 22, counties also were charged for CPS assessments in budget account 3145. So I'll show that in a couple of slides. But for now, just wanted to illustrate how those personnel costs have gone up. And that is true across the state for both DCFS and Washoe and Clark. On slide 22, you can see the increase in the adoption subsidy payments. These are fully funded through general fund and Title 4E payments. Again, echoing that for DCFS served counties, Title 4E penetration rate is very important, and eligibility for those dollars impacts how much the state then has to pay to support these services. And this has just not nearly doubled, it hasn't doubled, but just under doubled. And those are great. Thank you to the legislature for those. Those are important. They do benefit our families and we need those dollars, but it is important to note that it is not increasing the capacity of child welfare agencies to deliver services. On slide 23, just highlighted, I really want to thank Administrator Abbott, Deputy Crumrine, the entire DCFS team. They've been working with the Nevada Association of Counties over the past 4 months and prior in setting this up on a workshop series to really bring county and state teams together to understand how can we better serve families by, eliminating silos, better understanding each other's infrastructure, and really supporting each other to best serve kids across the state. We, through that process, identified a number of recommendations and steps forward. Because our task group is focused on funding, I'm just going to focus on the funding recommendations today. But I do want to thank that team for all the time they spent in helping counties and the state, counties helping the state in understanding what does the infrastructure look like for all of us to work together. So on page 24, you can see the Child Protective Services assessments. This is an assessment that counties pay to the state for services. It's one of many assessments counties pay to the state for services. The cost of this assessment has grown 112% over the project period. In reviewing those budgets, it is tied to personnel costs. And so we know that the driver of this increase is personnel costs because the way that the county CPS assessment is budgeted is based on percentage of time from budget accounts 3229 and budget account 3145, the percentage of time spent on CPS work. But because it's budgeted this way, it is very difficult for us to separate out child protective services costs. And that makes it very difficult when we're looking at a statewide perspective to compare apples to apples when looking at our 3 different child welfare agencies. So I just want to highlight here that there has been increased costs to counties for those services, and that more clarity or kind of a little bit more analysis of how the CPS assessments are budgeted in the state budget, I think would help statewide in us better understanding cost drivers. On slide 25, I want to highlight some recommendations that you've already heard so much about today. But because we're here on behalf of Task Group 3 with the context of having worked with DCFS through the NACO workshops, I really want to highlight recommendation number 1, which is that we need increased investment in developing foster parent infrastructure. This includes continued support for professional foster parents, additional staffing for foster parent recruitment and licensing of relative fictive kin, and increased local community support for current foster parents. Now, when I talk about the increased community support, we're looking at models where we already have current foster families. What is the community doing to really wrap themselves around those families and make them feel supported? And that can happen through the business community, through things like discounts at restaurants or vouchers to movie theaters. But we're trying to get creative about how, once you get foster parents in a community, how do you keep them and encourage them to continue in that work? The second bullet point is on analyzing the budgets for drivers of increased CPS costs and considering a revision of the formula to more equitably distribute costs between counties. I won't go too deeply into this, but the CPS assessment is based purely on population. So there's no base plus usage or base plus usage and per capita. And we do have counties that have invested in the front end on how do you keep kids, how do you do prevention in your community that reduces the need for CPS utilization in a community. And so as we move forward, I don't know that we have a specific recommendation about what would be the best formula yet, but we are taking a look at not just how do we redistribute the costs across counties, but how do we incentivize building prevention services on the front end, and maybe the formula can take that into account. And then finally, urge Congress to increase the income eligibility limit for Title IV funding, as that impacts all of our child welfare agencies. Thank you. That concludes my part of the presentation, and I believe we're all ready for questions.
Thank you. Questions? Senator Doniate.
Thank you, Madam Chair, and thank you so much for the presentation. I think part of my questions are a little bit all over the place and more philosophical. And I'll read to you the questions that I wrote, just because I think all of them are part of the puzzle piece. Listen, I hear you. I think that there is a case in point in terms of whether we should, the legislature should re-examine how the block grants are administered and how we fund child welfare services in our state. I think, I mean, if you've sat in our committee meetings, all of us know that HR1 is coming, and there's not enough money for everyone. And so I don't want to be in the position where the counties are fighting with the state, and it's kind of a back and forth of, well, we don't have enough money for anything, and so how do we move forward from this? Obviously, I mean, in my earlier questioning, I was trying to ask about licensing of what are things that we can do to move the flow of funding faster and easier for families. But I think what I would like, and again, I'm going to read to you my questions, because I think there's more that we could do right now that we're not taking advantage of. For example, so I wrote, obviously I'm looking at the shift in FMAP, and I think a lot of the changes in terms of our federal funding could be attributed to the penetration rate. I think that's something that we've noticed in terms of trends. I mean, I wrote down, does the bifurcation in our system create duplication and deficiencies in how our services are being billed? Is there a standardized way of how RMTS is being coded, and are we training our caseworkers to capture as much federal dollars as we can with what our processes are? Do we have standardization on billing and eligibility for how the counties are administering these at the local level? Should we look at creating a shared savings program on capturing these recovered federal funds, and maybe that could help us increase how much we're doing for the block grant administration? Are we capturing the legal representation administrative costs? I think that was more back in 2019. Are we doing the much that we can based on what we could be capturing? Are we utilizing technology to capture the data as far as we need to for billing some of these things to the federal government? All these questions, I think, back to the philosophical lens of, maybe it's not coming back to the legislature and asking for 40 million. Maybe it's looking at what we can do already to lower the deficiencies. And if that's something that we could work on, I mean, we have a month and a half left before we pass and approve our bill structure. Maybe that's something that we should look at in the coming weeks so that at least we can get the ball rolling for next year. So open to your feedback on some of those questions.
Cadence Matievich for the record, Madam Chair, through you to Senator Del Niate. Thank you for those observations and questions. And I want to be clear, Ms. Jacobs said it when she went over the slides that she covered. We wanted to present the data to you that we had found today for illustrative purposes. We are not sitting in front of you today suggesting that just there's a CPI that should be applied and $40 million more. We understand that we are partners with the state, and we too do not want to be in a counties versus state, county versus county. We're all in this together, and we recognize that the state has some significant fiscal challenges, particularly in the health and human services area. But so I appreciate the indulgence to present the findings from our analysis to you, and really the places that we sort of identified as structural deficits. And I think our recommendation that we look at some sort of a methodology that acknowledges growth indexes, maybe it's not inflation, maybe it's a combination of things, to try to put something into place to address it, not all at once, but to sort of stop the spread, as you saw in that chart, over time. A couple of your questions, are we training? Yes. Are we necessarily doing that consistently? I don't know. I don't have the answer to that question today. We can look into that and get back to you. Are we standardized? For the most part, I think that we are. I mean, the federal requirements and the criteria that you go through, I think are pretty stringent, and the workers must use that. But is there opportunity for improvement? Yes. Are we using technology? Not to the maximum. We, the counties, I think can speak for all of us. You heard from Administrator Abbott earlier this morning about the CWIS. We are super excited about what that technology can bring just from being able to have the data that will show us the trends and the things that will help illuminate whether or not we're spending dollars in the right place. Is it the end all be all? It's not. Is it going to take us some more time? Yes. But do we have the technology today? No, we're on our way. And so from Washoe County's perspective, we welcome the opportunity, recognize that there's not a lot of time between now and when BDRs are due, but felt like as we went through this analysis again, just looking at those two primary funding sources, that we found some structural deficits and felt appropriate to bring it to this body, and appreciate your indulgence, and thank you for the questions.
Thank you, Madam Chair. I just had a point of clarification. I think the rationale as to why I was asking those questions, if the answer to any of the questions that I had was, yes, we could do better, yes, we could be capturing federal dollars, the bill draft process, if I'm correct from our legal counsel, is just a legislative mandate, right? It can start to formulate ideas to move forward. We don't have to start getting things into law or implemented immediately, right? It's to move the structure. And so if there is an interest, I would hope there is, of a shared savings program, or maybe working in good faith to create a structure that establishes cleaning benchmarks, and so a performance structure between the counties and the state where we both benefit together. Like all of that can be done, but within our bill draft deadline. Don't get lost in the implementation process of it, because this is not a conversation of something that we'll fix within the next 2 years. And so I will just put that mandate on you guys. If that's something that you would be interested in working with us, it could be a paragraph, and we can work in the next several months to identify what that process would be. so that at least we're marrying the ideas and still moving the needle forward on how we're managing at least the cost perspective of this. So that's my only advice that I would give.
I'd just like to respond. I know Ms. Matievich did a great job, Senator Giannate. I guess if philosophically, let's talk philosophically. Philosophically, if any of the legislators asked me, what do we need in child welfare? I think as Clark County's representative, I would say everything. Do you know what I mean? We could tackle this from a number of perspectives. So I appreciate what you're saying is that maybe we have to think outside of the box a little bit and think about some of the reality. How do we move the needle, knowing the challenges that are ahead for you and for us collectively on some of these things that are happening? So I would like to say, I'm glad that Ms. Matievich clarified, we are not asking for a 48% increase. We know that that's not reality. I think it's a collective understanding of what the challenges that we are facing is probably my first ask, is that this committee would help us during the session to say there are some challenges, but how do we get through the challenges together? The good thing about these task forces that the chairwoman put together is that there's already structure in place, and with all of the stakeholders are here in the room who came together. You'll see this later in my presentation. It's a very complex issue area. So we need to have the state at the table and the counties and a variety of other folks. And it's my commitment. If you want to work on this, I will be ready tomorrow. I'll be ready later this afternoon. We will work on this together, and it's my commitment to work with this committee if there's appetite to work with us on this issue. Thank you.
Thank you for that. Thank you for the clarification. And I just want to go back and just identify that you all did what you set out to do, as each one of the task forces that we've heard from, and that are still remaining to present today, was the first meeting was really about identifying all of the problems that existed within and around the care of our children and families. And there were so many that we created 6 functioning groups working on specific issue areas. Well, yours, as I recall, was to identify where does the funding exist for the child welfare system, which is very complicated and comes from multiple streams. So while I understand that we are not a fiscal committee, but a policy-driven committee, I think it's important that we understand how many multiple streams there are. To the senator's point, I like that we're going to continue to work on this because it is an ongoing issue, and children are born every day. And so we're going to continue to have to address the growing needs of our children who are in the child welfare system. So know that I feel like you've done what you set out to do, and it's just started us on a very long path, which I look forward to continuing. With that, we do have our next question from Senator Titus.
Thank you, Madam Chair, and thank again for the presentation. FMAP is an extremely difficult and challenging concept to understand, and it has been for decades. I just want to clarify, there's been a lot of information in the news of late regarding our significant declining enrollment in our public education. And for example, Clark County says it's lost 30,000 students. I want to make sure, because we're looking at these numbers and you want more money and you need more money for the child welfare program. I just want to maybe put it on the radar that these children are not necessarily leaving our state. And so are you seeing, the question is, are you seeing a decline in the number of children in the welfare system that would compare to the numbers the schools are showing that we're losing statewide, but especially in Clark County?
Senator Titus, Joanna Jacob, JACOB for the record, and I'll take a stab at that one because I'm here from Clark County. I think I want to respond in this way, Senator Titus, and you always ask very thoughtful questions, and I'd like the opportunity to maybe take that back home and see what we're seeing. I think some of that news about the declining enrollment is relatively new. We may not yet know the impacts of that, and I'd like to go back home and report back to this committee. But I will tell you one thing. It is a concern because the schools are important partners to our child welfare agencies. They are where the children are. And when kids are in school, there are additional eyes and supports on those kids. And that is what I want to maybe go home and think about and report back to you on what that may look like. Because I think your point is well taken, is that even if there's declining enrollment in their public school system, the kids aren't leaving the state. We don't know yet the impact of that. And so we can reach out to our school district partners for sure. And then also what we may see, and we may not fully see that until the fall, Senator, but certainly by the time we get to the legislature or legislative session next year, I think we might have enough time. But I'm rambling now. So I guess that was my thought as you were asking that question, is that maybe too soon to know yet, but I'll take the opportunity to go back home and check with my department and see if we have a plan.
And follow up, if I might, Madam Chair. I think, and thank you for that answer, because one of my major concerns is I don't believe we're going to actually see a decreasing population per se. And again, if there's 30,000 children that are no longer in the Clark County school system, where are they and who does have eyes on them? And if the child welfare system is already stretched, how do we know these children are okay? So I really want to urge you and all the agencies to pay attention to that number and make sure that we have some resources for these kiddos, because I worry that they didn't just disappear, they didn't move to other states. And so what are we doing for these kids? So thank you, Madam Chair.
Thank you. Members, any other questions? Okay, seeing none, thank you so much for being here with us today. Thank you for the presentation. That moves us to the next presentation, the intersection of child welfare and school systems and discharge and transition planning for children released from psychiatric treatment facilities. Our presenter today is Senator Shelley Cruz Crawford. She'll be joining us on Zoom.
Thank you so much, members of the committee. Thank you, Chair Brown May. My name is Senator Cruz Crawford, and I am going to be presenting for Task Force 4, Child Welfare and the Intersection of Care with School Systems. I would like to thank everybody that worked on our committee. We had Nevada PEP, Boys Town, SEIU, Senator Don Darrow Loop, Dr. Hermes, Legal Aid, Aging and Disability Services Division, and Nevada Department of Ed. And I would be remiss if I did not thank Davis Florence for all of his background information, and he is going to be here reporting out on one of our items. So I have a very basic presentation. I did send a one-pager over, hopefully you received it. We basically identified 3 issues that we were able to solve within this short amount of time, and solutions for those issues. The first one is the task force found that Nevada Senate Bill 210 that was established in 2021 addressed one of the biggest concerns we had. And that was in regard to when students go into child welfare custody or into foster care or court-ordered psychiatric hospitals or residential mental health treatment facilities, sometimes they lose access to education. And so Senate Bill 210 in 2021 was introduced by Maryland Don Darrow Loop, Senator Don Darrow Loop, and she was part of this information. We found that it was not actually in practice yet. So I'm going to go real quick, a brief overview of the bill, and then Davis Florence will go over where that bill is currently sitting. The bill required a creation of an education plan, and the primary purpose was to ensure that those children did not lose access to education while receiving treatment. Within that plan, it was included that would be addressed how many instructional hours that children will receive each week, transfer of school materials to the facility, monitoring of educational services, compliance with IEP or special education service plans, and a transition plan for returning back to school. So pretty much everything that this whole task force was tasked with was already addressed in a bill from 5 years ago, but is not fully implemented yet. So I am going to take a pause and have Davis Florence share where we currently are with that bill and why has it not been implemented yet.
Thank you, Madam Chair. Davis Florence for the record. So just an update on the component that Senator Cruz Crawford mentioned. The regulations to fully implement that bill are housed in LCB file R131-22. And it is my understanding that that was recently approved by the Board of Education last week and should be going before the Legislative Commission on one of their future agendas. When that will be scheduled, I'm not sure, but it should be coming up soon. And for the specific details of that regulation, I can't speak to that necessarily. There may be stakeholders or subject matter experts that can talk about that component, but the regulation should be going before the Commission here shortly. Thank you, Madam Chair.
Thank you so much, Mr. Florence. So we are closely monitoring that situation, providing public comment and supporting to make sure that gets through. It is shocking that something that we are dealing with and still created a task force for has not happened 5 years later. But I'm learning as a new legislator that after we pass bills, they don't just come into place magically. We need to keep supporting that through. So that was problem number one. Problem number two that we discussed was that we reviewed practices of other models from states that were successful in centering strong partnerships with wraparound services to improve that school to home alignment. And one of the people that we had on our task force was John Etzel from Boys Town. And he shared that Boys Town is a great resource in regard to going to homes and helping with a 7-week treatment plan with parents to help with those transitional services. He also stated that they have services when they are gone at those treatment facilities to prepare those homes. And that is a partnership that CCSD already has. He also has access to national wraparound services that do similar models and is able to present additional findings as requested in order to look at models that work. Our last item here was last session, I carried a bill for a no eject, no reject. That was a Nevada Senate Bill 306. And we were looking at, it was recommended that the task force look into this. We did get some recommendations, but rather than having it be a committee bill, I'm going to continue to work on this next session with stakeholders. So I will be carrying this bill. So I took that off the task force list, but used the resources from the input from the task force. I know this is a very brief presentation compared to everything else. I am on work. This is my lunch break. I'm running the office by myself. But I think that the biggest outcome that I wanted to share is that this task force was tasked with the intersection of care with school systems. And I talked to Commissioner Justin Jones last week that had the privilege of doing a tour with CCSD at Child Haven. I also was a part of that tour. And one of the biggest concerns there were that the students were not getting the academic education. High school students were not getting credits. And now that we have pre-K available, they don't have any licensed teachers on staff that are able to teach pre-K. And a lot of this is solved with a bill that was written 5 years ago. So I really believe the task force work is going to make sure that we continue to make sure that this policy becomes practice before next legislative session. And so with that, I will yield to questions.
Thank you, Senator, for the presentation. Thank you for joining us on your lunch break and for staffing your office. Members, are there questions? Thank you. I don't see any. Thank you so much, Senator, for your presentation and your concise work on this matter, and knowing that we have to continue to follow that previous piece of legislation through to its conclusion. So thank you for joining us today.
Thank you, Chair Brown May. I teach elementary school. I know people don't listen for more than 5 minutes. So I hope you enjoyed that brevity.
Thank you. You got a laugh in the room, so I'm saying that they were listening to you. With that, we'll move to the next presentation, Child Welfare Statute and Regulation Review and Cleanup. We'll welcome back Ms. Joanna Jacob, again, Las Vegas Government Affairs Manager with Clark County.
Thank you, Madam Chair. I'm going to try and take Senator Cruz Crawford's advice to heart here. I'm just going to try and locate my slides if you'll give me 1 second. I can't. There's quite a number of presentations here, so once I'm sorry, I'm not going fast. I actually am not seeing it, Madam Chair. I don't know. I know it's probably here. Maybe Mr. Florence is going to help me, but I'll just let me get started because I know we are approaching the noon hour and you might want to go to lunch. So you don't need the slides to say this. It's actually 40. Thank you. Yeah. I chaired the regulatory and statutory cleanup chapter, which was like recognizing the fact that there's been federal changes and multiple things, and statutory cleanup is always a challenge in the legislature. We may have to go back and look at things as they go forward. This task force was comprised, this is my slide too, if you want to go back and look at it later. We had representatives from DCFS, Clark County, Washoe County, the Washoe and Clark offices of the district attorney, legal aid representatives from North and South, and various service providers that came in and out as thank you, Mr. Florence. I know, there we go. I hope you can see my slides. Now that this is my overview and who was involved in my regulatory and statutory cleanup committee, Madam Chair. So I'll move on to slide 3. The benefit of this group is, and can you see slide 3? Okay, great. We had a number of meetings and we talked about a lot of issues. The benefit of this group is that a recognition that we don't need a bill for everything, and cleanup may occur through a regulatory process or just a matter of communication in some ways. The first one I will just list here. This was a very positive outcome of our committee, and with the assistance of Chair Brown May, who reached out to her legislative groups. I think it was NCSL or I think it was NCSL that we've discovered that a mutual commitment from the state and the counties to work on a cross-border agreement. This is a model that exists in other states, and this would be a tremendous help for us. And no good news to you, no legislative authority appears to be needed to enter into this agreement, but what it would do is allow us to partner with California, Arizona, our border states, and while we are working through a process known as the Interstate Compact on the Placement of Children, it does delay having kids travel to, like if a grandparent lives in California, there's a process that we have to go through under that Interstate Compact. This would allow us to immediately reunite the family while we were working through that. So thank you, Madam Chair, and we're moving forward with that. There was a discussion very much in the news on foster home audits, and we mutually agreed, like, we need to work together on the enforcement of standards that are already in place. And then I just wanted you to know that, because you may be wondering, what did you talk about? This is why I have this slide. The third thing was a recognition that maybe we need to revisit the concept of mental health holds for children. I've listed some of the things that the group discussed. We need clear guidelines, transition for care, how and when are the agencies involved? But we recognize this is a much bigger policy consideration and fell outside of our working definition of cleanup, which is really what it sounds like. It's supposed to be a simple change that meant to align with current practice or federal guidelines. I will note here, there's a lot of people that work on child welfare policies, and this last one, if there's interest on this one, may be a topic that's taken up through other vehicles, including the court improvement program that works together on these issues, and they are currently working on their bill ideas and that process. So you may see it. So I'll go to our recommendations, and I will say I work for Clark County, but these were joint recommendations from everybody who was all involved in our committee. The first one is a workforce bill. We talk a lot about workforce updates to our statutes, and really I've listed here, there is a statute about mandated substance abuse evaluations in the court when a child is involved in the court process. It lists out certain providers that can perform those evaluations and left out social workers. So we would like to add social workers to this statute, licensed clinical social workers. And the statute talks about interns if they're operating under the scope of the internship, and that is our first recommendation. It would certainly help us to find providers to perform these evaluations in the court process. Recommendation number 2. Okay, this one is a bigger one. The big statute that governs child welfare is NRS 432B. This was something that came up through members of the group that talked about some of the provisions of 432B about who could share information. We may need to look about it. Generally, and I always like to put this on the record, when you enter the child welfare system, you are entitled to confidentiality. Confidentiality about your involvement, who's involved, the reasons for that, why you are involved, until the case is closed. And then there are limited exceptions to that. It's very, very strongly protected information. And we talked about it as the proposal would clarify that within those limited exception process that we would be allowed to share the information with an adult child, so someone who was involved in the system, who was the subject of the report, or with a non-offending parent. When I say non-offending, it could be like they're not the one who's being investigated in the child welfare system. And the disclosure will be limited to the nature of the report and safety issues. It also clarifies the information under the proposal would clarify the information could be shared with law enforcement or prosecutors, regardless of whether the perpetrator is a caregiver. This is something that is in the statute that we think warrants taking a look at. But important, and then last bullet, this was really a mutual decision that we have to maintain the standards in place, that we need to protect the identity of mandated reporters and subject the disclosure that we're proposing to reasonably necessary standard. So reasonably necessary for the purposes of the individual or entity, meaning we have a standard in place. This is my last one, right? We are coming in with 3 recommendations, and this is about background checks. So there's a statute, NRS 179A. Oh, I just realized in the previous slide, let me go back. I talked to the state also. There may be some other things we need to clean up in this statute. I will just say that there are always things that we find that we need to update on federal definitions. And so this is when I talk about a general NRS 432B cleanup is something that we could work on if there's interest here from the committee that we could work as we move towards the August deadline. Going on to my third closing thoughts. My third recommendation also here, these are preliminary recommendations. We might need to do some other cleanup in here because the statute on who can request background checks is NRS 179A 100. And there's a whole list of agencies that can request background checks. The statute right now is limited to, for our purposes, to child welfare agencies, ADSD and DHHS. Might need to take a look at that and see if we need to adjust it for the reorganization of the state government that happened last session with the Nevada Health Authority. But for us too, as Clark County has brought on new departments, we brought on a new clinical division, and a lot of our Clark County funded housing programs are now, we're shifting who is involved in that. And that would, the purpose of this language in the fourth bullet below is that we would permit an agency of a state or local government, and this mirrors the statute language, delivering services for the health and welfare of children and families, or our designated representatives. So to request a background check as needed to protect our workers and our caseworkers, clinicians and caseworkers, and to screen applicants for housing with written consent. And that's really so that if we're going to put a family into Clark, for example, into a Clark County funded housing program, that we're screening the family and the people who are there for the safety of the family themselves and the other families served in those housing projects, housing programs, excuse me. And we kept it broad because Clark County has a clinical division, but there are probably other counties, agencies who are looking at these models, especially as we're looking at prevention services. So that's my third recommendation. Here are my closing thoughts. This was really a group effort with a lot of different stakeholders. And I really want to say here and reemphasize that there's a lot of, this is a highly regulated area. We always probably can find cleanup and that is necessary. And there's a mutual commitment to keep working on this. And if the committee would want to work on any of the three recommendations, we're coming kind of like with a nice present, cleanly wrapped for you, because we have had everybody involved, the state, the counties, and a lot of the stakeholders with a commitment to keep working on it. And we thank you for your time.
Thank you for your presentation. Thank you. Members, questions? Okay, seeing none, thank you so much for that and your concise recommendations. We will now move to the final task force presentation before we break for lunch, which will be a short break, just so you have an idea of what's coming up. We will officially welcome to the table Jenny Fay, the Community Engagement and Development Director at Olive Crest, to discuss diverting children from child welfare and root causes for children entering the child welfare system. Thank you so much for being here. You may begin when you're ready.
Thank you. I'm Jenny Fay with Olive Crest, as Chair May has said. I'm just looking for my PowerPoint here, as everyone else has when they've come up. And as I get started with this, just quick show of hands, any hikers among you? Anybody hikers, nature lovers? Okay. Well, years ago, a guy named David Aylward from the University of Colorado, their School of Medicine, he painted a really vivid picture of upstream prevention and kind of this analogy with a river and a waterfall and hikers. And so if you are not familiar with it, I would love to just really briefly give you the gist of it, as it kind of sets the stage for what this task force has been working on. And the idea of it is there were some folks who were out hiking. They came across a river. And as they looked at the river, they saw a bunch of people struggling in the river, about to drown and being swept over a waterfall, being swept to their death. And so one hiker looks at this, they jump in the water and they start trying to save people from going over this waterfall. But they're realizing, like, as soon as they get them on the shore, some are slipping back in the water, more are coming down the river, and they just can't seem to make the difference that they're hoping to. Another hiker's looking around for branches or boards or whatever they can find to extend to the people in the water to help get them out before they fall over this waterfall. And one of the other hikers decides to go upstream and figure out, how are these people falling in the river in the first place? And how do we stop that from happening so that they never end up flailing around in the river and falling over this waterfall to their death? And that is essentially what this final task force has been about. As you can see from this picture, the idea of by the time that they get to the bottom of that waterfall, that's where these families have already got a CPS investigation going on. That's where kids are already in foster care. That's where there's all sorts of involvement. And you've heard today a lot of the things that are needed when children enter into the child welfare system. And what our task force looked at was, how do we keep these kids from going into the system in the first place so that a lot of these supports and services aren't as necessary because we've addressed the issue up front. If you want to create lasting change, we have to address the root causes. And that's what this task force has been about. We are not advocating for children to stay in unsafe environments. We're advocating to address the root causes of those environments so that they can become safe through real resources that solve real problems that families are facing. And before we jump into the three main focus areas that our task force looked at, I just want us to wrap our heads around some facts, some ahas that our task force had. And so some of those are some grim statistics that you're probably all familiar with, but they're really important for us to think about as we think about our kids and families in our state. Nevada ranks 46th in child well-being. Nevada ranks 51st, the last in the nation for mental health. And children's mental health needs are the leading factor in our ranking this low. According to Nevada's Children, the 2025 fact sheet, in 2023, there are about 6,500 child victims of abuse or neglect. But interestingly enough, there's a pattern throughout the years that is confirmed actually just by the DCFS data book that was published in May, looking all the way this fiscal year through March. 90% of maltreatment associated with the screened-in reports, it's related to neglect. So, and this has been pretty consistent throughout the years that 90% of those reports and removals are actually for neglect. And then along with these facts, our team just had some ahas as we were looking at this and interacting with the community on it. One of the things that we realized is there are actually some good resources available in Nevada. It's just that often maybe people who need those resources, they don't quite meet the criteria for those resources, or the people or providers who are working with those families don't know that the resources exist to be able to help families access them. There's not always alignment or cohesion or awareness when these resources are available. We also had the realization that was mentioned earlier, the impacts of HR 1. While other states are stepping in to fill the gaps, Nevada has fewer options to backfill these reductions, which means the impact is felt more directly by our kids and our families. We also noticed as we just had conversations with the community about things that we were working on, we realized there were many others in our community who were noticing these same trends and these same needs. And so as you're sitting there today, you've probably already heard some common themes. And as you continue in the day, you'll probably continue hearing some of those common themes, even from groups that are from different sectors in our community. And so as our task force looked through these things, we listed out a myriad of root causes for children entering the child welfare system. And then we narrowed down that list to three main focus areas, which are in alignment with the strategic plan for the prevention of child abuse and neglect in Nevada. We narrowed it down to poverty. Remember, neglect that I just mentioned, there's nearly 90% of maltreatment cases in our state. Neglect is most directly tied to poverty. We narrowed it down to mental and behavioral health. Parental behavioral health issues are common risk factors for child welfare involvement. And among Medicaid enrolled youth, children involved with child welfare are nearly 3 times more likely to receive behavioral health practitioner services. And then our third focus area was access to supports. Even with the Title IV prevention services funded under Nevada's Family First Prevention Plan, eligibility is generally determined through the child welfare system, making those supports available only after a family has become involved with the child welfare system. So for each of these focus areas, we have a couple of legislative suggestions, recommendations for you all. As we looked at poverty and we thought about many people come into contact with the child welfare system not intentionally neglectful. I've worked with kids and families for a lot of years. I don't think I've ever met parents that woke up in the morning and said, hey, today's the day I'm going to abuse and neglect my kids. I think I've met a lot of parents who woke up, took a deep breath and said, at least I'm doing better than my parents did. And a lot of times they are, but that doesn't mean that the home is safe and stable. These are parents who are exhausted, they're isolated, they're out of options, they're working 2 jobs with no childcare, no margin for error, and they're often one eviction notice or one missed utility payment away from losing everything. So with that in mind, we suggest childcare supply and workforce expansion, addressing some of those zoning barriers, expanding licensing reciprocity, supporting non-traditional or off hours for childcare, as well as expanded school, out of school time and pre-K. These things that contribute to the lack of childcare available in our state, which directly contribute to instability and poverty in the families in our communities. We also recommend a flexible family economic stabilization fund to help with some of those basic needs before families are referred to CPS. So rent assistance, utilities assistance, childcare subsidies, and things like that. Some of the benefits of this will be investing in childcare and flexible family economic stabilization funds. This delivers measurable cost savings for states. We see that for every additional $1,000 that states spend, it's linked to a 4 to 7% reduction in maltreatment reports, substantiations, foster care placements, and fatalities, showing that when we invest upstream, it pays dividends in the long term when it comes to state budgets. And another benefit is stable childcare enables stable employment, which is one of the strongest protective factors against neglect in child welfare involvement. For that second focus area of mental and behavioral health, we looked at the fact that behind most child welfare cases involving mental and behavioral health, there's a family that needed help long before they encountered the system. There's maybe a parent who's struggling with depression or anxiety or substance use and who just can't get into an appointment for weeks or months to address that. Or there's a child with significant behavioral needs whose school doesn't have the staff support for them, or their parents just don't know where to turn with those mental and behavioral health needs. So for us, our couple of suggestions or recommendations would be expanded Medicaid and private coverage, ensuring all payers provide parity in mental health services with a focus on preventative, family-centered behavioral health services, especially those delivered in schools, childcare settings, telehealth, and in homes. And then our second suggestion is provider workforce and licensing expansion. Being able to identify those barriers or streamline credentialing and licensing for providers, expanding our retention incentives, continuing to successfully implement SB 165, continuing to improve those reimbursement rates. And some of the benefits with this would be parental mental health and substance use are among the top drivers of child removal. So early accessible treatment keeps families intact and reduces the number of cases that escalate to CPS involvement. Additionally, more providers means earlier access, which means families get stabilized before they enter into the child welfare system. And for our third focus, access to supports. Like I mentioned earlier, we recognize that Nevada has some resources. What it lacks is a way for families in crisis to find and access them. So by the time most families encounter substantive services, a CPS report's already been filed or that crisis has already occurred. So our suggestions would be Reporter Supporter Training Act. Expand training for mandated reporters on when and how to report, refer, and provide those community resources. We also recommend expanded in-home family stabilization, increasing funding for in-home training and resources for families that need supports, with the goal of diverting those families from any or further child welfare involvement. And some of those benefits would be that approaches to train community touch points as active connectors, maybe not even just mandated reporters, they can reduce family disruption while still maintaining child safety outcomes. And the institutions that see families every day, they're the most efficient and trusted points for early intervention if they're resourced to act. Another benefit is that a lot of this would be eligible for that 50% federal match under Family First. So significantly less costly than kids going into a foster care placement, with documented outcomes showing reduced maltreatment, improved parent-child relationships, stronger long-term family stability, all of those things. So in short, the question isn't any longer whether we know what the root causes are for child welfare involvement. As we talked as a team, we know what a lot of those root causes are. Now the question is whether we're willing to invest upstream where the impact is greater and the outcomes are better. And I want to take a moment to thank you all for your time. I want to thank the task force who met month after month, brought their ideas, met with others, grateful for everyone's impact in this. And you have the slides in front of you. If the outline with some of the documentation would be helpful, that's also available as well. And I'll turn it over for questions.
Thank you. Thank you for your presentation and the concise nature in which you shared the information. I would like the documentation to back up with some of your notes. That will be helpful for me personally going forward. Members, any questions? Assemblymember Edgeworth.
Thank you so much for your presentation and how colorful and interesting it is. I like it very much. Very important information. I have a question about right after the waterfall, the next slide that talks about us being 51st in the country for that's appalling. I'm curious about the number of an increase of 10%. I think we talked about how there's probably not an increased population of kids. So do you think it's more attributed to increased reporting or literally more abuse?
I'm going to invite any of the task force members up to help answer any of these things. One with that to note is that while that statistic came from like the 2025, it was actually reported in 25, it was about 2023. So it was technically 10% increase from the year before. Sorry, just getting dates straight. Honestly, I'm not sure. I'm not sure if it just means, hey, we were still coming out of COVID. And so these kids and families were returning to more of the places in the community where folks could have eyes on them. Because you may remember, it seemed like CPS reports actually dropped during COVID because people weren't encountering anyone who might be able to see that something was off and make those reports. So it could just be a continued trend out of that. It could be COVID fundamentally shifted some things within our society, and isolation has increased drastically. And according to the CDC, one of the leading causes of neglect is isolation. So with that being more prevalent, maybe we shouldn't be surprised if we see more of these isolation cases. So all that to say, many reasons why maybe. I don't have a definitive answer on why.
Thank you. A quick follow-up? That's good information. It sounds like you're leaning towards there being more abuse that's happening. And I, as a mandated reporter myself, I'm curious to know if we're doing a better job of training people to report, but it sounds like it sounds like there'll be even more reporting if we do a better job of training. That sounds like where you're headed. Is that accurate?
Potentially, although I believe looking at if we can address some of the other root causes, then perhaps families could stabilize before intervention would ever be needed on that front, if that makes sense. It would never get to the point of crisis where a mandatory report would need to be made. That would be the ideal world. That's what would happen.
Thank you very much.
Thank you. Okay, seeing no other questions, thank you so much for being here and for your presentation. That officially wraps up the task force reporting and that agenda item. It is now 12:16 and we are scheduled to break for lunch. So we're going to take a quick 30 minutes. There is a coffee shop next door in the main legislative building. So anybody who needs lunch, we'll be back in 30 minutes on time to start the next agenda item, which is agenda item 5. Okay, so quick 30 minutes. Thank you, members. Okay, welcome back from your quick break. We will now move into agenda item 5, update on the status of the Nevada Child Care and Development Program. We welcome Mr. Robert Thompson, Administrator of DSS, Maria Wortman Meschberger, Agency Manager. Thank you so much. You may begin whenever you're ready.
Good afternoon, Madam Chair and Committee. For the record, my name is Robert Thompson. I'm the Administrator for the Division of Social Services. And I have with me today our Agency Manager over our Child Care Program, Maria Wortman Meschberger. We have a presentation to give you, and while we're showing that the slides are 24 slides, it is not that much in content. A lot of these slides are quick pictures, so we will get through this and try to leave the substance of the presentation open for questions. So our agenda today will be an overview of the Child Care and Development Program, the application process, how COVID really changed the face of our child care program, and the challenges of returning back to pre-COVID funding with post-COVID rates. And that's been one of our largest challenges. So an overview of the Child Care and Development Program. Our Child Care and Development Program is broken down into 3 parts. Our Child Care Subsidy Program provides for safe, high-quality childcare and makes early childhood education more affordable for parents who are engaged in allowable activities. Those allowable activities are primarily work and education or looking for work. The subsidy program provides payments to providers to assist eligible families with childcare costs, and we have licensing under us. Childcare licensing, their primary purpose of that unit is to protect our children by enforcing health and safety standards and ensure the environments are safe for our children. And the third component of our childcare is quality. The quality supports quality improvement activities that benefit children in childcare settings. These activities aim to elevate safety standards, promote healthy development, and create enriching environments that foster the children's potential. I think it is important to note that we are required to dedicate 12% of our block grant of this program into quality. So when we start talking about our application process, I'm going to turn it over to Maria. She's embedded in this every day, and she will go over our application process and our efforts to reduce our backlog.
Good afternoon. My name is Maria Wortman Meschberger, Agency Manager for the Division of Social Services. When someone needs to apply for child care subsidy, they can apply through the Access Nevada portal by mail, email, fax, or they can also drop off an application in any of our offices. We also receive referrals from Child Welfare Agency or from our internal NEON team. So once we receive an application, we register it, we assign it to a case manager, review available systems to gather any information. If we already have it, we'll go ahead and make a decision. If we need additional information, we will mail a request for information. Once we receive everything, we are able to make that decision. So between January of 2025 and May 31st of 2026, we've received about 15,500 applications for service. Our average processing timeframes right now are at 65 days. And as of June 8th, we had 2,385 cases that were on the wait list for families. And there are 20 full-time employees dedicated to application processing.
So when we look at our child care program, we do recognize the COVID event really changed the landscape of child care. And the American Rescue Plan Act, ARPA, changed the funding that came in, which altered everything that we did at that time. So the child care funding runs at approximately $112 million right now, but during COVID, we were receiving over $500 million in the funding. Now, the $500 million did not go directly to children. Approximately $285 million of that was infused into the providers so the providers could stay open. When children weren't going to childcare, they weren't attending, the intent was that we didn't want those provider facilities to shut down so they could still be there when the economy opened back up. So the next slide is just a snapshot that shows our administrative costs over the years, just to give a visual of where we've been at in each fiscal year. The next slide shows the number of children served for our programs, and we can see that our most expensive years did have the least number of children there because of the COVID event. The average monthly benefit in our programs increased during COVID, but when we reversed our program and started sunsetting the ARPA money that was coming in, we recognized that we could not move our rates back to the pre-COVID amounts. We must support our providers with the benefit amounts that they need today to run their facilities and pay their staff, acknowledging that we are using the total amounts of money that came in prior to COVID, and those amounts have stayed flat, which means we are able to serve less children now. In returning to the pre-COVID amounts, we had to adjust our income eligibility limits. We had to reinstate family co-payments. We had to reestablish wait lists, and we had to start paying attendance based on approved schedules. Make our payments based on attendance rather than on approved schedules. During the COVID event, we had additional monies. We were able to increase funding. We were able to pay when children weren't attending their childcare, but now we've had to reverse that back. So one of the questions we were asked is, how do we determine policy changes? The primary thing that we have to do when we are making policy changes is align with the federal policy. This is federal block grant and the monies come from the federal government. Therefore, we do align with federal policies. We have to align with our licensing requirements, and we have to align with our current funding. We have less funding per child than we've used to have, and we have to make those adjustments. I think Senator Donate said that earlier, the monies are finite and we have to make difficult decisions, and we've had to make those decisions. When we do amend our state plan, we do allow for public comment and we do allow for public input. We have been meeting with our providers. We have made some adjustments because of that input that we've had, but some of the decisions we've had to make were difficult. When we're communicating those program changes, our communications aren't any different than any other agency. We use email, listservs, mail, social media, webinars. We engage in the child care resource and referral services and press releases. We have a great public information officer, and we have a dedicated public information officer for the child care program. The challenges that we've had in this program right now, our primary challenge is our system limitations. The computer system that we are using is simply outdated. We were moving forward to engage in a new computer system. We recognized at the very last minute that the computer system that we were going to go in to purchasing with a new vendor was going to be outdated by the time it rolled out. Technology has changed, AI has come into the picture, and we, at the very last second, pulled that contract away and has started over. Because we had to start over with the system limitations that we have had to move back into manual processes. We have borrowed staff from what I'll call on our eligibility side of the house. Our caseworkers that normally process the food stamps, cash assistance, Medicaid eligibility, there are approximately 1,250 of those workers, and we've borrowed approximately 25 of them to assist in these manual processes. That is temporary. We do not plan on using them long-term, but once we are able to get the systems up and running, which will be our entire focus in 26 and 27, the plan is for those staff to go back to processing the other programs that we have and have a robust system that will do much of this automated. So our backlog reduction efforts, we have seen just in the short time, Maria's been with this team for approximately 8 months. She came to us internally. She's worked for the Division of Social Services for many years. She was the lead chief over our energy assistance program when energy assistance was having backlog efforts. Because of the work that she did over there and the success that she had, we asked her to join this team as the agency manager, and we were lucky enough that she did take this position. And now she is using the same ideas and the same methodologies that worked previously in our agency to now reduce the backlog efforts here, targeting our system improvements, pursuing long-term system modernization options, standardized practices. When we say hiring additional staff, they were not permanent staff. Like I said, they were borrowed from other parts of the agency. And we've even gone as far as we have one of our large district offices. We took all of the supervisors in that team and we trained them in childcare so that when we go through periods where we have the influx of applications or high vacancy rates because our staff have promoted and moved on, and that did happen, we now have resources that we can shift from other parts of the agency for short term while Maria's rehiring her staff. The results of this work have shown, they are showing. In March of 26, there were 7,045 applications pending, and at this time, as of yesterday, I think it's gone down a little, but when we put the presentation together, it was 2,796. There is a significant reduction in our backlog, and we are moving it in the right direction. The next slide shows the pending timeframes for these applications. Ideally, we don't want any applications pending over 30 and 60 days, but we got behind in our work. We hit bumps in the road, and 64% of our applications were pending over 60 days, and we've reduced that to only 40%. I would like to point out that just because an application's been pending over 60 days, it does not mean the agency is behind. Often we do give customers allowances when they have asked for additional time to provide verifications that we need. So sometimes an application over 60 days has been a client request. And we are now open for any questions.
Thank you. Members, questions? Go ahead, Assemblymember Hibbets.
Thank you, Chair. I'm going to take you all the way back to slide number 9. I'd like a little bit of clarification if I might. And you don't have to flip the thing on the screen if you don't want to. It's the child care funding where it shows that in fiscal year 21, obviously that was during COVID, you guys got just over 500 million in funding. And you said, and correct me if I'm wrong, I want to make sure I heard this properly. You said that 285 million of that went to children and the rest went to, or am I getting that backwards?
Robert Thompson for the record, Assembly member through chair to the Assembly member. That's backwards. It was 285 million went to the providers to shore up the providers. It was approximately 285 million of the extra monies that came in.
Thank you. Follow-up, Chair? Isn't that what PPP loans were for?
Robert Thompson for the record, we did not deal with PPE loans, Assembly member. I could not comment on that. We were providing dollars that came in from the child care subsidy and the additional funds that came in from the federal government. Some of those funds were ARPA dollars that went to the state of Nevada that the state determined for us to give out. So some of them came directly from the federal government with the requirement that we used it for childcare. Some of it was determinations made by the governor's office and legislature for us to use it for that purpose.
Yes, please. Just so that I understand, because I was not in this position in 2020, 2021. There was a federal program called PPP, and forgive me for not remembering exactly what that stands for. But the purpose of that program was for employers, such as childcare providers, to apply for loans in order to keep their employees employed and their businesses afloat while we navigated the pandemic. And now we're hearing that $285 million of state money was used for the exact same thing. Am I getting that correct?
Robert Thompson, for the record, Madam Chair, through you to the Assembly member. I was not in this position either then, Assembly member. I am working off old notes. I could not comment on what the PP dollars, how those were used. I did go through the previous paperwork and how the dollars were spent and meant to be spent at that time. And all I can tell you was these dollars were used for those purposes from the child care monies that came in.
If someone in your office could look back into the records, because I know that the state government is required to keep records for a certain amount of time, if we could get some follow-up on that to the committee to figure out where this money went and why it went there, that would be wonderful. Thank you.
Robert Thompson, for the record, we will do that, sir.
Thank you. Members, any other questions? I do have one, and perhaps it's for our agency manager. So first, thank you, welcome. Administrator Thompson talked a bit about the computer system that we thought we were going to move forward to, that we didn't move forward to, that we're now trying to navigate. We're in the middle of a manual process right now. He noted how talented you are at sort of this transformation effort. I'm curious to know if you could just talk us through a little bit about what does the technology transition look like for your division currently? How are we decreasing? Obviously, your waiting lists are going down, but when you are that person that needs childcare assistance, right, every day is essential, especially if you have employment. So I'm curious to know, how is the technology rollout and transition that you're overseeing going to affect your wait list until and unless we get to utilize technology and not mail to somebody's personal mailbox for data?
Maria Wortman-Meschberger for the record. So currently we are in a very manual process with spreadsheets and the antiquated system. So trying to do case management is challenging. With a new system though, we will be able to not do that anymore and manage system, our workflow that comes through easier and more efficiently, as well as allow our staff to process cases more efficiently.
Thank you for that. Do you have a time frame as to when you will incrementally add cases to a technological system as opposed to having everyone on this system that we can just expedite processing?
So currently we're looking to hopefully we're going through the procurement and doing all that right now to get a new vendor. Hopefully we'll have one selected in early next year.
Thank you. So then what I hear you saying is that we're going to continue to augment this process with humans and not with technology until we have this new vendor identified.
Yes, that is correct.
Thank you. So I would just then ask you for one consideration as you move through this process, and that we perhaps as a state could look at a system that is successful somewhere instead of trying to build something wonderfully unique that then can't be supported long-term, right? Like maybe we could just buy an off-the-shelf program that works somewhere so that we could deploy it quickly to serve Nevadans. Yes, thank you. Members, any other questions? Okay, seeing none, thank you so much for your presentation. We appreciate you being here. That will move us to the next item on our agenda. I will welcome the Children's Cabinet, Kim Young, CEO, and Marty Elquist, the Chief Programs Officer. I understand we have a Northern presenter as well as a Southern presenter. No, we're both Southern. Okay, super. Thank you. Welcome. You take your time. You may begin whenever you're ready.
Chair Brown May, members of the Joint Interim Standing Committee on Health and Human Services, and guests, thank you for the opportunity to be here with you today. My name is Kim Young, and I have the privilege of serving as the Chief Executive Officer of the Children's Cabinet. And with me today is Marty Elquist. She's our Chief Programs Officer. The Children's Cabinet Foundation is our public-private partnership model. We work alongside families, community partners, and state agencies to keep children safe and families together. And we've been doing this work for over 40 years. We are committed to helping Nevada children and families succeed through access to resources, services, and supports that strengthen family well-being and economic stability. We are funded by over 50 federal, state, county, and philanthropic grants and have a team of 250 staff members to carry out over 45 programs. Our programs are focused on early education, childcare providers, families, and children prenatal up to age 24, all under a single mission to keep children safe and families together. Half of our programs are focused on the early education development period using a 2-generational approach to support both families and their young children. The Children's Cabinet is a statewide organization. We have more than 10 offices located across Nevada, including Washoe County, Carson City, Fallon, Elko, and Clark County. We appreciate the committee's continued focus on Nevada's child care system and the vital role it plays in supporting children, families, employers, and our state's economy. Today's presentation is a collaborative effort between the Children's Cabinet and the Division of Social Services Child Care and Development Program team. Thank you for your leadership and for your interest in ensuring Nevada families have access to affordable, high-quality child care. And with that, I will turn this over to Marty Elquist, our Chief Programs Officer. She will give you an overview of our child care subsidy programming.
Good afternoon. Thank you so much for having me, Marty Elquist, for the record. I'm going to talk about our subsidy services for which we partner with the Department of Social Services. We have provided this partnership for over the last 30 years. And we do not do subsidy administration, which includes determining eligibility for families and provider payments throughout the state of Nevada, but we do service 14 of Nevada's 17 counties, so all the counties excluding Clark, Lincoln, and Nye. For our subsidy eligibility case management that we provide to low-income families, we really strive to ensure success of our families on the program, as well to assess their additional needs, through which we provide wraparound support services on these families' path to self-sufficiency. An important component of child care subsidy is recognizing that traditional licensed childcare does not work for all families. Many of our families also rely on family, friend, and neighbor provider support, for which we provide enrollment and support to these providers. These providers are legally operating, but they are not licensed. This supports the Child Care and Development Fund's philosophy in a parent choice model, because for far too many families, they cannot find licensed care that meets their family's needs. They must rely on their family, friends, and neighbors to accommodate their work schedules, transportation, and/or financial needs. These providers themselves must also be supported beyond program eligibility and compliance, as many of these providers also face the same socioeconomic challenges as those receiving child care subsidy assistance. Statewide, we also provide Child Care and Development Fund services through our partnership with the Division of Social Services. Statewide, we provide child care resource and referral services to any Nevadan searching for child care. We help educate families on what quality looks like and how they can find it, and why that is so important for their children's development. Statewide, we also provide case management for families who are receiving subsidy on the wait list, And those who meet their federal eligibility financial threshold of 85% of state median income. But it's important to note that right now our state can only serve up to 41% of state median income. So if a family earns 42%, they don't receive child care subsidy assistance. Many of these families have critical needs that must be addressed that we can help support them with through our wraparound case management. Statewide, we also provide licensed child care provider subsidy program enrollment, training and support, and how to navigate child care subsidy and the requirements of that program. We provide market rate surveys throughout the entire state to understand the price of care and the difference between the price of care and the true cost of care. That gap is steep. The true cost of care, what providers need to earn to keep their businesses afloat. We also produce Nevada child care fact sheets to talk about the supply in our state, the demand for care, the quality of care, and the affordability of care. We have multiple programs to support child care provider quality improvements that will not be discussed today, given our time constraints. That presentation alone would be at least a half hour, so you're welcome. Next slide. So for the Children's Cabinet's service delivery area, that's 14 of Nevada's 17 counties, families can apply through a variety of ways. They can come into any of our multiple office locations that Kim described. They can apply through Access Nevada. They can email us at subsidy@childrenscabinet.org or through regular email. We definitely prefer and encourage our parents and clients to apply in person. When an application is received, our subsidy program assistant will complete this pre-screening within 1 to 2 days of receiving the application and either approve or deny through pre-screening. If the application is denied because they do not meet income or other eligibility requirements, the program assistant will send the client a notice of action indicating that the application was denied and the reason for doing so. If the pre-screening is approved, it will be forwarded to a case manager who will then schedule an intake either in person or over the phone, whatever the family's schedule will accommodate. This intake appointment is made within 10 days. Although a recent policy change no longer requires an intake appointment with the family, the Children's Cabinet still upholds the philosophy of the Child Care and Development Subsidy Program as a self-sufficiency program and not a benefits program. To help support families on their path to self-sufficiency, we assess the additional needs of the family. We do this during the intake and refer families to additional resources and services, many of which we provide at the Children's Cabinet. We not only connect these families, we follow up with the family to make sure that they are successful in obtaining those services. And if not, we document what those challenges are. The Children's Cabinet exists to fill gaps in our community. So doing that analysis is critically important for us to achieve the mission of the Children's Cabinet. Since intake assessments are not a requirement, the family may opt out of the additional needs assessment, and the needs assessment cannot uphold the eligibility decision for childcare. During the intake, our case managers will discuss all verifications needed to make an eligibility determination. If items are missing at that time, the case manager will issue a request for information, as Maria discussed, for the missing items and give the family 10 days to submit the information. Once the information is received, our case managers have 10 days to process the case. The case manager also sits with the family and reviews the client service agreement so the family understands their responsibility on the program. Once the case is approved, our case managers will send a notice of action to the family along with the certificates and a copy of those certificates to the child care provider. Per this child care state manual and our scope of work with our DSS partners, eligibility decisions must be made within 30 days. Additionally, in Southern Nevada, we identify those who need case management support through those who walk into our Green Valley office just right down the street, and they inquire about their child care subsidy application status. Due to data system constraints that were previously discussed, we cannot view many of the records for clients who are on the wait list in Southern Nevada and to support them with their status. Additionally, DSS is actively cleaning up the Southern Nevada waiting list, as you previously heard. And we do work with our DSS partners to make plans eventually so they can share that list with us so we can actively make calls to those on the waiting list to help assess their needs and support them with wraparound case management. Our DSS partners are also creating a referral process to refer families who may need additional services for those that apply directly through them. Our child care children's cabinet team employs 14 subsidy specialists, 2 subsidy coordinators, a training coordinator who also assists as backup, and the program support specialist who helps with pre-screening. For our child care providers, our provider success staff checks the state licensing portal every single week for newly licensed providers. Our team reaches out to all new licensed providers across the state and discusses all of the quality programs and supports that the Children's Cabinet offers. If a provider decides, a licensed provider that is, decides that they would like to participate on the subsidy program, the provider is connected with an R&R specialist who will register them on the child care subsidy program. The R&R specialist also reviews program guidelines, how to submit timesheets, and other additional training. Once the registration is complete, the R&R specialist inserts them into the Nevada child care system, which is the antiquated data system that was previously discussed, and notifies staff that the provider is now an active provider on subsidy. For family, friend, and neighbor providers in the Children's Cabinet's service delivery area, those 14 counties, when the family notifies their case manager that they would like to use a family, friend, and neighbor, the case manager schedules a registration with the R&R specialist and notifies the client of the FFN eligibility requirements and the additional documentation they'll need for registration. At the time of registration, the R&R specialist reviews the program guidelines, assists the provider with completing registration paperwork, completes their fingerprinting, and discusses the additional training they will need to be CCDF compliant, and then schedules their health and safety visit. After that registration is complete, the visit is scheduled, and we supply the FFM providers with items like a fire extinguisher or electrical plug outlet covers. During the health and safety visit, our team validates that the environment meets CCDF health and safety compliance. And because, like I previously mentioned, many FFM providers also have similar resource needs as the families we serve, we discuss any additional needs the provider might have, and we connect them to resources. Once that visit is completed and the provider has finished their initial training and the clearance memo for the background check has been received for the provider and other required household members, the provider is finally entered into the data system and activated. During this process, the R&R specialist, resource and referral is R&R, forgive me for the acronym, reaches out to the provider, offers them support, and checks in with them every 90 days. For family, friend, and neighbor providers in Southern Nevada, the process is slightly different. Our Department of Social Service partners share our contact information for those Southern Nevada families choosing a family, friend, or neighbor to care for their children. Our staff then completes the registration with the provider, and we notify DSS once the background checks results are received and all training requirements are completed. Child care licensing then schedules and completes the health and safety visit with family, friend, and neighbor providers in Southern Nevada, and then saves the checklist on our shared teams site. Our team then reviews the checklist that child care provider licensing has completed, and we check that list for additional needs like fire extinguishers, outlet covers. And then we upload the checklist on nevadachildcare.org, as publicly posting health and safety visit results is a child care and development fund requirement. Our team follows up with the provider to distribute resources identified on the checklist. Next slide. Finally, we track all complaints that we receive regarding the child care subsidy program from both families and providers. In Southern Nevada, we've received 389 complaints from July 1st of 2025 to June 15th of 2026. We received these complaints through walk-ins or calls to our Green Valley office. We assist families and providers with their questions, and if we're able to look at the case, we can see what's going on and help them navigate any challenges they might be having. If we are not able to help them, we email Maria each Friday with a list of concerns that we've received during that week. If the concern was previously reported and the family and provider calls back or comes into the office still waiting on a resolution, we elevate the concern directly to Maria at DSS. In Northern Nevada, we received 11 complaints during the same period. The complaints that we received are tracked regardless if we receive them via email, phone, or in person. We respond to all inquiries within 24 business hours, and our subsidy coordinator or manager will discuss the issue with the family or provider and try to resolve the issue. I hope that gives you an overview of the Children's Cabinet's activities in the Child Care Subsidy Program, and we'll open up for questions.
Thank you for your presentation. Thank you. Members, questions? Okay, well, I do. Thank you. This is really robust, and I will admit, sometimes a little bit difficult for me to follow.
Yep.
And I think it's because you have a bifurcated effort that looks like it's all under one umbrella. So I'm probably going to ask some very silly questions. You are serving both provider organizations, the ones that are delivering the service, and the families in need of childcare services. Is that correct?
That is correct.
Okay. Do you have two separate teams that are doing that, or is it your one intake personnel, that group of people that's providing the services for both sides, the provider and the family needing service?
They're two different teams under the child care under one director.
Okay, thank you. Then I believe there was a time in the state we had another provider organization that was helping to do some of these intake and referral. I don't recall, but that organization was working with JOIS, as I believe, and then when we pulled it back in, it was believed that some of the administrative savings that from negating that contract, we would have an opportunity to roll back out into services. Have you seen any of that happen? Do you have any idea what I'm talking about right now?
I believe you're referring to the Las Vegas Urban League was the other entity.
That's correct. Thank you.
Mm-hmm.
Have we, to your knowledge, been able to roll any of those administrative funds back into services through perhaps your organization?
Thank you for the question. We have been able to consolidate our resource and referral services. So the Children's Cabinet now does the child care resource and referral across the state of Nevada. So when parents are looking for child care and that child care consultation, we now do that statewide. So there has been a significant consolidation with resource and referral. The child care subsidy eligibility, we maintained our service delivery area, and now our partners at DSS do the subsidy eligibility determination for families in Southern Nevada. Although we do provide some of the family, friend, and neighbor registration activities that Las Vegas Urban League used to do, it is the health and safety visits are still being conducted by child care licensing directly. and that it's a difference of service delivery because we provide those supports to family, friend, and neighbors in the 14 other counties in Nevada, and then licensing does the family, friend, and neighbor validation visits in Southern Nevada. So it's still a little bit bifurcated.
Thank you. I'm going to ask you to clarify that just so that I can really wrap my head around. You're not serving the entirety of the state, even though you have 10 locations, that there's an allocation and a service area designation. Does that designation come from us, the state of Nevada, or does it come from a county? Why are you not able, the long question is, why are you not able to serve everyone everywhere so that I can just go to this website and figure out I need services? But it sounds like if I live in Clark County, I can't do that. Is that correct?
That is correct. For child care subsidy eligibility determination, you have to go through a DSS for your application eligibility determination. That is correct. And to your previous question, the Children's Cabinet is a statewide organization. There are many of our CCDF services that we provide in Southern Nevada, just not subsidy eligibility, and that family, friend, and neighbor on-site compliance validation visit.
Okay, and then just the next point of clarification, you have an average processing time of 15 days. That is for that eligibility processing, is that correct?
That is correct.
And okay, and I believe the states was significantly higher in there. Yes, I got a nod. Thank you. Okay, thank you for that. So I'm following the right track, I think, at least. Okay, do you have any idea, and knowing that you're not the state agency, do you have any idea with your programs, right? You're the chief programs officer. How many licensed, how many not even just licensed, unlicensed, as you talked about, care provider organizations do you have listed for referral through your organization?
Licensed providers in our database, there's about 440 licensed providers in the state of Nevada. And then in addition, our family, friend, and neighbor providers right now in Northern Nevada, I can speak to, we have about between 45 and 50. And in Southern Nevada, I do not have the exact number. I know our partners at DSS are still trying to clean up those that are truly watching children today.
Thank you.
You're welcome.
I think that wraps my questions for now. I'd like to follow up with you at a later date just to really solidify some of the data points that you've talked about right now as we work to build policy solutions going forward, right? So thank you for being here today, for answering my questions. I'll give it back out to the members one last time. Anybody have any questions at this point? No, they don't. So thank you so much for being here. I appreciate you.
Thank you for your time today.
Okay, that officially moves us to item 6 on the agenda, presentation of policy proposals for consideration by the Joint Interim Standing Committee on Health and Human Services. We will start. Mr. Musgrove, thank you so much for being attentive. Priorities of the Nevada Children's Mental Health Consortiums. And I believe you might also have a Carson City. Oh, our Carson City Annie Zucker Washoe Consortium will be joining us via Zoom. Okay, you may begin whenever you're ready.
I hope I've got it right. Good afternoon. Dan Musgrove here in my role as the chair of the Clark County Children's Mental Health Consortium. Good afternoon, Chair Brown May, Vice Chair Doniate, members of the committee. This is an honor for me to be here today representing the children's consortiums as well as the Clark County specifically. And if I could, I think this is kind of the perfect day. I understand that you already talked about children's mental health, but you've also spent most of the morning talking about child welfare. And earlier, my colleague Cadence Matievich talked about AB1 from the 2001 special session. Well, it was an interim committee, much like this, that decided in that previous interim, it was actually ACR 53, chaired by then Majority Leader Barbara Buckley, who looked at the issue of child welfare bifurcation and the issues in child welfare and decided that they believed that a children's mental health consortium needed to be created to focus on those needs. So back in 2001, they knew that we had an issue with children and mental health for kids that were in the system and just overall. And you've heard great presentations all day today about our system of care on that river and how we try to prevent things from happening. And you will notice from our priorities that a great deal of that is focusing on how to help families, how to try to do prevention, how to help kids that are coming out of crisis services, how to make sure crisis services are there and responsive to families' needs. And then what do we do for those kids that are in the most intensive types of behavioral health care and then come back home? And so those were our priorities. And so 25 years ago, believe it or not, June 15th, Governor Sandoval signed that bill in. And so 25 years, the consortiums have existed in Clark, Washoe, and in the rurals, much like you heard today about child welfare being handled by Clark, Washoe, and the rurals. And our job, and this is kind of the perfect word, and you know, in their just knowledge of the system, what has been so important in my eyes as a person who's a part of the consortium is the membership. It is statutorily required that we have a certain representatives from agencies, from the public sector. I represent the business community. We have a parent who has a child that's involved in behavioral health. We have a foster care representative. We have someone from DCFS, DFS, juvenile justice, the school district, and we all come together and meet and try to be nonpartisan. In other words, no one's to blame for the system, but we want to work as individuals and as a group to make the system better. And so our responsibility is to come up with a 10-year plan and then to grade ourselves and the system on how we're doing with that 10-year plan. And as a part of that, we come up with service priorities that we do every other year in time for the legislature so that we can come before you and talk about what it is that we see as our priorities. And that's what you have before you today. So there we go. Thank you so much, AV. So these are our 10-year plan goals. That's what we're working on from 2020 to 2030. But more importantly, these are the 4 priorities that we want to bring to you, this legislature, much like the ACR 53 committee brought to that legislature back in 2001 and said, these are the things that we as a system need to focus on. And candidly, I've been on the consortium over 10 years now. These are a lot of the same priorities. They get changed a little bit, they get tweaked, but unfortunately, we make incremental strides, and it's nobody's fault. It's the system's fault, whatever you want to say, whether it's lack of funding, whether it's systems working, more people entering a system, whatever it might be. And that's why we try to be nonpartisan in our priorities. It's nobody's fault. Let's just work together and try to make the system better. So thank you, Chair Brown-May, for all the work that you've done this interim with the groups that you heard from today. Thank you, Nevada Health Authority, for all the work you're doing in the Children's Behavioral Health Transformation Project. All the things you heard about today are making incremental changes. So again, we want to focus on evidence-based mobile crisis intervention, evidence-based transition practices from residential care. Again, you heard about it all day today. Family and youth peer-to-peer support, how important that is to families and youth to be able to talk to people that are going through the same thing. And expand accessible quality mental health services that best fit the needs to, again, reduce and prevent the need for crisis service intervention. Let's get them before they fall into the river. Before you've got the justification. I think you've heard about it all today. And then our specific recommendations. So if we had a magic wand and we had all the money in the world, these are the things that we would want under mobile crisis, expanding family and youth peer support, evidence-based transition practices. Again, we have very specific recommendations that are focused on Clark County, and you will hear from the rurals and Washoe on what they see as their priorities. But as you know, whatever happens in the rurals is the same thing that happens in Washoe. It just happens in Clark in greater scale. We're not that different when it comes to kids and families, but sometimes it's just a different case where what's happening in Clark cannot be replicated in the rurals. Take mobile crisis, for example. We would love to have a call made to mobile crisis and 60 minutes later, someone's helping that family. That can't happen necessarily in the rurals. It can't even happen in Clark 24/7 because we don't have the funds or the ability to do it. Those are the things that we'd like to see. And expand accessible quality mental health services, again, to prevent the need. These are our recommendations. And one of the primary things that we talked about was what's happening in the school districts, in our schools, in terms of programs that exist in the schools. Sometimes they only focus on certain schools, sometimes they're not broad-based. Again, we need more consistent and stable of those kinds of services within the school districts. And again, these are recommendations under that last one. Take a look at that last page and you'll see the folks that come together that are just on the board. I mean, our meetings that happen once a month, we get 50 to 60 people dialing in and bringing their issues to the table. We're very inclusive. We try to work with them. We have open discussion on all of our agenda items. And again, what we're trying to do is move the needle forward on children's behavioral health. These are the Clark County priorities. And I just wanted to be very quick for you, Tracy, as Chair Brown May, and thank you very much. And I'm open for any questions.
Thank you. Members, questions on this presentation? I don't see any. Thank you. I'm going to say it's really clear and concise from my perspective. I appreciate the documentation as well as the supporting information with regard to the recommendations. So I thank you for that. I do also believe we have the other two presenters. We have one in Carson City and then one person online. Is that correct?
That is correct.
Yeah. Okay. So let's go up to Carson City and we're going to hear from the next chair, right? Consortium chair.
Hello, Melissa Washabah for the record, MELISSA-WASHABAUGH, and I am chair of the Rural Children's Mental Health Consortium. So I wanted to give our update if that's available.
I understand that your slides came in late. If you don't mind, you're welcome to just deliver the presentation and we will take a look at the hard copy slides. They're available online for our members.
Oh, okay. Yes. First of all, I would like to give, I was here this morning when they did the sorry, I'm not a big talker, recognition of the retiring employee, and I just wanted to put on the record, Kristen Rivas, our clinical program planner, is also retiring today, and she has been such a great help to all of our consortiums, doing all of the background work, answering all our questions, so I wanted to say a big thank you to Kristen as well, who's also retiring from the state. And I'll go ahead with our presentation. Overview of our 10-year strategic plan. Yes. Thank you. Oh, I can click it? Yeah. Great, thank you. Okay. Okay, so as Dan mentioned, we each have a specific 10-year strategic plan for each of our regions. Ours specifically is listing our long-term goals to expand and sustain the Nevada system of care to rural and frontier Nevada. We've heard already about system of care and the good benefits that they provide, and so we've been a close partner with them. And as their grant has shifted focus in the last year or so, we've been keeping up on that, and the focus is more on the dual diagnosis needs. Goal number 2 is to increase access to mental and behavioral health care in general. Goal number 3, increase access to treatment in the least restrictive environment. Again, looking at that over-hospitalization and residential use and trying to upstream stop that from getting to the crisis point. Goal number 4 was to increase health promotion, prevention, and early identification activities. This is, especially for the rural committee, has been a big factor in doing very ground level communicating and working with families. And goal number 5, develop, strengthen, and implement statewide policies and administrative practices that increase equity to access to mental and behavioral health care for youth and families. Now, under the 10-year strategic plan, we have our service priorities. We do adapt yearly, depending on the progress on how are we meeting these goals each year. So our top 5 current service priorities, expansion of the comprehensive website. So we have used part of our budget to create a rural consortium website, and the main goal of that is getting information and links to other services. We don't provide any specific services. We're more of a connecting source, and so for all the community outreach we do, we're trying to connect people to the NAMI website and Nevada PEP and Youth Move and Children's Cabinet, who we just heard from, all of the available resources. So we want to have an email website that we can hand out where they can look at the list and see all of the resources in one area. And we've been keeping up on that, and also putting some of the events that we do onto the website. The second priority was awareness and destigmatizing messaging. Stigma is still a big problem nationwide, statewide, and is especially in the research shows rural areas tend to be a little bit slower to drop that stigma of asking for help or talking about your feelings, or there's even pushback against they call DEI services, which they're including some mental health services in some of that. And so we're trying to say that this is overall wellness and health care. It should be accessible to everybody, and we want to make it less scary to talk about. And so how we do that is we're holding community awareness events. We like to be in very public areas, talking with families on the ground, things like state fairs, sports meets. In Silver Springs, one of our members goes to the trunk or treat every year and hands out some information for the families, along with some candy and little fidget toys. So events like that are public, where we can be out and talking with families and getting the word out about prevention and mental wellness and just taking care of our minds and bodies. For example, we did the NAMI walk. We had a booth there in Carson this year. And in Humboldt County, they have a brain health summit where they have community members and professionals, and we've attended that as well. Priority number 3, support and encourage training at the community level. So this has changed this year. We were partnered very closely with the NVPEDS program, which was a grant that had ended this year. So we had to look around for other organizations that provide community level training. And so we've worked with, I mentioned before, Nevada PEP. They have a lot of good parenting skills training and information about how to navigate systems, IEPs, behavioral training. And so we're trying to promote those trainings for parents and caregivers. Youth Move has informational and peer support like group meetings that are online throughout the state. So that's actually very important to us to promote to the actual youth needing the services and letting them know that they have a voice and they have an organization as well where they can get support and have their questions answered. And then also the Office of Suicide Prevention, we're working on promoting Safe Talk, which is suicide prevention, community level training, not for professionals, for lay people. And priority number 4, increase the consortium's influences on mental health policy creation. During the legislative session last year, the consortium has drafted several, I don't have the numbers, but more than a dozen letters of support for bills that were related to youth and family wellness. Much of them were aimed at increasing the number of providers, so student loan forgiveness programs, opening up new positions of different types of counselors, and promoting counselors and social workers into the schools. We attended Children's Week at the Legislature and had a booth there, and then many of our members were also involved in providing testimony or individual support to certain bills. Included a few pictures of some of our events, and I'm actually missing a slide. We had one more priority service, which I pulled up on my phone because it didn't send correctly. I sent an old version, sorry about that. But priority number 5 was develop, strengthen, and implement statewide policies and practices that strengthen equity to access in mental health and behavioral health care. So equity to access, I think we've heard a lot about that, is who qualifies and who decides and what's available. And so some of that is insurance company based, some of it is statute, some of it's just lack of providers, and how can we enhance training, retention of providers, and use of telehealth services when appropriate. So we are focused on access as well. That's all. Thank you for your time. Any questions?
Thank you for your presentation. Members, questions? Nope, I don't see any at this time. Thank you so much for your presentation. We appreciate your detailed analysis. We will now move to the third presenter, Annie Zucker with the Washoe Consortium, who is on Zoom with us today.
Good afternoon, everybody. Can you see my screen?
Not currently, no. No. But we have your slides. We've submitted them, so you are welcome to just do your presentation. Thank you.
Oh, okay, perfect. All right, I will, and I'm going to be more brief. I know that we have a time crunch today, and much of what we're doing obviously is at a statewide effort, but I'm going to talk a little bit about Washoe County in particular, and kind of go over some things that skim over things that are statewide and focus more on Washoe County here. So our consortium obviously meets the same monthly as the other consortiums with the 10-year plan and 3 goals. The goal 1 is to increase the access to compassionate care in the least restrictive environment, decrease the buffer of children's exposure to toxic stress, and increase access to the positive community-based experiences. We know from the research that these kids and families do really well with positive childhood and positive family experiences. For the forces kind of shaping mental health in 2025, obviously, we're the U.S. Surgeon's General Advisory from a few years back that was prioritizing mental health and the framework that it gave the United States to work forward together. Also in Nevada, the DOJ settlement and the court oversight that happened with that 2030 oversight. The incredible work that's being done from the state of Nevada with the Medicaid transformation is something that we need to consider when we're looking forward in our 10-year plan. And then obviously still those workforce and housing shortages in Washoe County in the state of Nevada. Some data points from Washoe County through our SOS program, which is our Signs of Suicide program implemented by the Children's Cabinet through Washoe County School District, is that 35% of our 7th graders identified as at risk for depression and suicidal ideation. Nearly 6,500 individuals have been trained in evidence-based suicide prevention through the Nevada Office of Suicide Prevention. 13,000 students in Washoe County experience homelessness or a housing instability in Washoe County. 140 youth are served through Quest's Youth Opioid Intervention Program, which are justice-involved youth that have been sent to Quest for that program. 531 families served through Nevada PEP peer support programs, and 9,400 Narcan kits distributed by Quest Counseling, again, protecting those lives risks from opioid overdose. So those are some of our data points from the work that's been done in 2025 with this group. Some really great highlights across our system. And again, I'm going to focus on Washoe County. We had our 4th annual Youth Mental Health Summit with over 300 attendees, 30 resource fair organizations, and youth-led panels. We're moving into our 5th annual on September 15th this year, again at Grace Church, expecting over 400 attendees for the event. Washoe County School District SOS program, 90% of 7th graders received that suicide prevention education, and 80% of those families consented for the screenings, meaning that 3,352 students were screened in the SOS program this year. With Nevada PEP, 531 families were served through family peer support, now Medicaid reimbursed under the statewide behavioral health reform. Mobile Crisis has transitioned to Washoe County Human Services Agencies, which expanded our in-home crisis response capacity. Quest Counseling expanded workforce by 2 psychs, APRNs, 4 clinicians added. Child Psychiatry program has 7 clinicians now. And our early childhood day treatment program completed its 2nd year of operations, and it is serving that critical need of ages 3 to 6. I'll skip through our family voice. Every meeting we take a moment in our to recognize family voice and give all of the members time to talk about family voice. So we hear a lot about what is going on in our community through that family voice time in our agenda. Talking about things that are holding us back, access barriers, workforce shortages, obviously, insurance barriers, housing instability, our systems gaps, that funding cliff, acute care shortages, which is really critical, especially from that pediatric lens, IDD special needs gap, and our data infrastructure. Fragmented tracking of service utilization seems to come up often in our meetings, and I heard it throughout today's meeting as well, so I'm hearing kind of the same things. Our recommendations, I'm not going to really get into funding. Funding is always tricky, and, we put numbers attached to these things. But our recommendations is to commit funding, infrastructure, and legislative support to maintain and expand existing programs and services, promote innovative programs to respond to the growing youth mental health crisis. So working on some intensive in-home crisis stabilization programs while we get our youth behavioral center up and running in Washoe County. And then looking ahead is just that priority with our Medicaid transformation, school-based mental health services, continuing SOS screening, Hope Squads, youth mental health first aid, et cetera. Workforce development, expand clinical trainings, internships, and licensure pipelines is really important to us right now. Potentially coming up with some really great funding opportunities that we've had through a private foundation to do this work. And then our suicide and harm reductions is really scale that Office of Suicide Training that is statewide, and in really a win lately has been that Churchill County actually has mandated suicide prevention training for their entire counties recently, and that was in their last meeting that they did that. So some really big wins there, obviously. Some momentum that needs to be worked upon, but really excited and proud to continue this work. And available for any questions if anybody has them.
Thank you for your presentation. Thank you. Members, questions? Okay, I'm not seeing any. Thank you so much for being with us today. Thank you for your slideshow and the recommendations from your consortium. Okay. That moves us to the next item on our agenda, which is the medical evaluation and system support for child abuse cases. We'll welcome Lee McAllister, Executive Director, Nevada Chapter of the American Academy of Pediatrics. Thank you for being with us today. You may begin when you're ready.
Thank you, Chair and members of the committee, for giving our organization an opportunity to present this morning. I am Lee McAllister, McAllister, the Executive Director of the Nevada Chapter of the American Academy of Pediatrics. Our presentation will begin with Dr. Chris Dieter, who's on Zoom today, while I work to pull up our slides.
Thank you, Chair and members of our committee. I appreciate the opportunity to speak today. My name is Chris, K-R-I-S, Dieter, D-E-E-T-E-R. I serve as Chair of Pediatrics and Physician-in-Chief at Renown Children's Hospital, and I also practice as a pediatric intensivist in our Pediatric Intensive Care Unit in Reno. Too often, my colleagues and I care for children whose injuries or circumstances raise concerns for physical abuse, neglect, or human trafficking. These are some of the most vulnerable children in Nevada. Many have already experienced repeated trauma before they ever arrive at our doors. For them, every interaction with the healthcare system can either reinforce fear or become the first step towards safety. When these children arrive at our hospital, we are well equipped to treat broken bones, traumatic brain injuries, burns, or other medical emergencies. But medical treatment is only one part of what these children need. They also need experts who can carefully evaluate whether abuse has occurred, coordinate with Child Protective Services and law enforcement, communicate with district attorneys, document medical findings in a way that will withstand legal scrutiny, and most importantly, help determine what will keep that child safe after leaving the hospital. For the past 8 years, the entire state of Nevada has had no board-certified child abuse physicians working for our children, despite our best efforts to recruit them. Because of that gap, physicians, surgeons, emergency providers, social workers, and nurses have come together at Renown Children's Hospital to create a multidisciplinary child protection team. Every member of this team volunteers their time in addition to their regular clinical responsibilities. Together, we review complex cases, produce comprehensive medical recommendations, and provide consultation to CPS and our district attorneys as they make difficult decisions regarding a child's safety. Recently, through grant funding, a few of our physicians completed specialized training through the University of Utah. That education has strengthened our ability to recognize abuse, document findings, and support our community partners. It has shown us what's possible. But volunteerism and temporary grants are not a sustainable model for protecting Nevada's children. To build a statewide system of care, we need dedicated funding to train additional providers, support consultation time and call coverage, and allow these experts to leave their clinical practices when they are required to testify in court. Expert testimony is often essential to achieving justice and ensuring children remain safe. Yet today it frequently comes at a personal and professional cost to the providers who volunteer. This investment is not simply about supporting healthcare workers. It's about creating a sustainable child protection infrastructure for Nevada. When an abused child arrives at one of our hospitals, frightened, injured, and uncertain about what comes next, they deserve more than just excellent medical care. They deserve a coordinated team with the expertise, time, and resources to advocate for their safety and their future. I appreciate your consideration of this important effort. Lee McAllister will now provide additional details regarding the framework of our proposed legislation. Thank you for your time.
So children who are abused, they interact repeatedly with healthcare, emergency rooms, urgent care, primary care. These encounters are critical. They are the chances to identify, document, and intervene. Our chapter hears directly from pediatricians, law enforcement, and prosecutors through informal multidisciplinary discussion groups. The consistent message: reporting isn't the problem. The problem is what happens after the reporting. Delays in record access and clinician engagement, slow investigation, and weaken prosecution. This isn't a story of bad actors. It's a system problem. Without training, protocols, and formal collaboration, even committed providers disengage after a report, driven by uncertainty about authority, documentation, and uncompensated time. HIPAA permits patient information with law enforcement for mandatory reporting, subpoenas, and court orders. The real challenge isn't the law, it's uncertainty about process and timing, which can delay access to medical evidence when it's needed most. Kansas has built a structure instead of relying on informal goodwill. A statewide network of trained providers on call for evaluations and testimony, compensated for both. The result, predictable access to expertise, not dependent on individual relationships. And there's an added benefit worth noting. With trained physicians and advanced practice providers across the state, Kansas Care was also able to quickly clear families who were wrongly accused of abuse, reducing the trauma a false allegation causes. Since this isn't a money committee, I'm going to skip that, but I can go back to it if you have questions. Nevada can clarify authority for timely information sharing, support a compensated provider network, align guidance with HIPAA, and invest in training. The principle is capacity must precede mandates. Support has to come before expectations, especially in rural areas. And the Nevada chapter of the American Academy of Pediatrics stands ready to help build it. And Dr. Dieter and I are happy to take your questions.
Thank you for your presentation. Thank you for being with us. Members, questions? Nope, I don't see any. Thank you so much for your policy recommendation.
Thank you.
Okay, that leads us to the next policy recommendation, priorities of the Children's Advocacy Alliance of Nevada. I will welcome Alexis Marin, the Las Vegas Health Policy Manager, and Alyssa Cafferata, Executive Director. Thank you so much. I do believe this is your first presentation to a legislative committee today, so we're happy to have you.
Thank you. I'm so nervous. I'm like,
They're going to be great. We have all done it for the first time at some point, so just take a deep breath and.
yeah, absolutely. It's funny too, because it's like my hands are doing this sweating thing that it doesn't, it's just, anyways, really excited to be here and happy that you guys invited us. Awesome. So I'll go ahead and get started. My name is Alexis Marin. I'm the Health Policy Manager here at the Children's Advocacy Alliance. And today we're going to be discussing one of our priorities, which is children's healthcare access here in Nevada. And I'll let Elisa also introduce herself.
Good afternoon, Elisa That doesn't work. Good afternoon, Elisa Cafferata with Executive Director of the Children's Advocacy Alliance, ELISA-CAFFERATA.
Awesome. And just a little bit about who we are. We are a policy advocacy organization here in Nevada, and we represent kids. And then also to this policy priority came out of the Children's Mental Health Action Coalition. This is convened by CAA, but we also do this in partnership with UNLV Lindsay Institute and also Councilman Brian Knutson. There's about 138 members right now within this coalition, and we have 3 active working groups, but for the sake of time, I'm just going to focus on working group 3, which is insurance and provider access. Awesome. And just a quick roadmap for today, just to let you guys know what we'll be covering. We're going to start off with what we heard from the community, how we, the Children's Advocacy Alliance, decided to explore this issue, what we found, why this matters for children and families here in Nevada, and opportunities moving forward for the legislature. Awesome. So what we heard. So we heard from providers across multiple children's services reported difficulty participating in Medicaid and Medicaid MCO networks. These challenges were reported by providers of behavioral health, ABA, speech therapy, occupational therapy, and physical therapy. They described denials, lengthy application processes, and lack of clarity regarding participation. You may be wondering how we as CAA probably went about exploring the issue. So in a coalition meeting in person on June 2nd, in working group 3, we had 2 provider contract denial letters and put them in the middle. We had a laptop and showed it to the working group, and we had a conversation about it. And by the end of the conversation, we decided to put out a call to collect as many denial letters as we could in the span of 2 weeks. We wanted to see if this was like an isolated event happening or like within the coalition, or if this was something larger at hand. And all the denial letters are made available to you within our materials. And for the people behind me, there's also denial letters in the back if you guys are interested in those too. We also had some conversations, not just with providers across multiple disciplines, but also with the Division of Insurance, Medicaid, a Medicaid MCO expert at the Georgetown Center for Children and Families. And we haven't yet talked to MCOs, but Mr. Young's comment this morning and him engaging with our presentation, we're really grateful for, and we look forward to collaborating with them too in the future. We also reviewed some data. We looked at the Division of Insurance's annual denial report from 2021 up to 2024. I believe the 2024 one isn't yet posted, but if you guys want access to it, you can ask the Division of Insurance. We looked at Medicaid network adequacy reports, specifically the 2024 one. We looked at some workforce data in Nevada, and we also looked at the EQRO, which stands for the External Quality Review Organization, and EQOs is a federal mandate to oversee all things MCOs in the state. Awesome. So a little bit about what we found. Most denials cited business decisions, closed panels, network capacity, or a lack of network needed, and there weren't much concerns about provider quality. Providers reported navigating multiple applications to contract with Medicaid MCO networks, creating some pretty significant administrative burden. Medicaid has centralized enrollment and credentialing and does share provider information with MCOs, but the contracting step with MCOs is not yet centralized. Nevada continues to face a workforce shortage across all these disciplines. And we also too hypothesize that when providers can't access networks, children and families may face reduced access to care. Over time, agencies may reduce services, leave communities, relocate to states where network participation is more accessible, or stop accepting insurance altogether and transition to cash pay models. Lastly, the DOI data doesn't capture like specific Medicaid or MCO provider denials. They do capture Medicaid MCO denials, but it's a bit more aggregated. And this cannot be teased out by carrier due to restrictions in statute. DOI did inform us that DHCFP provider enrollment also receives all MCO denial letters, but again, they don't also have a statutory requirement to report, and their provider enrollment team is only at 2, and they're kind of at capacity. I'm now going to transition the rest of the PowerPoint to my boss, Elisa.
Again, Elisa Cafferetta for the record. Why this matters for children and families in Nevada. I think you've spent the day hearing about the need for more providers and more streamlined processes to be sure that we can address the mental and behavioral health needs of children in our state. And these are also all related to child welfare and child well-being. We know that about 40% of Nevada kids are served in the Medicaid or the program and Nevada checkup, more than that. And about, no, that's right. Sorry, I don't have the numbers on the slide. So about 40% of kids are in Medicaid and Nevada checkup, and 80-something% of those are served by the MCOs. So the question of MCOs specifically and how that program is being implemented, which is fairly new on a statewide basis, directly impacts the most vulnerable families in our state. And what we found through the investigations is that because we are just building this program, you do have a lot of information, but you don't really have an insight into the full picture. So the state is investing a lot of money into the workforce in these areas, but we don't have sort of a pipeline map of how many new providers are there, how many of them are accepted into Medicaid, how many of them are contracted into the MCO contracts. So we kind of need to have that full pipeline look to see if those investments are translating, and it will take some time for those investments to come to fruition, but we do need to see if those investments are providing increased access for families in need. And then the network adequacy metrics also don't include all of the specialties. And they are metrics that don't necessarily tell us the whole equation of there are providers in the networks. The networks do have a report that they are meeting the adequacy standards, but what we don't know is one of the standards is, are they an active provider? And the definition is, if you take one patient a quarter, you're considered an active provider. I don't think many of us would consider that the level of service provision that we really need. So we're also saying you need to have a little bit better look at those standards and how they actually translate to families' ability to get the care that they need. So our recommendations are, as we move forward, and again, some of these programs are new and we don't have all the system in place, but building a real provider pipeline map. So as we bring people online, are they getting put into these networks and are families able to access them and get the service? Part of that's going to be reimbursement rates, and part of that's maybe going to be denial and how we determine how many people we need in a specialty. But we need to have a clearer picture of whether those investments are translating into access to care. The denials report that the Division of Insurance currently produces does sort of at the aggregate level, as we've noted, include private carriers and Medicaid and MCOs, but we can't really pull out specifically the MCO piece to see what level of denials are happening there. And if the stories and the anecdotes we've heard are just a few providers or if it's a systemic issue. There are coming online from CMS some regulations that would include the requirement to do secret shoppers, so calling to see if these providers actually have appointments, if they're actually available within the next 2 weeks. That requirement doesn't actually fully get implemented till 2027, 2028, depending on your plan year. So there are some things we could possibly look at doing, like doing an analysis of the real claims data to see if these providers, if these services that we're looking for are being provided and being covered by Medicaid and the MCOs in point of fact, without waiting for those rules to come into place. So that might be something to explore. And finally, I think you've heard a lot about developing the care coordination pathways. And when we do that, we also want to have a standard to make sure that we're meeting those needs as well. So we greatly appreciate all the testimony you've heard today and will hear today. You can see everybody is working very hard to make these services available to children and families. And what we have found is we're hearing a lot of stories that they're not available. And so we want to make sure we're taking a look at putting together the metrics and reports in a way that you can really tell whether this investment is bringing a return to our families as intended. And we're ready for questions if you have any for us.
Thank you so much. Thank you for the presentation. Members, questions? I don't see any. I do want to thank you for being here with us. We're getting late into the afternoon, so I know that you've waited with us all day. And the policy recommendations are very important, so thank you for following through on that. That leads us to the next item on our agenda, the creation of a centralized early childhood governance system. We will welcome Shannon Bilbray Axelrod, Director of Policy and External Affairs with the Children's Cabinet, to do this policy presentation. Welcome. You can begin whenever you're ready.
Thank you. Is that up? Do I need to do something else? Thank you. Sorry, I do have it up. I don't know if I need to make it like full screen or anything, or is that is up?
That's the PDF, not the slideshow.
That's the slide.
Thank you. You'd think I'd never been here before. Thank you, Chair Brown May and committee. My name is Shannon Bilbray Axelrod, and I have the pleasure of being the Policy and External Affairs Director for the Children's Cabinet. I'm here with Marty Elquist, who is our Chief Programs Officer. We do have an agenda item here that we're going to be referencing, which is our case statement and policy proposal, and that is agenda item 6D2. But here we go with this. It is 6 slides, so I will be cognizant of time. Away we go. Thank you.
Good afternoon, Marty Elquist for the record. In 2024, we had the privilege to work with the Gwynn Center, who conducted a study of Nevada's early childhood governance system. They found that our system had a significant fragmentation, and that it was really difficult for our families to navigate. As a part of that study that Gwynn did, we really looked at with the Early Childhood Advisory Council when we were redoing our strategic plan, and the strategic plan is really focused on how do we create better system governance for our children and our families. And so as a result of that, there's a coalition in addition to the Nevada Early Childhood Advisory Council that came together, and we are now calling ourselves Kids First Nevada. We're a statewide coalition. We're focused on aligning early childhood programs and monitoring our governance structure to improve access, efficiency, accountability, and outcomes for Nevada's youngest children. Our focus for this recommendation is how improved governance can better serve children, families, and our state. The study that I mentioned from the Gwynn Center showed that our system is highly fragmented, and it's very difficult for our families to navigate. The report is called From Crowded to Coordinated, and I believe you have that report. If not, we'll be happy to direct you to the link on Gwynn's website. They found that today our services are spread across 26 different state statutes, chapters, 40 state budget accounts, 18 separate state agencies, and 45 additional organizations. This fragmentation has real consequences. We have duplication across agencies. We have inefficient use of our very limited funding. And most of all, we have confusion in our families of where they go to access services. Families often don't know where to go to navigate these multiple systems. At the same time, the state lacks a single entity accountable for outcomes, and this is during the most critical developmental period of our lives, early childhood. The bottom line is that we do have strong programs, but we're not working together efficiently. Our recommendation is governance reform, not more bureaucracy, which is aligned with the ECAC strategic plan and the Gwynn report. Specifically, we seek to establish a Nevada Department of Early Education. Early childhood. Early education is just a sector in that early childhood system. This would create a single point of accountability and coordination. We are asking for a governance structure that works better for our state, as well as our families and those who serve them. For the state, we aim to reduce duplication and administrative overhead, improve efficiency and coordination across programs, provide clearer budget transparency, maximize state and federal funding opportunities, enable stronger oversight and data-driven decisions. For families, this will improve access. They'll have fewer doors to knock on, reduce confusion and administrative burden, expand access to services, and support more family-centered decision-making, and ultimately help parents participate in the workforce. In short, better coordination equals better outcomes for our children and our families.
Shannon Bilbray Axelrod for the record.
I just wanted to point out that this is a proven bipartisan model. Nevada wouldn't be starting from scratch. This model is already working in other states. To date, there are 14 states that have created early childhood focused departments, including Colorado, Alabama, Georgia, Illinois, and Ohio. These are bipartisan efforts across different political environments. National organizations support this approach and have provided guidance on the development and implementation of the new governance structure. And we're really seeing a national trend to organize resources and support services during this critical period of development. We know that 90% of brain development happens in that 0 to 5 period. The takeaway, this is not experimental or new. This is not partisan, and it's a proven strategy to improve coordination and outcomes. The Kids First Nevada Coalition has the following recommendations. Establish a Nevada Department of Early Childhood, centralize leadership and accountability, appoint a qualified director, which is critical for strong implementation and leadership, develop a thoughtful transition plan, which will ensure smooth transfer of programs, funding, and staff, minimize disruptions to both families and providers, align with ECAC, which is our Early Childhood Advisory Council, which will allow for us to maintain our strong stakeholder engagement, create interagency agreements, which will ensure coordinations across the systems, require annual reporting, accountability to the legislature and governor, and also transparency on both the progress and outcomes. This practical phased approach to achieving better coalition will be the most important part of this agency. In closing, Nevada has a strong early childhood program. We do, but the system structure limits their full impact. Government reform is an opportunity to improve efficiencies, simplify access for families, and deliver better outcomes for children. We thank you for your time and consideration, and I'm happy to answer any questions.
Thank you for your presentation. Thank you. Members, questions? I don't see any questions. Thank you. Really comprehensive. Very well done.
Thank you. Thank you very much.
Okay, that leads us to agenda item 7. We're getting there. Update on the Fund for a Healthy Nevada and a Fund for a Resilient Nevada. We will thank you for being here. Administrator Rich, I will encourage you to go whenever you're ready.
I'll wait for the presentations to be loaded.
Did I demote you? I apologize. Director Rich. Yes. Sorry.
All right, it looks like we're good. That's exit. Sorry, exit. Okay. Thank you, Madam Chair and members of the committee. I am Laura Rich, and I serve as the Director of Human Services, the Department of Human Services, I'm sorry. In the north, we have Dana Roscom, who oversees the Fund for Healthy Nevada program, and then Christina Hadwick, who is the Deputy Director over Fiscal at DHS. They're going to be helping me with this presentation as well. So just a little bit, we're going to go over the Fund for Healthy Nevada and then Fund for Resilient Nevada after that. We'll stop in between for questions just because these are 2 different programs, so I'll make sure to stop in between. A little bit about, I'm going to try to go through this pretty quickly. I know that we are short on time, so I'm just going to kind of rush through them, but I think we'll hit on the important parts of what I think are important to resonate with the committee. So just a little bit, an introduction on the Fund for Healthy Nevada. It was established in response to the tobacco settlement, and really it's tasked with funding and overseeing programs that support the health and well-being of Nevadans. So the tax revenue that we receive from the tobacco settlement is what basically funds some of these programs. On the next slide, we have a little bit, it describes the programs that the tobacco settlement funds. So what we do is every 2 years, we have a statewide community assessment, and Dana will be going into that in just a few minutes. But the purpose is to identify the most urgent health issues in our state. And then funding decisions are then guided by the findings. On the next slide, we see that just a little bit about the different programs here that are funded. We've got, senior independent living, assisted living, a lot of different wellness programs. You see 211 support, suicide prevention, FRCs, FQHCs. We've got counties that are funded through this as well. So there's a lot of different community services out there that are funded through the Fund for Healthy Nevada. On the next slide, and this is where I want the committee to focus their attention on, is really the FHN revenue and why we're here today. I think it's important to just highlight the fact that so DHS receives projections from the Treasurer's Office in August of every year, but we don't actually receive the revenue until April. For budgeting purposes, DHS bases revenue projections on a 3-year average, and specifically in the 2025 sessions, DHS started working with the Treasurer's Office because we found that there was a very, very significant drop in revenue. So in the middle of session, they had to go back and make cuts to what was in the governor's recommended budget. So as you can see here in the table, you can see that we anticipate a very steady and significant decline in what we're seeing in tobacco settlement revenue funds. Obviously, I mean, this is great. This means that people aren't smoking, right? But I would also say that smoking has been replaced by vaping, and we don't get those tax dollars from vaping. We only get it from tobacco. So you're seeing here that there's a pretty significant drop in our revenue, and the current projections are showing a drop between FY fiscal year 24 to 29. It's over a 31% drop in that revenue, and so you're going to see that there's going to, we're going to have to make some pretty significant and hard decisions moving forward. So next biennium, we're expected to have a reduction in revenue of a little over 7% in FY28 and a little under 8% in FY29. So that's about $3 million total. There are some statutorily required funding programs in this within FHN. So we can't do anything to this. So that means that the rest of the programs are going to be even, with a greater impact, right? So you're going to see potentially a 10% reduction in some of these programs. We're going to look at it and try to figure out, if maybe some programs can absorb more than other programs in terms of reductions. We haven't really had an opportunity to dig through, and we're talking to the different divisions and the different, just the different funding sources and what we can do to make this impact the least impactful, I guess, that we can, but we know it's going to hurt. And, this is not, there's no, great way to go about it. There's, as Senator Doniate said earlier, again, we're going to quote you again, there's a limited amount of money here. And, we're going to have to make hard decisions moving forward. So with that, I'm going to pass it along to Dana to talk a little bit about the needs assessment and how we determine what gets funded through this program.
Thank you, Director Rich. Dana Roscom for the record, ROSCOM, and I serve as the Social Services Chief overseeing the Grants Management Unit in the Department of Human Services Director's Office. And so transitioning into our 2026 Community Needs Assessment, this is required by NRS 439.630 Section 6. Our department conducts an assessment every biennium to identify the funding priorities for the next 2 years, ensuring that funding decisions are informed by current statewide data. For this assessment, we partnered with the University of Nevada, Reno School of Public Health Larson Institute. And after a thorough review of a variety of different existing reports, we ultimately synthesized 25 reports from those data sources representing urban, rural, and frontier communities across our state. Our goal was to identify common themes, service gaps, and of course, emerging priorities that are affecting children, families, older adults, individuals with disabilities, as well as other underserved populations. Again, as Director Rich pointed out, these findings really serve as an evidence-informed framework for us to really ensure that our resources are invested where our state's most needs are. So I just want to reiterate that the funding categories that are depicted throughout this assessment and presentation are specifically the areas that are administered by the Director's Office Grants Management Unit. And so collectively, as you can see, these programs support a broad continuum of services, which include access to health care, youth and wellness, behavioral health, disability services, school safety, direct community-based assistance through family resource centers. As these recommendations were developed, they were intentionally aligned to ensure that they would fall in line with the already established program areas. I also want to point out that our current programs that are funded out of these FHN funds, they are currently, quite a few of them are addressing the current needs, as you'll see in the later slides. So I do believe there's strong opportunity to enhance what's already being implemented rather than focus our efforts on identifying new strategies. So a little bit about our methodology behind the 2026 Community Needs Assessment. This was a secondary data community needs assessment, so rather than building something from the ground up, we went ahead and compiled 89 existing reports from national, state, regional, hospital, and community-based sources that were completed in the past 5 years. 25 reports met the inclusion criteria and underwent a detailed content analysis. We then engaged community partners to validate our findings using a modified Hanlon prioritization approach, which ultimately considers prevalence, health equity, and feasibility. Partner feedback also just provided us with additional context. With them being boots on the ground and working closely with these communities, we felt that their feedback was very valuable in ensuring that what we were seeing in the data was actually reflective of what was going on in these communities. So again, just to reiterate, the combination of this quantitative and qualitative approach through our partners, we truly believe that these recommendations do reflect Nevada's current health landscape. While the focus of the needs assessment are obviously identifying the most top needs of our state, we did want to acknowledge our community strengths. And so across the board, through our data and qualitative feedback, it was expressed that really our infrastructure is something that we really should all be proud of. While it's not perfect, we do have strong partnership network and collaboration, whether it be formal partnerships or simply referrals, and just being knowledgeable in all the different resources that exist, as well as the diverse menu of offerings that we as a network have in terms of outreach services as well as other community engagement efforts. So this was an area that through our data we would like to continue to enhance and build upon. And so this is something really great for us because we do have a solid foundation moving forward. So now focusing on the actual priority needs. Across all regions of Nevada, several priority needs consistently emerge. So as you can see, behavioral health, access to health care, transportation, housing, food insecurity, and the cost of health care were all identified as the most significant barriers currently impacting our communities. Although local needs vary, these remarkably remain consistent across urban, rural, and frontier communities, again reinforcing the importance of coordinated statewide investments. I do also want to note that these needs are interconnected, so rather than looking at them independent. So for example, transportation barriers can affect access to health, behavioral health, food access, as well as employment. And so really addressing one barrier often really provides just or improves outcomes across multiple areas. And so diving into the recommendations, based on our findings, these were the 5 recommendations that were developed. So first, focusing on strengthening Nevada's healthcare workforce through recruitment, retention, and provider well-being. The second emphasizes strengthening organizational capacity and improving coordination across healthcare and community service providers. The third recommendation addresses transportation barriers and recognizing that access to services often depends on an individual's ability to reach them. The final recommendations focus on expanding evidence-based substance use disorder services and addressing upstream social determinants of health that contribute to health disparities. And also, I should have pointed this out, so as I'm going through each recommendation, you'll see at the bottom underneath each of these recommendations, I've highlighted aligned FHN program categories. So again, it just really shows the flexibility in our ability to maximize our strategy to implement these different recommendations. So rather than addressing individual issues in isolation, these recommendations were intentionally designed to complement one another. So together they support really a coordinated approach that strengthens healthcare across access and improves system capacity, and of course addresses the underlying factors influencing health outcomes across the state. And lastly, I think it's important to note that these recommendations require both immediate service delivery as well as consideration for long-term investment. And so as we look at this data that we've collected and have identified the recommendations, really this sets the footwork for key considerations for our future notice of funding opportunities, which our goal is to release January of 2027. So we want to include just emphasizing direct service delivery, ensure that strategies are evidence-informed programming, that there is equitable access for underserved populations, that we continue to encourage the collaboration and strengthening of that partnership network. We want to implement reporting requirements that capture measurable outcomes, so we can really identify what worked, what didn't work, and see where we may need to pivot in the future, and of course identify programs with long-term sustainability plans. And so collectively, these considerations are intended to ensure future Fund for Healthy Nevada investments remain responsive, accountable, and are aligned with Nevada's evolving needs. And so with that, that concludes this portion of our presentation. And so as Director Rich said, we'd be happy to take questions before we transition to the next part.
Thank you. Members, questions? Go ahead, Assemblymember Nadeem.
Thank you so much, Chair. Thank you for the presentation. My question is regarding the cut in the healthcare, the facilities you are going to provide. So can you kindly tell us that exactly where you are going to have a cut and which are going to be remain as it is?
Laura Rich for the record. So that hasn't been decided quite yet, right? That's part of the budget building process. We are now talking with different agencies and organizations and trying to assess where maybe some cuts can be absorbed easier than in, you know, other programs. So I think that's just that's going to be a process of part of the budget building process. So we anticipate that it's probably going to be proportional just because of the amount of cuts that are coming. But again, some of them, again, are statutorily required to be funded. And so we cannot cut those, which means that other programs are going to have to be cut at a higher rate, right? So it's 7, if we looked at it across the board, it would be 7-8% per year of the biennium in the next 2 years. So the cuts are going to be, you know, they're going to be painful. It's not, you know, we're really going to have to be diligent and try to look at it in a, you know, meaningful way and to try to assess what makes the most sense. But it'll be part of that budget building process.
Thank you, Chair. Can you kindly, whenever you get the information, can you kindly provide us that information? Because this is very concerning and it's very unfortunate.
Laura Rich, for the record, that will eventually be in the governor's recommended budget in January. So there's nothing much that the committee can provide before that. We just wanted to make sure, or I'm sorry, that the department can provide before that. We just wanted to make sure the committee was aware that, you know, this was coming. You know, that we've been looking at the revenue ourselves and knowing that this is coming down the road, and it's not just in this next biennium, but in the biennium after that too.
Next question from Assemblymember Goulding.
Thank you. On a related note to my colleague's last question, I was a little confused by something you said. So 60% of the tobacco settlement funds are directed to this program. And so you said that there's a reduction in tobacco use, which is great. So that's a good thing. But then you mentioned vaping isn't taxed in the same way. Can you just unpack a little bit where the relationship between the reduction in, like, is there I know it's not a fiscal committee, but the relationship between tobacco use, vaping, the revenue, how do we recover here?
Laura Rich, for the record. So I'm not going to profess to be a subject matter expert in vaping revenue and taxes, but what I will say is that, you know, there was a tobacco settlement, right? And so out of this revenue and out of the revenue that we get from those tobacco taxes, that is what funds the Fund for Healthy Nevada. So that's essentially where the revenue is coming from, right? Vaping has, and I don't have data or specifics in front of me, but I think anecdotally, you know, in the past you used to see children, kids, teenagers, you know, even adults smoking, whereas now you see a lot of vaping. I don't believe that the tax you know, structure is similar, right? Where the Fund for Healthy Nevada is not receiving the tax revenue from the vaping. We are receiving tax revenue from tobacco settlements.
Thank you. I think that's where I needed the clarification. So if behavior is changing, which we want, but then that behavior change isn't, the revenue isn't following that. So that the vaping taxes are not coming to the same fund. Thanks for that clarification.
Thank you. Members, any other questions? Okay, seeing none, thank you. We'll move to the next part of your presentation.
Okay, Laura Rich again, and with me today to present on the Fund for Resilient Nevada is Dawn Yohei. She oversees the FRN program, as well as Heather Kerwin, who serves as the opioid and infectious disease epidemiologist within this program. So again, this is more informational. I don't have I don't have the same bad news that I have on the last one. We actually are we are due to receive opioid settlement funds for the next 20 years. So that's the good news. So the Fund for Resilient Nevada was established in 2021, and that was in response to the opioid settlement. FRN tasks the Department of Human Services to administer the state's portion, which is about 43% for the next 23 years, or I'm sorry, 20 years. Next page. FRN is just a part of the opioid settlement funds that Nevada receives. As you can see from this chart here, the state receives 43.86%, and we manage that amount. The rest of it, the remaining, goes directly to local government. So that's the county, cities, things like that, and as well as the Medicaid match to that. Next. Similar to Fund for Healthy Nevada, a needs assessment is completed for this program as well every 4 years, and it drives the funding decisions. And I'm going to pass this to Dawn and Heather, who will kind of go over, how that is done and what that process looks like, and talk about the latest needs assessment. I think I can't see over there. So, Dawn, is she there?
Good afternoon, Chair and members of the committee. My name is Dawn Yohe, Y-O-H-E-Y, and I am a clinical program planner with the Fund for Resilient Nevada. This slide right here just shows the principles for the use of funds from the opioid litigation. This is kind of what our driving force from the very beginning of the inception of the fund. Today with me I have Heather Kerwin. She's going to be going over the current needs assessment and timeline, and then I'm going to be wrapping up with an annual plan or an annual report that has been due based on our law. So I will pass it over to Heather.
All right, thank you. Heather Kerwin, Kerwin. I'm an opioid and infectious disease epidemiologist leading our next iteration of our state's opioid assessment and plan development. This is part of our requirements through NRS is to do these, as Dawn mentioned, every 4 years to inform our statewide plan. It includes secondary data indicators, which are the ones that you are probably most familiar with, mortality rates, hospitalization data. We are also reviewing existing assessments and primary data collected for the purpose of those assessments. There's identified gaps and needs that we will be addressing through the development of a plan, and these will be under the existing 7 statewide goals that are currently in alignment with the funding streams that are approved through those settlement dollars. So we have data for over 30 indicators, and this is a continuation of much of the data that was presented in the initial assessment that was conducted. We will have primary data from our Nevada residents that we've collected through key informant interviews, focus groups, and a community survey that is currently open. And I'll go into more detail about those in a few slides. Our estimated timeline here, this gives you what we already accomplished through the fall of 25 and winter of 26. And we will be developing written portions of the assessment in a digestible format. And then we will be working with FRN, Surge, CASAT, and other entities to help prioritize the areas of needs that align under those 7 goals to develop a plan by the end of this calendar year. So our key informant interviews were allotted 60 minutes. These were one-on-one conversations. We conducted these with persons with lived and living experience. So this included persons who are unhoused and utilizing multiple substances, as well as people who have been in recovery for several years. Spoke with 75 people across the state. Our goal was to hear from populations that represented all 17 counties, and we succeeded in every county except for one. We had at least 2 or more representatives in any of these groups that we spoke with. We also connected with county leadership. This included healthcare providers, court systems, law enforcement, juvenile probation.
health and human services, social services, and people who worked in substance use or who do work in substance use prevention coalitions. And we conducted 80 interviews with the various community leadership, again, throughout the state. And then we conducted focus groups with people who identify as friends or family who have loved ones with who have had or have opioid use disorder. And we were able to communicate or connect with 19 total participants throughout those focus groups. As of this morning, I did check, we actually have 269 responses to our survey, and this allows for another mechanism for anybody in our state who is a Nevada resident and over the age of 18 to help prioritize areas that fall in alignment under the 7 goals that are currently identified here in Nevada under our current opioid assessment and plan. These evidence-based practices and community-based participatory research is a model that is required by NRS 433, and it will also include a crosswalk and prioritization of those primary and secondary data so that we don't have to use subjective measures to determine which of these areas are seeing a greater need. There are established mechanisms to do so, and so we will walk our FRN members through or ACRN members rather through these processes to get us to these places to help identify these priorities. I'm not going to read all the organizations that identify that as a best practice, but you can see it is not just limited here nationally, but is also internationally recognized as best practice. The additions to the previous assessment is that we are gathering data directly from Nevada residents. The voice of Nevada residents was largely missing from our last assessment iteration. We just want to make sure that we are hearing from all the various touch points that anyone's lives can be impacted by opioid use. And our data collection protocols have been shared with county leadership and appointed entities, and we have also worked with a couple different counties already on their county level opioid assessment and have helped by collecting data, sharing those analysis with them, and will continue to help working with counties. They are on different cadences, so they do not necessarily follow the same 4-year timeline. They are required, if they would like to apply for opioid funding through the statewide opportunities, to conduct their own assessment each 4 years, but they might be on different timelines and cadences. We will continue to align with those 7 existing goals, as I stated earlier, with a hope to narrow down about 3 to 5 topic areas within each of those goals, because as we know and we've heard today, the needs are plentiful, but the resources are not. And so we just want to make sure that we are targeting where we can most effectively through the next 4-year cycle. And our overall aim, of course, is to prevent and reduce substance use and related loss of life that's specific to opioids, but including polysubstance use. And some of our next steps and asks that we have communicated to our partners, including Fund for Resilient Nevada, the SURGE, so statewide, this is a substance use response group, and CASAT with the University of Nevada, Reno. They've all assisted us by providing feedback related to the processes, helping to recruit for those primary data collection, and they've shared survey links or provided contacts for us to reach out to and engage with. They've encouraged county leadership to connect and communicate with us through those key informant interviews and helping increase the overall awareness for this updated assessment and plan. We really want to make sure that that our priorities and planning and other organizations' planning documents are available so that we are not duplicating efforts without being complementary. We might identify similar priorities that need to be addressed, but we want to make sure that we are not doing something that has already been done, and that we identify the other champions in the state and across the state and local governments that are working towards those same goals so that we can work together to achieve what we believe are priorities at the end of this process.
Dawn Yowie for the record. Will you turn off? And that kind of moves us into our annual report. So part of our NRS requires the Fund for Resilient Nevada to submit an annual report by January 31st. So not only are we fulfilling our needs assessment and statewide plan this year, every year we do have to submit an annual report. The layout of the report, you'll see an introduction, statewide funding priorities, findings from some of the data collection that we've done, funded programs and progress reports, recommendations, as well as expenditures. The statewide, oh, you're too far. The statewide funding priorities that Heather kind of touched on are our 7 goals, which are to ensure local programs have the capacity to implement recommendations effectively and sustainably, prevent the misuse of opioids, reduce harm related to opioid use, provide behavioral health treatment, implement recovery communities across Nevada, provide consistent opioid prevention and treatment across criminal justice and public safety systems, as well as ensure high-quality data and accessible, timely reporting. Some of the findings from this last report, unfortunately, are overdose deaths and opioid involvement continue to increase from 2023 to 2024. There is some provisional data on this slide for you. 792 deaths, which is about 63%, did involve opioids. Growth rate for synthetic opioids has slowed. The HIDA does continue to identify fentanyl as a high threat due to the widespread of availability and low cost. However, deaths related to synthetic opioids, including fentanyl, only increased by 7% from 23 to 24. Opioids continue to pose a disproportionate risk for families and children involved in the child welfare system. And methamphetamine, cocaine, and heroin remain high threat substances as well. Some of our funded programs and progress reports, they were funded initiatives were organized by region throughout the report, so you'll see it by northern, rural, southern, as well as statewide. Each subsection summarizes progress towards opioid abatement goals, services, the reach area, and any sort of measurable outcomes. We did highlight a few programs, such as Living Free Health, which is treatment and housing program. They are in Pahrump, which is one of our rural counties. They've been able to serve 11 unique clients, delivering 735 bed days through November. 100% of the clients received individualized treatment plans and engaged in regular group or treatment or individual treatment. And they've had 4 successful completions and 64% of participants stepping down to a lower level of care, with multiple clients successfully reunifying with children or transitioning into independent living. Our second highlighted program is University of Nevada, Las Vegas for their wastewater detection program. This is a partnership between Southern Nevada Water Authority, the Southern Nevada Health District, UNLV Center for Water Intelligence and Community Health, and the University of Nevada, Reno. They've built an integrated wastewater monitoring program to detect opioids and other high-risk substances among youth and transitional age youth on college campuses in Southern Nevada. Monitoring of individual residence halls has revealed consistent detection of methadone and its metabolite. Cocaine and related metabolites were also elevated in the same housing units. Results are shared with the local health departments, the city mobile crisis intervention teams, and the university student wellness team, creating a direct pipeline from wastewater signal to student-facing public health response. A new dashboard is currently being developed to be able to monitor this, and new efforts are also being developed to deploy monitoring of additional substances such as xylazine, and no detections currently are from dormitories at this point. And then we have Raise the Future, which is our third highlighted program. They provide, if it's in today, because they provide permanency outcomes for youth in foster care. The program delivered specialized permanency services to 183 children, including 96 youth with documented parental or environmental exposure to substance or opioids. 9 youth connections advocates secured 45 permanency matches and achieved 27 finalized adoptions, guardianships, or reunifications. Recruiters implemented a full continuum of permanency-focused activities, including diligent searches, reaching an average of 97 youth per month. They have identified 800 potential adoptive resources monthly and initiated contact with an average of 71 new prospective families each month. The recommendations in the report are to maintain and or decrease funding efforts at this time as programs are able to become sustainable. Complete program evaluations to make sure we are continuing to fund projects and programs that are leading to opioid abatement efforts. Complete our needs assessment as well as our statewide plan, which is due here in December, and then identify priorities with the ACRN and other partners for future funding. The final area you'll see in the report is an expenditures table, which is provided in accordance with NRS 3.4, we are changing the timeline of the report in order to, instead of capturing a calendar year for our programs, we will be capturing just the state fiscal year so that it aligns better with our expenditures. Any questions?
Thank you. First question, Senator Donyate.
Thank you, Madam Chair, and thank you, Director, for your presentation. I purposely waited after this presentation because I think my question is probably relevant to both of the funds. I think the struggle that I have oftentimes, so I served on Surge for several months, a year, 2 years, who knows. And I think the struggle that we always had with Surge was that you had two different committees. You had Acorn and you had Surge, right? One developed the ideas but never funded it. The other one wanted to create the ideas but never delivered onto it. And so you had this level of bifurcation system. And I remember asking last year, at least in Senate HHS, is have we created more bureaucracy and complexity to what all of this means? I'm looking at the funded programs for the Fund for Healthy Nevada, and to me, just taking a look at it, I think the rationality as to why we're finding ourselves into this fiscal crux is because a lot of these programs should have been built into the general fund or deployed through our health districts, and instead your office has been supplementing them. And so I think the challenge that we need to face, and I'm just saying this as more of an ask that you perhaps can help lead on this, is we've talked a lot about today about deficiencies with how human services is delivered through the state, whether technology is not being implemented or standardization and so forth. And that to me means that there are plenty of dollars that we could do to implement, to capture currently what we already have budgeted, and on top of that, capture more federal dollars. And so I think it would be, I would be remiss if I asked your office to start to think more holistically in terms of how these funds are administered, because while we do have the fund, the tobacco settlement dollars, we have the opioid settlement dollars, we have potentially youth vaping dollars that California and New York are already obtaining. We have social media dollars, settlement dollars that are coming. And I think we're developing these fragmented systems when in reality, it's the social and mental health system deficiencies that are causing all of this. And so I think if we, we can talk offline on what that would take, but I think we need to start looking at how we maximize all these funds together and start looking at healthcare economic development and actual large-scale projects that could move the needle on healthcare versus these kind of plug-and-play hodgepodge projects that I think have been occurring over the last few years. So I don't know if that's a recommendation that you have seen internally, but I would hope that your department can probably help us with that between now and next year.
Laura Rich for the record. Senator Donyate, you are speaking my language. We are having those conversations internally. We are looking at things a little bit differently than how it's been done. And so there's a very long laundry list of things that we're looking to tackle in the next biennium. So yes, I would love to talk offline and maybe, pick your brain on this.
Thank you. Members, any other questions? Okay, seeing none, I'm going to say thank you so much for being here all day and your presentation. With that, we will move to the next agenda item. Agenda item 8, the report on the proposal to establish a program to reinvest money obtained through the enhanced federal match for the provision of healthcare and public health services pursuant to Senate Bill 312. We will welcome our presenters to the table. Thank you so much for being here up in Carson City. I believe we have Ms. Flores Rosales. Sorry if I did not say your name appropriately. Ms. Carissa Pierce, and it looks like Ms. Jensen is joining us. So thank you all. You may begin whenever you're ready.
Thank you, Madam Chair, committee members, Ann Jensen for the record. I'm the Medicaid Director here in Nevada, and I'm really excited to turn it over to my colleagues Nahivy and Carissa, who will be sharing more about a really comprehensive and thoughtful report they've prepared for this body regarding a proposal on reinvesting funds for tribal health initiatives. So with that, I'll turn it over to them. We're going to go quickly through a lot of detail, and so if you have any questions, we're happy to answer that at the conclusion. Thank you.
Good afternoon, Chair and members of the committee. My name is Nahivi Flores-Rosiles for the record, and I serve as the Tribal and Community Liaison for the Nevada Health Authority within the Director's Office.
And good afternoon, Chair and members of the committee. My name is Carissa Pierce, and I am a Tribal Liaison with Nevada Medicaid. And today we are presenting on the Tribal Federal Medical Assistance Percentage, or FMAP, reinvestment proposal as required under Senate Bill 312 from the 2025 legislative session.
So the purpose of this presentation is to provide the legislature with an overview of how Nevada can reinvest Medicaid dollars to strengthen tribal health systems and improve health outcomes for American Indian and Alaska Native communities across the state. Senate Bill 312 directs the Nevada Health Authority to work closely with the newly established Tribal Health Authority Council to develop a tribal FMAP reinvestment plan. This plan must be submitted to you all by today, June 30th, 2026. When tribal or Indian health service facilities provide or coordinate care for American Indian and Alaska Native Medicaid members, each state has the ability to receive a 100% federal match. Okay, thank you. This is due to a trust responsibility between the federal government and tribal governments to provide health services to American Indian and Alaska Native, the Alaska Native population. The intention of this proposal is to shift funds obtained from this enhanced match into an FMAP reinvestment account that can be used to support tribal health priorities, such as care coordination, infrastructure, and expanded services. Nevada is home to 28 federally recognized tribes, bands, and communities, and 16 tribal health clinics, which includes the Indian Health Service, or IHS-operated clinics, that are enrolled Medicaid providers. Senate Bill 312 created the Tribal Health Authority Council, or the THAC, which will consist primarily of tribal health directors. Their role is to advise the state on tribal health needs and guide the reinvestment plan. While the Tribal Health Authority Council is being stood up, Nevada Health Authority has worked directly with tribal health directors to make sure tribal voices are at the center of this proposal. Strong government-to-government relationships are the foundation for successful implementation of the plan. American Indian and Alaska Native communities face some of the most significant health disparities in the nation. Chronic disease, suicide, liver disease, and certain cancers all occur at higher rates in tribal communities. At the same time, Nevada faces serious provider shortages, especially in primary care, mental health, and specialty services. Tribal and IHS facilities operate with chronic funding gaps. This reinvestment plan is one way to address these disparities by leveraging federal Medicaid policy that already exists and is available to states. A key tool in this process is the Care Coordination Agreement, or CCAs, between tribal health clinics and non-tribal providers. Under a care coordination agreement, a tribal provider refers a patient for specialty care to a non-tribal provider. A non-tribal provider delivers the service under the agreement and shares results back with the tribal provider. Because the care is coordinated through the tribal health clinic, this service qualifies for a 100% federal match. This increases access to care for tribal members and eliminates state general fund costs for those services. So here, this slide shows the standard billing processes without a care coordination agreement in place for both the tribal health clinic and non-tribal specialty health providers. Tribal health clinics are reimbursed at the all-inclusive rate, which is drawn down at 100% FMAP, meaning it is entirely paid by the federal government and is passed through Nevada Medicaid. Tribal health clinics can refer patients to non-tribal providers for specialty services, and non-tribal providers often do see American Indian and Alaska Native patients even without a referral. In these instances, the non-tribal provider delivers the service to the patient and bills Nevada Medicaid directly, and then is reimbursed at their standard fee-for-service rate for their provider type. This typically has a state share cost that ranges from anywhere from 10 to 40%, depending on the eligibility group. This slide shows the current billing process when a care coordination agreement has been established between a tribal and a non-tribal provider. When a care coordination agreement is established, the tribal health clinic agrees to send their patients to a non-tribal specialist provider at a contracted rate that is paid by the tribal health clinic. Since the service is provided through the care coordination agreement, it qualifies as being received through the tribal health clinic, which allows the state to draw down the 100% FMAP. This results in a no state cost for the service and ensures access to specialty care for the patient. This also creates the opportunity for reinvestment. I'll now pass it over to Carissa to share how the reinvestment program would fit in the current billing processes.
Thank you, Nahivi. This is Carissa Pierce for the record. So under the proposed FMAP reinvestment program model, the billing process stays mostly the same as the process for billing with a care coordination agreement. The non-tribal specialist provider bills the tribal health clinic. The tribal health clinic bills Medicaid. Medicaid pays the tribal health clinic at the all-inclusive rate, and the federal government covers 100%. The difference is that the reinvestment program captures any state dollars that would have normally been spent on that non-tribal specialist provider through the fee-for-service rate and redirects these funds into the reinvestment account. These reinvested dollars are only captured and redirected when a service is provided under a care coordination agreement, which has the potential to create a sustainable funding stream to support tribal health initiatives. These reinvested dollars could support critical tribal health needs through targeted initiatives that would be identified by the Tribal Health Authority Council. Non-tribal Medicaid providers can also benefit from establishing care coordination agreements with the tribal health clinics because they have the potential to negotiate higher payment rates than the standard Medicaid fee-for-service rates. So this can incentivize non-tribal provider participation, which ultimately increases access and continuity of healthcare for the American Indian Alaska Native population. In state fiscal year 2025, 7,873 tribal Medicaid members received over 156,000 services from non-tribal Medicaid providers. If all of these services were provided under established care coordination agreements, Nevada could save more than $9.3 million in state general fund annually. This represents the pool of potential dollars that are available for reinvestment. But in order to unlock these funds, tribal health clinics need care coordination agreements in place with non-tribal specialty providers, and the reinvestment account must be established in statute. As part of this report and presentation, we have put together 5 key recommendations to support the next steps for this program. The first recommendation is for continued consultation with tribal leadership, tribal health directors, and the Tribal Health Authority Council to design the program. The second recommendation is to authorize the Nevada Health Authority to administer and oversee the reinvestment account as the state Medicaid agency. The third recommendation is to establish a ramp-up period to expand care coordination agreements statewide between tribal health clinics and the non-tribal specialty health providers. The fourth recommendation is to ensure that state administrative costs are supported first through a state allocation of reinvestment funds, and that any additional reinvestment dollars allocated to the state should remain with the Nevada Health Authority to support priority initiatives. And the fifth recommendation is to require an annual report to be published that can track the progress and outcomes of the reinvestment program. We thank you for your time and consideration. This proposal offers a meaningful opportunity to strengthen tribal health systems. After this slide is the appendix where we have included more resources from the report that was submitted to the Legislative Council Bureau that had helped to inform this proposal. And we are happy to take any questions at this time.
Thank you. Thanks for your presentation. Our first question, Senator Danyate.
Thank you, Madam Chair. I apologize. I don't want to belabor. I know we're kind of getting late on this. I think your appendix makes a recommendation for funding mechanisms. I like option C. That's the one that has an administrative cost funded first through the reinvestment. Contrary to a lot of the presentations that we've heard, this is a good one because it actually shows that we can capture more dollars back to the state. I guess my question is, it's my understanding that when we passed Senate Bill 312 last session that we allowed the council to have 2 bill draft requests. So I don't know if your department is working with the council or the Tribal Health Authority, or what the process would be to engage with them to get this placed as one of the bill drafts, but I just wanted to put that out there. I don't know on the back end from the administrative side on who's coordinating with them.
Madam Chair, committee members, Ann Jensen for the record. Thank you for the question and for that input, Senator Dinate, on option C. We also like that approach to really ensure this is a sustainable program. My colleagues have been working very closely with the department that's setting up the Tribal Health Authority Council, and it's those conversations are very active. As recently as last week, they were meeting to discuss this proposal. So I do believe that they will have all of the resources they need to make a decision if they'd like to carry forward this proposal as one of their BDRs, and again, really support their autonomy and authority to do so. I hope that's helpful.
Thank you. I would just ask that if you can, please keep us informed as to the direction that they're going to choose to go, as we do have a robust list of policy priorities that will come from this committee. Members, any other questions? Okay, thank you. Thank you so much for being here with us all day. We appreciate you. With that, we will close this agenda item and move to our next agenda item 9. Thank you so much for being here today. A presentation on recommendations to address healthcare workforce shortages. We will welcome Dr. Packham, Co-Director, Nevada Health Workforce Research Center at UNR. You may begin, sir, whenever you're ready.
Just 1 second here. I see every presentation but mine. Oh. Oh, there it is. Oh. My bad.
I just want to make sure we accept. Yep.
All right, good to go. All right, for the record, my name is John Packham. I'm Associate Dean in the Office of Statewide Initiatives at the University of Nevada, Reno School of Medicine. I'm also co-director of the Nevada Health Workforce Research Center, and I'm pleased to speak just a bit on policy considerations and recommendations for the upcoming legislative session. Davis informs me that this committee is so familiar with our research on shortages and workforce gaps, I can just skip straight to the policy recommendations. Is that correct? You owe me a beer, Davis. I'll save that presentation for another day. When I think about policy recommendations and solutions to address workforce shortages and gaps in this state and elsewhere, I like to put them into 3 buckets. For simplicity's sake, and I'll give some illustrations of recent legislation quickly, as well as some suggestions for the upcoming session. As I go through these, I want you to keep in the back of your mind that between now and the beginning of the session, and certainly during the session, I am happy to speak to any of these. I truly view these as evidence-based. Other states have implemented some of what I'm going to speak to. And Nevada has, to their credit, implemented some of what I'm going to illustrate and discuss today. But there is a strong evidence base. We know what moves the needle. I've been reminded 14 times this is a policy, not a money committee, but some of these come with an obvious price tag, which begs the question of revenue, which I will touch upon as well. I like to throw policy measures into 3 buckets. The first, and there's no substitute for grow your own strategies to increase the number and diversity of program graduates. Full disclosure, I work for a public higher education institution. I think that that's where we move the needle. You make those programs available, you make them affordable, you provide scholarship support, you tie the bow on the package with loan repayment at the end, and that is the best way to grow and keep those in the state. The second bucket is measures that I call stretching the existing healthcare workforce. That is to say, measures without producing one more doc, one more RN. We make the most out of the available workforce. And there's a lot of strategies here. Incentivizing and promoting and policy measures that allow individuals to practice at the top of their licensure and scope. of practice. There's technological measures such as telemedicine, Project Echo, which I can speak to another day and so forth. I think artificial intelligence, I'm a little bullish on artificial intelligence being an example of something, at least in the short run, is going to augment the existing workforce again without producing one more health professional. We can make the most in effectiveness of our workforce. The last bucket is kind of an amalgam of different measures that focus on what we can do to attract, retain, recruit, and keep folks from the other U.S. states, and in some instances from other countries to practice in the state. I'm going to quickly roll through just a couple of illustrations of these three buckets. In the last legislative session and in the special session, here's an example of a couple of measures that I think are going to move the needle on growing our own workforces. I'd love to see these baked into the governor's budget permanently, maybe doubled. And I think a case could be made for more money in GME and more money in nursing. SB 5 in the special session. I think this is going to be one to really watch because there's a lot to like in that bill. It's targeted. It asks applicants to provide state match with that so that they have skin in the game. It also has some pretty, evaluation and outcome that has some teeth in it. If you want money from us in the future, you're going to have to prove that you spent it well with the dollars appropriated in this program. So there's some examples of grow your own. In the second bucket, there weren't a lot of measures in the last session, to be honest, that stretched the existing workforce. But I've highlighted a couple of examples here, including a telemedicine measure sponsored by Assemblyman Koenig with respect to optometry. Also, some measures that extend what EMS providers and EMS techs can do. I think a really interesting one, near and dear to me, with an 87-year-old mom with an army of caregivers around her, is thinking about Medicaid reimbursement for those caregivers. One of the dirty little secrets of healthcare in this country is the amount of care provided by friends and family members. Shouldn't all be compensated. We can do that out of love of our parents and relatives and so forth, but it is work. Make no mistake, it is work. And then finally, a wide range of measures dealing with attracting, recruiting, and retaining health workers, including SB 124, sponsored by Senator Donyate. I think that goes into effect in about 8.5 hours. So that's right around the corner. But a good example of a measure of we have trained health professionals right here in our community. Nevada actually has one of the highest percentages of docs, licensed docs, who receive their undergraduate medical education in training in another country. Let's make use of those that exist here. I also want to point out all of the compacts that didn't pass in the session. I've listed those that did pass in the previous session. I'll come to the nursing compact. I can't help myself. We'll do that. And then the legislature's attention to loan repayment. What I like about this is that the legislature is not only looking at throwing more dollars into student loan repayment, but they're also rethinking who's eligible for those at the end of the day. And I have an idea or two to share with you there. Again, policy committee, not a money committee, but we think about those three buckets. I would argue that going from that third bucket to the second to the first, you're going to have your greatest impact, but it's also going to come with a price tag. Not always, but it's going to have the greatest impact. You get what you pay for, and conversely, you don't. So with thinking about the 2020 session, I'm going to offer a couple of considerations in each one of those three buckets. The first would be to extend and increase investments and grow your own. I work in a medical school, and so I'm a little more familiar with what's happening in that particular space. But I think there are game-changing dollars now in graduate medical education. We produce a lot of MDs and DOs that go on to do their residency and fellowship training in another state. They buy a house, they fall in love, they leave the state, and they never come back. We can't. We've got to do it differently, and I think we can. And the most recent round of investments, I'm confident, will be game changers. Up north, we're going to use some of those GME state dollars to roll out a surgical residency program. And that's going to have a lot of positive effects up north. And no small, we're going to produce more surgeons and hopefully fellowship programs to follow that. But it also allows us and our affiliation partner, Renown Health, to finally explore creating a level 1 trauma center up north. I would also add that in this first bucket, we need to pay attention to workforce pipeline programs, and that is getting kids interested early and often, as early as middle school, but certainly in high school in health careers. I've got some bookmarks with a QR code in back for a career manual that my office has produced for the last 20 years, 50,000 copies, 8th edition. And it's as simple as a single page devoted to about 75 occupations, how much they pay, what your employment prospects are like, where you can go to get trained in Nevada. The third bullet there is, again, we can't be talking about any of this without thinking about and exploring new sources of revenue. I don't think there's bipartisan consensus on whether we need new revenue. So I won't pretend that there's bipartisan consensus on how we would obtain that revenue. But I'm going to give a couple of examples, though, that I think are instructive. The state of New Mexico, in their most recent legislative session, appropriated $25 million to loan repayment. They appropriated almost $600 million, that's $600 million for basically to create a new medical school. Now they have a state income tax. Packham's not proposing a state income tax, but I will argue that the revenue available to state lawmakers in state like New Mexico means that they have a different level of again moving the needle on workforce shortages in their state that mirror a lot of what's taking place in Nevada. In that second bucket, I would like to propose that we again think about what we can do as a state to increase the utilization of non-physicians, not just advanced practice clinicians, but everyone, the gamut of those in the workforce. I had an example there and I've already forgotten what I was going to put in there, but I spoke with a colleague in San Diego earlier this week, and he's working with academic institutions in that corner of California to utilize former cancer patients and survivors of cancer, if you will, to serve as patient navigators for individuals, figuring out the management and treatment of cancer. That's not creating another health worker in the state, but it is making the most of what is available in a community. Again, there's other examples. I think you're going to see a bill looking at expanding the scope of practice for both physician assistants and pharmacists. I can hear my medical school colleagues fuming and the steam coming out of their ears already, but again, expanded scope at a minimum, increasing the ability of to stretch that workforce again is where I was going with that. On to the third bucket. As I noted earlier, there can't be enough dollars in loan repayment. The Rural Health Transformation Program has provided unprecedented level of dollars available to the state of Nevada. Really disappointed that Dr. Oz concluded that we can't use any of those for loan repayment. I think that's a mistake I'm happy to discuss over beers at the airport, but I think it's a missed opportunity because speaking from someone whose office has overseen a loan repayment program for the last 30 years, it is the best retention tool that I would argue that we have in the state. I spoke with a hospital administrator in Ely recently, and he told me that our program has supported loan repayment, not just for physicians, nurses, a couple of pharmacists, other techs in the building. They supported 20 individuals, 19 remained in the community to practice, complete their careers, set up homes and so forth in that community. And I don't see quite that retention rate in every community, but I can't think of a better mechanism. One new thing that I'd like for you to be thinking about going into the next session is applying that same logic to faculty loan repayment. One of the biggest impediments to our nursing shortage is the fact that you need clinically trained program faculty that make a fraction of what you can make as a bedside nurse or someone providing clinical care out in the community. And I'd love to see some novel thinking on loan repayment for not just nursing program, but other health professions, social work, medicine, and so forth. Finally, we need to revisit our state's participation or lack of participation in licensure compacts. In and of themselves, they're not going to end a shortage, but they're part of the solutions and strategies that we need to be looking at as a state. Once again, we're going to have someone introduce a nurse licensure compact bill. The opposition will come out. Maybe it won't even be introduced. Didn't even get a committee hearing last time. But we'll be the 49th state. California will always be the last to pass it. But nursing, dentistry, PA compacts, again, hopefully will be on the table. I've got a couple of other considerations I would throw in there. One of the things that's a little disappointing, I review federal grants from time to time, and I'm always bummed to see that there's no Nevada applicants on just one after another. I'm not sure what we can do to address that, but those dollars are still out there. There's been a flurry of HRSA grants and SAMHSA grants that have dropped in the last week or so. I'm hoping that we can think about how to take advantage of those programs. The rural residency program in Winnemucca that's being overseen by UNLV, the very new one in Fallon overseen by UNR School of Medicine. Both of those were started with HRSA rural residency planning and development grants. Tiny bits of money that got us over the hump with respect to planning. Also mentioned the Nevada Nursing Workforce Center being spearheaded by Orvis School of Nursing and colleagues down south. And then finally, because I'm a data nerd, we need to continue to support efforts to improve health workforce data collection analysis, including efforts of the Division of Public and Behavioral Health's Health Workforce Working Group. Apologies if you've seen this metaphor before, but I'm going to close with a Chinese proverb that crystallizes my views on health workforce development, and that is, Nevada, we've often been late to the game when it comes to workforce development. It was 1980 before we graduated our first medical class from a public institution in Nevada. 1956 before Orvis was kind of the last state to do a public nursing program, 1956. Public School of Dentistry, 2002. On and on and on. We've been kind of late to the game. But again, this Chinese proverb is the best time to plant a tree was 20 years ago. The second best time is today. And so I leave you with that. And again, motored through that rather quickly. But I'm hoping that, again, between now and the beginning of the session, and of course during the session, please don't hesitate to reach out if our office can provide assistance in illuminating some of these issues.
Thank you, Dr. Packham. We are grateful for that 17 minutes.
And 17 minutes, I almost did it.
Very good, you did great, thank you.
Toastmasters teaches you to do it in 3 minutes or 15, either way. So.
15 works, thank you. Members' questions? Yes, Senator or Assemblymember Edgeworth.
Thank you, Chair. I've been promoted. Thank you, Dr. Peckham, so much for being here, for being a data nerd. I love that. Data speaks volumes. And this is something I'm really passionate about. As somebody who trained here 20 years ago, I was one of 3 internal medicine residencies, and we have come a long way. It's hard to see it if you weren't there. So we have come a long way. We didn't have fellowships. We had, very few residencies. So I think we have come a long way. And then I have spent my career training the next generation of people who are going to be taking care of me when I get sick. So I'm highly encouraged that every single one of the presentations we had here today all talked about workforce development. So I'm glad it's on the front burner. That makes me really happy. So thank you. This is my question, which you may not have an answer for, and I don't mean to hit you out of nowhere, but I've had some feedback from constituents, and I attended an academic summit yesterday with a lot of different teaching institutions in the city. There's some feedback from new nurses, new graduates. I think we are growing our own and greatly expanding the nurses that are being trained, but there seems to be a real limit on how many new nurses are being hired by hospitals. And I didn't hear a lot of solutions, and I'm not even sure what the solution would be, but do you have any thoughts on that?
Well, I think the hospitals always want more experienced nurses. I mean, it's a chicken and egg problem that you have with that. And that is, how do you gain experience other than working and beginning a career in a hospital? I also think those new nurses are seeing much more acuity in patient settings. A lot of patients are treated in outpatient, growing proportion in outpatient settings. So they're seeing more acute patients. And so forth, but I think there's strategies to address that. There's programs. I'm not sure what the technical term is. They're almost like nursing residency programs where you get. You always get clinical training in hospital settings as part of a baccalaureate degree or an associate degree, for that matter, in nursing, but. It's just got to mean more experience in those settings than they're currently getting. I don't have a great answer to that. So,
thank you. Tiny follow-up. I would love to talk to you about this because I think that I've even spoken to the hospitals, and the hospitals recognize that they're having far more applicants than they're able to hire. And my feedback I'm hearing is that brand new nurses are literally leaving the state because they can't get jobs in hospitals and locally. And I do think that that's a little bit of a barrier to the incredible shortage we have of nurses. So I would love to talk to you about that later.
And I would just dispel, we still have a shortage. I'm a little frustrated when I hear claims that we don't have a shortage. And trust me, there are hospitals all over the country, certainly in California, that will hire them tomorrow.
Thank you. Members, any other questions? Okay. Seeing none, thank you.
Dr. Titus would have had a question for me if she was there.
Yes, she would have, yes. Thank you for being here. Okay, that leads us to the last item on our agenda, item 10, overview of the Nevada Rare Disease Advisory Council and latest needs assessment. We have our presenter on Zoom, Annette Logan Parker, the chair of the Nevada Rare Disease Advisory Council.
Thank you. Good afternoon, Chair and members of the committee. Thank you for the opportunity to speak with you today. For the record, my name is Annette Logan Parker, and that's Logan-Parker, sorry, and I serve as the chair of the Nevada Rare Disease Advisory Council. The report submitted in advance of today's meeting is a summary of the work the council has already presented publicly through our meetings, annual reports, needs assessment updates. So for the sake of time, rather than talking through that report section by section, I'd simply like to provide some context about where we've been, where we are today, and where our work with the RDAC is headed next. When the legislature created the council in 2019, Nevada simply didn't have the tools to fully understand the needs of people living with rare diseases. We didn't have a statewide registry. We didn't have a clear understanding of the Nevada specific patient or provider rare disease experience, nor the data to validate its prevalence in the state. We didn't have a coordinated picture of where families were struggling and where providers needed support, specifically when caring for patients and families with rare diseases. Over the past 6 years, that's exactly what we've been building. Today, the picture looks very different. Working alongside the Nevada Department of Health and Human Services, the Nevada Health Authority, Nevada Medicaid, the Office of State Epidemiology, the Nevada State Board of Medical Examiners, healthcare providers, et cetera, et cetera. The council has made substantial progress on 11 of our 12 statutory responsibilities. Together, we have established Nevada's first rare disease registry, which now includes more than 4,000 unique Nevadans living with a rare disease. We've completed 2.5 years of a structured 3-year statewide study on patient and provider needs focused exclusively on the rare disease experience. We've partnered with the Office of State Epidemiology to significantly expand Nevada's rare disease dashboard. We've supported 3 pieces of legislation that directly improve the rare disease landscape in Nevada. We've built strong partnerships across state government while being recognized by the National Organization for Rare Diseases as one of the country's leading rare disease advisory councils. And most importantly, because of this work, Nevada now has the preliminary information that it needed to make better decisions for families living with rare diseases and the providers who care for them. The reason I requested to be part of today's agenda is simple. The council is now entering what I believe is the most important phase of its work. One of the council's 12 statutory responsibilities has been the development of a comprehensive rare disease management plan. Everything that we've built over the past 6 years, the registry, the needs assessment, the provider surveys, the expanded dashboard, all the statewide partnerships, was designed to support such a plan. We're moving from building the tools to using them. And as many of you know, during the 2025 legislative session, the Nevada Rare Disease Advisory Council was included in the broader discussion surrounding board and commission consolidation as part of the state's government efficiency initiative. Ultimately, advisory boards were removed from that legislation and those discussions were deferred. We believe that they are expected to return in the 2027 session. We understand and support the goals of improving government efficiency and accountability. Our request is simply that the Nevada Rare Disease Advisory Council be evaluated on its own merits and recognized as being at a unique point in fulfilling the legislative mandate that was entrusted to us. Over the last 6 years, we've built the infrastructure the legislature has asked us to build. The remaining work, which is the comprehensive rare disease management plan, depends on all of those efforts. If the council were to be folded into a broader advisory body before this work is completed, our concern is not simply that Nevada would lose a council. Our concern is that rare disease would become one important issue among many. The specific and dedicated expertise, sustained focus, and momentum that have allowed us to make the progress could be diluted as attention shifts across a much broader set of public health priorities. Today, I simply respectfully ask for 3 things. First, please recognize the substantial progress the council has made in building the rare disease infrastructure Nevada did not previously have. Second, please support the council as we move from building that infrastructure to using it while we begin the process of making recommendations for a comprehensive rare disease management plan. And third, as future discussions about board and commission consolidations move forward, please recognize that rare disease requires dedicated and specific type of expertise, sustained focus, and a council whose sole responsibility is improving the lives of Nevadans living with rare diseases. 6 years ago, the legislature asked the RDAC to begin building something Nevada didn't have. And today that infrastructure exists. The data is being collected, the partnerships have been established, and we are asking for the opportunity to finish what we started. Please keep this in mind as you are asked to make incredibly important decisions in the upcoming session. Thank you, and I would be happy to answer any questions.
Thank you. Well, thank you for your presentation. We do have a question, Senator Lang.
Hi, thank you so much. I'm one of those 4,000 people that sit out here today. And I know that Congress right now is dealing with genetic testing for rare diseases, and we passed that bill here in Nevada. And Chair, I would ask that this committee would send a letter to Congress supporting genetic testing.
Thank you, Senator. Any other questions, members? Okay, seeing none. Thank you. Thank you for being here with us and waiting all day for your presentation. I have your documentation, as do the rest of the committee members, so we'll take your recommendations under consideration. Thank you so much.
Thank you. Bye-bye.
Okay, members, that leads us to public comment. Item 11. Thank you. We'll start with public comment for people who are in the physical location. So if you are in Las Vegas or Carson City and you want to offer public comment, please come forward and fill in the chairs. If you want to provide public comment through telephonic testimony, please dial 888-475-4499. And then when prompted, provide the meeting ID. Enter 857-1071-3988 and then press the pound sign when prompted. Remember to clearly state and spell your name for the record. You'll have 2 minutes to offer your public comment. We'll start here in Las Vegas. Go ahead.
Thank you, Chair. My name is Sabrina Petrel, Sabrina Petrel, and I'm so sorry to be here at the end of the meeting. I promise to be fast. I am here today on behalf of Foster Kinship, who spoke this morning. We want to thank DCFS, Washoe, and Clark County for its commitment to Nevada's children and families and for their partnership with Foster Kinship. As we talk about the need for more foster homes, though, I hope we also continue investing in kinship caregivers on the front end. When relatives and fictive kin are supported early, helped through licensing, and connected to resources, children can remain safely with family, and more kinship homes can become licensed foster homes. While we know not every child can be placed with kin, strengthening kinship care also helps preserve traditional foster homes for children who cannot be placed with relatives, including children with higher needs. As DCFS continues implementing the new kinship licensing standards and refining the updated licensing process in Clark and Washoe counties, Foster Kinship is here as a resource and a partner. We look forward to continuing working together to support kinship caregivers and strengthening the licensing process for families across Nevada. Thank you.
Thank you. Seeing no one else here in Las Vegas and no one at the table in Carson City, AVH, is there anyone on the telephone line who would like to offer public comment at this time?
Thank you, Chair. If you would like to provide public comment, please press *9 now to take your place in the queue.
Good afternoon, Chair Brown May and members of the committee. My name is Casey Melvin, CASEYMELVIN. I am an occupational therapist, a member of the Nevada Therapy Alliance, and CEO of Children's Therapy for Tots, a statewide multidisciplinary therapy provider. We serve children in their homes, daycare, schools, and communities across the state of Nevada. Thank you for your continued investment in Nevada's healthcare workforce and community-based care. Despite these efforts, critical shortages in therapies and behavioral health persist, leaving families waiting longer than ever for necessary care. I urge the committee to consider this. If Nevada successfully recruits healthcare providers, including through the $60 million invested in SHARP via Senate Bill 5, but those providers cannot join the largest insurance network serving our patients, we will not realize the full return on that investment. As Children's Advocacy Alliance highlighted, reports don't include all provider types, and networks often appear adequate on paper, while at the same time, families face long wait times and limited provider choices in reality due to contract limitations, including capitation agreements. While quality and network stewardship are vital, we must define sustainability together to prioritize timely access to care. Furthermore, as telehealth expands, provider availability should be evaluated by where services are delivered, not only the physical office locations. Workforce reports show we lack enough licensed professionals, and our goal should be maximizing, not restricting, the participation of qualified providers who are ready to serve. Thank you for your time and your commitment to improving access to care for Nevada's children and families. I appreciate you.
Good afternoon, Chair and members of the committee. My name is Deanna Yates. That's spelled DEANNAYATES. I'm speaking today on behalf of the Nevada Therapy Alliance. Several presenters today talked about the challenges Nevada families face in accessing health care. We especially like to thank the Children's Advocacy Alliance for shining a light on provider network participation and the barriers to care, because those issues directly affect the families we serve. In addition, we want to point out that centralized credentialing is not the issue. The real concern is that qualified providers and provider groups are often unable to join Nevada Medicaid fee-for-service or the MCOs because they are told the networks have enough providers, the provider panel is closed, or the plan uses a specific capitated provider. Nevada already has a shortage of many provider types, including behavioral health, occupational, physical, and speech therapists. When already limited provider networks become even smaller through closed or capitated panels, families lose the ability to choose another qualified provider that has availability. Instead, children are often evaluated, but then must wait extended time for treatment to begin, causing delays in medically necessary care, even though another qualified non-network provider has appointments available. As Nevada works to improve access to care, we should be giving families more choices and allowing more qualified providers to participate, not creating more barriers that make it harder to get medically necessary care. Thank you so much for your time and consideration.
Chair, your public line is open and working, but you have no more callers at this time.
Thank you, AVH. That concludes our public comment today. Members, our next meeting will be held on Tuesday, August 11th at 9 a.m. And thank you for your time and attention today in this very robust agenda. We are adjourned.